minutes per session. Bell will go off at 13 minutes, and we are request the chairpersons to control and ensure that we finish on time. So without delay, we start off with the first talk. Dr. Anvay Mule is no stranger to us. He will be joining us online, and may I request the link to be provided. Thank you.
Perfect. Now if you can get on to presenter mode. Yeah, that's right. Presenter mode. Yes, absolutely. We are putting you online live now. Thanks a lot, Nanda.
आता बंद कर ना माझा फोन याच्यावरती मी झूमवर आहे हेलो Can I start?
Hello.
Yes, sir, please start. Hello, can I start? Can you hear me?
Hello. Yes, yes.
Please start. Okay, good morning, everybody. So welcome to the first day of the Techno College CME of our Indian Association of Cardiothoracic Surgeons. On the onset, I thanks Dr. Goel, Dr. Shah, the chairperson of the organization committee, and whole organization committee for allowing me to participate in this program. I apologize for not able to be there because of the other commitments I already had. Personally, I cannot be there. So today my topic is sutureless aortic valve replacement and its benefits. The sutureless aortic valve concept was in 1960 by McGowan and he started this. If you can see these hooks here on the side of the star valve or a ball cage valve, the problem with that was it was a too bulky device, high rate of thromboembolism, paravalvular leak, and conduction problems. It was discontinued in 1980 after hundreds of patients they had implanted this valve. The Medtronic came out with the 3F enable sutureless aortic valve in 2005-6. It has excellent results and some good trials. However, it never hit the market as one would expect it to be. Then came the Edward intuitive rapid deployment valve system, and that bioprocess is still available. It is in the market. It is used in some continents and in countries. However, it has not come in India yet. So I don't have much experience and much know about it. So this is a delivery system of the rapid deployment valve. There are 3 stitches we have to take in this, where we can see this line marker, and these 3 stitches are tied in this valve. The Arbor trilogy is only on the papers, and I have not seen it anywhere or heard of this anywhere. So there are 2 valves which are available today in the market. One is Edward intuitive valve, but the Sorin Percival valve is in Europe and in Asia very used quite frequently by many centers, and we know the advantages, disadvantages, and the benefits and the problems or complications of it. So I would like to just give some tips and tricks for the sutureless Percival valve. It's a different concept, and so the deployment system is also a little different. So the valve is developed to combine the advantages of Sauer and TAVI. The first implantation, the very fast deployment, so the less cardiopulmonary bypass and ischemic time, the complete removal of the native valve along with the decalcification of the annulus, no need of surgery, and application in and it is applicable in the minimally invasive aortic valve replacement, where you don't have to tie the knot. You don't have to tie the knots. The TAVI pitfalls are calcific valve is pressed into the aortic sinuses. It is not so it is not tower actually. We don't replace the valve. We just implant another valve in a valve. No decalcification of annulus. More chances of paravalvular leak because of irregular annulus. Durability due to the crimping of the pericardium, and I will touch that point again for Percival in a few minutes. So advantages of sutureless valve: there is a complete and thorough removal of the diseased tissue. The speed and ease of insertion of the valve, so better effective orifice area and better clinical outcomes. Then who are the ideal candidates who will benefit from the Percival valve? The high-risk patients needing combined procedures like CABG, hostile aortic root, redos, re-redos, a small aortic annulus, and application in minimally invasive aortic valve replacement. Percival valve is mounted on a dedicated device, and the valve is only collapsed, not crimped. The diseased leaflets are removed, and annulus is completely decalcified. The precise level of implantation, which is under vision, and that avoids many problems. The better effective orifice area, technically simple in difficult and hostile aortic root, and less paravalvular leakage than TAVI. So there are some challenging cases in TAVI. The small peripheral or heavily calcified vessels, heavily diseased aorta, heavily calcific annulus. Patient is extremely symptomatic, and if the aortic annulus is less than 18 or more than 25, or if it is for self-expanding, you can do that. But for the balloon expandable valve, there is a limitation how much you can put it in the aortic position in TAVI. The presence of asymmetric, heavily calcific, and low-lying coronaries again is a contraindication for TAVI, where Percival can be used effectively. There are some contraindications. There are some absolute and some relative. Acute infective endocarditis, dilatation of the ascending aorta at the ST junction more than 4 cm, and that is important. Sinotubular to annulus ratio more than 1.3, that is very important. The bicuspid aortic valve with asymmetrical sinuses and multi-valve lesions like double valve replacement, they are relative contraindication. I have not done in double valve replacement because the mitral valve, when we insert, then the annulus of the aorta gets deformed a little bit, and then there is uneven expansion of this Percival valve. But some surgeons have done it. So it is a relative contraindication. The Percival and TAVI, if we look at the permanent pacemaker, paravalvular myocardial infarction and stroke mortality, the higher in TAVI group, significantly higher in TAVI group. But if you look at the standard stented bioprocesses, standard centered bioprocesses, the same parameters, statistically there is no difference. In conclusion of review of many articles, the rapid deployment valve is safe, reliable. It reduces the ischemic and cardiopulmonary bypass time. It has a shorter ICU and hospital stay and better effective orifice area and gradients. So there are certain tips which are like summarized for surgical deployment of sutureless valve. The aortotomy should be transverse. Proper sizing of the valve is crucial, very important. Do not oversize, do not undersize. The 3 guiding sutures at the nadir of each cusp for a better placement or the level of the valve, level where the valve will be implanted. Warm saline washes as soon as we open it up so that the Nitidot technology keep it expanded and in a position. The post dilatation of the balloon for 30 seconds at 4 atmospheric pressure. So aortotomy should be transverse. It should be 1 to 2 centimeter above the ST junction or at least 3.5 centimeter above the annulus. But from outside, for a surgeon, it is difficult to measure that. And so the best landmark, as you can see here, is this epicardial fat fold. Just a couple of millimeters above this is 2 centimeters above your ST junction. Normally. So incision need not be more than 4 to 5 centimeters in length because we have collapsed the valve while putting it, so we don't require a big aortotomy. The traction sutures at the commissure helps the aortic valve to come up and it keeps the aortotomy open, brings the annular plane upward towards the aortotomy and allows better access to the valve while excision and decalcification. Very careful and complete decalcification of the annulus is important. Thorough decalcification ensures radial, geometrical and even expansion of the inflow crown, and that is very important. The proper decalcification at commissures allows commissure strut expansion. The calcium extending into LVOT and IML, which is protruding in the lumen, should be excised, otherwise it changes the level at which the valve will be implanted. We should maintain the integrity of the annulus, especially aortomitral continuity, as if there is some, while decalcification, if there is some gap, then there is no cover which will protect from bleeding in the intramyocardially or outside the heart. Also the valve will not sit properly. So if there is a aortomitral discontinuity, then with interrupted 4 or 5 octolith, we can just take the stitches and make the aortomitral continuity, so see that aortomitral continuity remains intact. The severe LVOT obstruction, hypertrophy, also doesn't allow the proper enlargement of the inflow sites, where you can see here in a small, medium, large and extra large, it is 6 by, increased by 0.5, here it is increased by 1 centimeter. So it doesn't allow the inflow portion to expand properly, and that should, if there is a severe hypertrophy, then localized limited myomectomy will be helpful. Sizing of the Percival valve, it is expandable processes. It has a larger diameter than indicated in annular range. Remember that. So do not oversize. In Percival valve, correct sizing is extremely crucial. We have got this sizer where you can see here that there is a transparent end and there is an opaque end. The transparent end should pass, the opaque end should not pass. But if there is borderline things, then will come. So it will give the range. The smaller size pass means the annulus is at least 19, or in this medium size it is 21, 23 and 25. While it will be expanded, possibility of expanding till 27, 25, 23 and 21. So that takes care of itself. So Percival is designed with inbuilt oversize, anchoring, sealing and optimal valve performance. The white or the opaque sizer presents the upper limit of the given size. So each sizer represents the lower and upper limit of the valve. So this is a transparent which should be able to go here and it should not go here. It is important that how you measure it, how you size it, because it should be perpendicular to the annulus and in the axis of the annulus, not angled at the annulus or not in the axis of the LVOT, then this is a wrong measurement. This is the correct measurement, this is a wrong measurement. An oversized perceivable valve will not guarantee better hemodynamics. In borderline cases, when annulus is between two sides, very important, consider the overall sizing of the aortic valve. Divide ST junction diameter. So we know the STG calculation, we have done it on TE. Divide it by 1.3 and that is the smallest valve that you can implant it in that annulus. If it is a borderline, if both things are going and it is difficult to measure. So oversizing of the perceivable valve is 100. If it is the correct sizing, then the effective orifice area is 100%. If it is oversizing, there is enfolding, not complete expansion of the leaflets, and you get 94%. If it is extreme oversizing, it happens, then it is 80% of the effective orifice area will be available. The guiding sutures, there is no, this is sutureless one, but we have to take the 3 sutures at the nadir of each cusp. The correct placement is the key to correct positioning and orientation of the valve. Guiding suture should be at least at the lowest point of each cusp. It should be 2 to 3 millimeters below the leaflet hinge point and perpendicular to the annulus. And the 120-degree distribution can be confirmed by the transparent side of the side. You can use opaque also, but transparent is very easy and nice. So it is smaller size. So you can keep this each bar here at each commission, or you can make your own commission. For example, in bicuspid aortic. For example, in the redo cases, when you don't have the exact nadir, because it becomes a circle or it becomes an oval in bicuspid aortic. So if I keep the coronary ostia here and in this portion, then this is my commissure, this is my commissure, and this is my commissure. So in the center of these 3 here, if I take the suture, it automatically helps for coronary. The strut doesn't come in the way of the ostia, and the coronary blood flow is not impaired, and at the same time, the deployment will be uniform and even. So the role of guiding sutures, always put the on the right side. Because when I pass through the nadir here and come out from the LVOT, that LVOT suture should go through this eyelet. Remember that. So here it is, and then only when we do that, then the annulus, the collar of this valve, will sit supraannular. So at the correct level of deployment, the LVOT side should pass through the eyelet of the valve. Please remember this point. The role of guiding sutures, it is the guiding sutures are pulled firmly while lowering the valve with the similar and simultaneous tension. The close to the delivery system, they should be the 3 sutures to be pulled simultaneously with similar tension and close to the delivery system. They should not be away at a maximum angle. One is pulling one side, second one is pulling second side, third. That is not right. So it should be close to the. You can see here in this diagram. It should be close to the valve in the axis of the LVOT. Then the delivery goes down. So access the valve alignment in all the cusps. Maintain the axis of LVOT with the guiding sutures. Nadir of the non-coronary cusp is the lowest, so may have to tilt the delivery shaft little bit gently towards the surgeon. Rotate the knob on the top clockwise and until the clip that is inflow ring is now released. Avoid the rotational movement and keep the axial position of the aorta. Remove the smart clip and pull back the sliding sheath of the holder. That is the blue one. So outflow of the valve is released. Remove the holder gently. Inspect the valve, its position, whether it is fully expanded or there is enfolding due to the oversizing. And see the plane of coaptation of the leaflets. It should look at the Mercedes star sign. So the annulus is visible from the top, then valve is placed too low. The guiding sutures are visible from the top, it is too high. So remove the valve and you can re-implant it again by collapsing it. For removal of the perceivable valve, rinse with the cold water. Infold the valve with X movement with the forceps. From opposite side, infold the valve and then twist it and bring it out. It's a nitinol technology, so can be deformed and the same shape can be given again very fast. The ballooning of the valve seals the aortic annulus. Inflow level, balloons only act at the inflow level. No damage to the leaflets or to the stent. Stop LV vent to avoid negative suction of the LV when you inflate the balloon. Very important. They insert the deflated balloon inside at a blue marker level and then inflate it at 4 atmosphere for 30 seconds. And this time we must put a warm saline so the valve remains expanded in that position and hugs to the aortic annulus. The closure of an aortotomy is preferably single running suture than 2 layers. Care should be taken not to include the stent in the suture line. If CABG and vein grafts, then perform the aortic anastomosis of the clamped aorta to avoid the side effects of the aorta. The intraoperative imaging is important to confirm the position, deployment height, presence of carbon plate. The valve displacement in and infolding can be detected on immediately on. Short exit.
Can I request you to kindly wind up because we are just exceeding our time. Thank you.
Yeah, okay. So the take-away message is it is speedy, reliable, good for high risk and hostile aortic patients, reproducible in a variety of the situations. The word of caution I would like to state here is needs unconventional implantation technique which necessitates understanding of important technical nuances, and echocardiography assessment and the parameters are important. In our experience, we have done 52% were hostile aortic roots. One pregnancy patient who was bicuspid aortic valve and a doctor herself, 3 redo with 1 post-op CABG and AVR, 1 redo with valve in valve TAVI which got displaced, and we have to explant 2 valves and put a Percival valve. So there was no complications, no parallel, no pacemaker, no implantation, no restoration for bleeding, there no 30-day mortality. One patient had a PPI which was before operation and then it was malfunctioning post-operatively, and patient was luckily still on ventilator from 6 hours after the operation. So we had to massage them, but we took him to the operation with the in operation that to see the T and there is no displacement of the valve even after the massage. So mean gradient discharge was single digit, except in 6 patients it was 11. Our average follow-up is 36.5 months with the peak gradients is 11.1 plus or minus 5 after 36 months of follow-up. So it is a good valve, good effective orifice area, and no displacement. Thank you.
Thank you, Dr. Anvay Mule, for introducing the sutureless valve and the techniques. Now I request Dr. Anil Jain to present his talk on a polymer valve that he is investigating.
Morning everybody, and I thank the organizers for this opportunity to be here. Bhupesh and Gaurav, I'm really sorry that I could not contribute at all to helping you organize the meeting. I've been caught up with several small and big things in life. Good morning everybody, and a warm welcome to Ahmedabad. So we've all been, this is a valve session and we are all always looking at what is the ideal valve. Kenny, one side I can't see. So, search for the ideal heart valve I think is as difficult as the quest for the Holy Grail. Many types of valves have been evaluated, and we've seen that there are problems with mechanical valves, with tissue valves, and all the valves that we are at present using. So if you look at bioprosthetic, if you look at polymer valves, what is it that we would want them to do? They should have optimal hydrodynamic performance, they should be biocompatible, they should have low thrombogenicity, and they should have an application for tower. Any valve coming in has to have tower application, otherwise it is not possible for that valve to succeed commercially. And it should be low cost, and it should have widespread accessibility. The material, the polymer, should be such that it is resistant to the high dynamic loading of cardiac conditions. That is, we have got pressures that go right from 150 and come down to 0. So that's extremely high dynamic loading on the heart. It should be biostable and it should not need anticoagulation. And it should be biocompatible to human tissue, and it should have minimum reaction to the body immune system. And now many groups are investigating polymer valves. It's not that there's only one type of valve. These are the multiple types of valves that have been looked at, and in fact many companies are looking straight away at TAVI. They are not even looking at surgical valves. They are only looking at TAVI polymer valves. So these are the multiple types of valves that are coming up. All the valves are in different stages of development, but as of now, Foldex Tria is the only one that has come into human clinical trials. Triskel valve, that's another valve that's been evaluated in USA, and that has completed all the animal experiments, and it is likely to come up for human trials in 2023. So if there is a polymer valve, how will you evaluate it? You know, we know how we look at tissue valves, you know how we look at mechanical valves. What is the evaluation strategy for these valves? Polymer valve, see, plastic has invaded our life totally. It's there wherever we want and it's ready to invade the heart. So how are we testing polymer valves for human use? If we look at hydrodynamic performance, then to check the hydrodynamic performance, the effective orifice area must be more than 0.85 centimeters square. Gradient fraction should be less than 10%, and total regurgitant fraction should be less than 20% to be an ideal valve. As of today, both the Foldex and the Triskel valve satisfy these particular norms. Other valves are still being evaluated for this particular thing. Then, how do they evaluate the long-term durability? There is accelerated wear testing, that these valves are put in machines and they're continuously run over cycles. Because it's a polymer, we have to see whether the polymer will stay, it will degenerate, it will survive implant or not. So these are in vitro testing, and the minimum they have to go is 100 millimeter pressure gradient should be there, and that should be maintained for at least 5% of the cycle and 95% of all test cycles. A minimum number of cycles that needs to be completed is 200 million cycles of testing. So the valve can be approved for trials. Foldex valve has completed this, and Triskel is about to reach there. So hence Triskel will be there this year for human clinical trial. Then thrombogenicity and hemocompatibility. All the valves are compared with existing human implant valves, like it is compared either with mechanical valves or with Gore-Tex grafts or something like that, so that the valve has low thrombogenicity. So the comparison will be to existing implant material. So in that again, Foldex, Triskel, and in fact Polyvalve also are confirming to this. In fact, most of the valves are okay with thrombogenicity. The idea is once implanted into human into the patient, they should not need anticoagulation. That's the idea with the polymer valve. So no need for anticoagulation and lasting forever are the two properties required for any polymer valve to reach human use. Immune response, whether the plastic or the polymer generates any immune response. That's very important, because if there is an immune response and the plastic or polymer degenerates, then again the valve will have structural dysfunction. So most of the valves are found to have minimum immune response. We know plastic is a very inert material, and in general no calcification is seen on these leaflets. So basically there is no degeneration of these leaflets, no calcification of polymer leaflets. The other important thing that I said is all the valves should have a TAVR application, and most of them, that is the Polynova, Triskel, Foldex, are all self-expanding valves, and the others are balloon expandable, and most of these valves are as of now being tested for TAVR applications in the world. And the big problem that they are facing is the crimping, because see, once the polymer is crimped, it can get damaged. So that is the area where all the TAVR applications are stuck right now, and their idea is that whenever they crimp and they deploy, the polymer should not get damaged. If it gets damaged, then there will be structural deterioration of the valve. So that is right now the main concern. The concern of crimping during restriction restricts most of the TAVR devices. Also, the polymer has to be very thin to be able to be crimped into a small gauge so that it can be delivered through the femoral artery. So this is the basic idea about polymer valve. Tria valve is right now the first that has reached a human clinical trial area, and we'll take a small deep dive into the, excuse me, can we have a little less noise on that corner, please? Computer corner, please. Please, can we have a little less noise there? Thank you. So TRIA-valve is the first one that's reached human clinical trial, and we'll take a small deep dive into what the TRIA is. It was first studied in USA through this particular protocol, and they have been approved for 40 patients, and they've completed that, and now right now they are in their follow-up phase, and they've submitted their data to the US regulatory status. In India, again, this particular valve was submitted to the DCGI for clinical use, and it was approved for the aortic position in patients over 45 years of age, and in mitral valve, it has been approved for all ages. What are we looking at? The main criteria that we look for is thromboembolism, valve-related death, and hemorrhage. Whether there is valve thrombosis, whether the leaflets get thrombosed or not. If there is any valve-related death or valve-related reoperations, like the leaflet degenerates or there is a leaflet rupture or something like that, and whether there is mortality of patients, and also hemorrhage, because initially for first 3 to 6 months, these patients have to be kept on anticoagulation. So looking at the basic problems with tissue valve that we face day to day. And the primary endpoint, of course, is death, reoperation, and structural deterioration of the valve. We also look at many other secondary endpoints such as TIA, stroke, ICU admission, arrhythmias, and also the function of the valve, the gradients and the regurgitation, or the gradient and the regurgitation in the polymer valve. This is what we look at. Also, we look at the functional class of patients, whether after implant of the valve, the functional class of the patient is good or not. So like I said, patients over 45 years are being taken up in the aortic, and in mitral, all ages have been approved for clinical trial use. There were a lot of exclusion criteria in this particular trial. For aortic position, only patients who required CABG and aortic valve replacement or pure aortic valve replacement were taken up for the trial. Redo surgery, double valve replacement were not included. Any patient with renal failure, pregnant patients, and patients who would not be compliant with the trial were excluded. Also, patients with LV dysfunction were not included in this trial. So essentially, they wanted to take good patients, and they were taken up. We did a follow-up where we looked at things like medical history, preoperatively medical history, NYHA class, their STS scores, the standard data, and then the patients were enrolled. More than 42 patients have been enrolled in the country so far. And once the surgery was done, patients had a regular echo, regular screening visits, and also patients were anticoagulated. All patients were to maintain an INR of 2 to 2.5 for the first 3 to 6 months. Initially, it was 3 months and then extended to 6 months. And all patients were to be kept on aspirin 75 to 100 milligram. So what is the technology of the TRIA valve? What was this valve having? This valve has a polymer. The valve is made of a patented polymer that is called life polymer, and it is supposed to last forever. It was computer designed so as to have very good hemodynamics, and no requirement of anticoagulation, and last forever is what they desired in this particular valve. And the manufacturing of this valve was to be robotic. So what does this valve has? This valve has 3 flexible polymer leaflets which are made of something called life polymer, and they are radiolucent, and the material is polyether ether ketone. It had 3 stents that are made of peak stents. These are the stents, they are peak. It's a type of a plastic material, but it's very, very tough, and it's already used in many medical devices like joints and otherwise. It has a PTFE swing ring. This swing ring is a simple felt swing ring. This is a peak stent, and the leaflets are made of, I said, life polymer. That is a biomedical grade silicon polyurethane urea material. All the polymer valves have a very different material. Some have silicon, some have polyurethane, and they are looking at what happens. See, once the plastic goes into human body, the temperature changes, the pliability of the plastic changes, the leaflets can become hard, the leaflets can become brittle, the leaflets can snap. There are a lot of problems with polymer. We all know if you heat up a plastic bag, it becomes soft. If you cool a plastic bag, it becomes hard. So polymers are not as easy as we think to use for valves. And this valve has an excellent, hydrodynamic performance. And this valve basically, the peak stent that I said is already used in our Avalus valve. That same stent has been used in this particular valve. Like I said, this is what the valve looks like, and it actually looks very beautiful on the table once you implant. It is also translucent, so while you are implanting, you can have a good look under the valve also, okay, whether any suture is stuck, not stuck, how is the valve implant, what is the space. So it looks very beautiful when you implant the valve. Very easy to implant also because it is a felt swing ring and it fixes very well. The computer dynamics are beautiful. It shows a complete opening of the valve and it's very well designed. When you open the valve, the effective orifice area on the table also looks very pretty. Its size, it's slightly more bulky than standard valves, but still it gives a very good effective orifice area. As you can see, even a 90 valve will give an effective orifice area of 1.87 and peak gradient only of 12. At higher sizes, of course, they talk of EO of 3.4 centimeters square and a gradient of only 3 millimeters. That is how the valve has been designed. The materials, like I said, they have been through all the possible animal testings and sheep, animal testings, and the polymer is otherwise bio-suitable and biocompatible. And these materials basically have been used for pacemakers and pacemaker leads and other implants that are put in human use already. They've also done, what do you say, animal experiments. Look what happens to the valve once it is implanted and explanted. This is how a perimount valve will look after explant, 6 months after explant, and it shows some calcification. Whereas the polymer valve, the tria valve, will look absolutely clean because there is no calcification on the leaflet. The leaflet is immune to any human reaction. It doesn't need any treatment or anything. So the polymer is a totally, it doesn't do anything in the body, it just stays there. So there is no reaction to it, no calcification, no degeneration of the leaflets are known. This valve has been tested extensively, and as of now it has completed more than 1 billion cycles in vitro testing, like I said, in the accelerated testing machines, and that would be equal to 30 years of clinical testing. So 30 years is good, hence the valve can be implanted at any age. That is why so many years of testing are required. They also, you know, implanted into sheeps, brought it out and looked at the pathology. The pathology shows no changes when they explanted the valve. Valve is as good as it was implanted. Like if you put a valve today and you take it out after a year, it looks as if it's brand new. No degeneration, nothing, neither at the swing ring, neither at the leaflet level. So that is how the valve has been designed. So current design is such that it should avoid long-term anticoagulation, it should be very durable, and it should be resistant to leaflet calcification, and they want a good valve performance that is low gradients and a good effective orifice area is what they're looking at. So as of today, the valve has been compared to the perimount valve, and the, as you can see, by pressure gradient, the yellow is the Edward valve and the blue is the tria polymer valve. So the gradients in the tria valve are lower than the Edward valve, and the effective orifice area is more than the Edward valve. Actually, when you look at an echo in these valves, the valve opens up 100%, and hence it shows a very good effective orifice area, and the gradients have also been low. This is how the valve X-rays look after 6 months when they're explanted. More so, these valves are made by robotic manufacturing. So their footprints are very small. The manufacturing facility is hardly required. You don't need to source so much of tissue, so much of metal, treat the carbon. You don't have to do any of those things. Hence, it is very easy to manufacture, and they can put a robot in India and manufacture valves day and night if they want to. So manufacturing is very easy. The footprint is very small, and because of robotic manufacturing, the valve duplication is 100%. In America, when they evaluated this valve, they have seen significant clinical improvement, which also sustained over time. There's been no degeneration. So how would it impact India? See, in India, we have a problem with mechanical valve that we have to do PT. If you have got a tissue valve, it will degenerate. How would it change things for our country? Because our requirement in our population is slightly different. Our average age for a mechanical valve in aortic position is 40 years, mitral is even younger, and if the valve turns out to be successful and durable, it will be boon to our young patients. It will eliminate the need of anticoagulation, which is extremely difficult in our country, we all know of that. It has low thromboembolism rates, so it will eliminate that risk, and there is no calcification, no degeneration. Hence, implant in young people who are looking at pregnancies or who are busy with the work where they can get injured and they can't take anticoagulation. For those people also, those patients, it will be excellent. So it can be good for all ages. Like I said, we won't need much for manufacturing too. So in conclusion, I would like to say that polymer valve is something that is going to come in time. The technologies are still under testing. I'm not saying the final word has been said. The trials are on. Fortunately, the human trials of polymer valves have started, and one day I'm sure this technology is going to succeed. Are we there or not there yet? I don't know. But yes, one day this particular material will come in. Second, being plastic or a polymer, you know, polymer is very cheap and robotically made, hence the effort goes down. So I do believe this will be very cost effective when they come to the market. And of course, their application to TAVI, good hydrodynamic testing may make them the ideal valves. So we may actually be able to cure patients from prosthetic valve disease that we see. So we have valvular heart disease patients, you replace them with prosthetic valve disease. If a polymer valve succeeds, then we will be able to eliminate prosthetic valve disease, which is our biggest concern today. So I don't know whether this is the eureka moment or not. Trivalve has been in clinical trial now. The Triskel valve will come. I don't know whether this is the eureka moment or not, but only if the data coming out of the valves we are implanting at present is as good as the valves already being used, then as good and better than that, then this will or maybe the final solution or the holy grail for the patients suffering from valvular heart disease. Thank you very much.
Thank you, Dr. Anil Jain. May I now invite Dr. Bhupesh Shah to compare TAVR and SAVR. I request all my esteemed speakers to please start concluding when they hear the first buzzer.
Where we stand with the surgical AVR. Today we are going to discuss between TAVI and SAVR. What is basic difference between cardiologist and surgeon? Cardiologists always follow the dye and we always follow the blood pathway. Depending whom you are asking which is better, the technology is the technology is either beneficial or has a negative effect on the health environment. Today I am going to talk about these few points about SAVR. First is limitations of procedures, complications, future issue of the TAVI over SAVR, global data of SAVR versus TAVI, why industry is behind TAVI, policies and discussion on the low risk patients trial, which is more important for us for our future. SAVR, surgical AVR can be done by any surgeon globally, whether he is a junior or senior. At least we have in training phase in India, we are saying mitral is better than the AVR, aortic valve. But in outside India, the people are saying AVR is more difficult than the mitral valve. So in TAVI, they have always make some limitations. Yeah, just picture. Okay, sir. Yeah. Okay. Surgical AVR can be done by any junior or any senior surgeons all over globally. But for TAVI, they have make an inclusion criteria. They have various protocols. They follow TAVI protocol, STS scoring, another Euroscore 2, and they come up with the risk criteria, high risk, intermediate and low risk group. So very high risk patients, they are filtered and they are not publishing their data also. What are the exclusion criteria which is important for surgeon to learn? There is a bicuspid valve, acute myocardial infarction, coronary artery disease, which require revascularization, ejection fraction below 20%, aortic annular, small aortic annulus or dilated aorta, severe aortic associated mitral or aortic regurgitation, and lot of or TIA or severe renal insufficiency, they are not doing it. So, what are the advantages, anatomical limitations of TAVI over SAVR? Patient selections, what we discussed. If there is any small root, which is most common in Indian scenario, dilated aortic root, heavy calcification, coronary osteal variations, they are also finding lot of difficulty for TAVI. Tortuous and heavy calcific vascular access, bicuspid aortic valve. Now they are come up with the trials in the bicuspid aortic valve, but it is not comfortable with for TAVI procedures. So, as a surgeon, once we open the chest, we can deal with the associated disease like other valve, aortic valve, mitral valve, any associated coronary disease, CABG can be performed. If it is a small aortic root, we can do the root widening. In bicuspid aortic valve, we are always performing better than the TAVI, and we are not handling any tissue valve during implantation. So, what TAVI carries the limitations. Anatomical limitation, as we know, they require always proctor. Surgical standby to bail out from their various complications. There are various valves, various techniques, and nothing is standardized for each and every TAVI procedures. Selection of patients, what I told, associated lesions, they are generally common with the 20% of the patients during AVR. Pre-operative complications, before entering, there are a lot of problems for bleeding, cardiac tamponade or vascular damage. What they are facing, why they require surgical help also, because by heavy calcium, vascular trauma, bleeding, all things they have to be diagnosed immediately and to be tackled immediately. TAVI related complication to be diagnosed and immediate. What we discussed. Paravalvular, if we see the complications of the TAVI and the data, each and paravalvular leak, acute kidney injury, prosthetic mismatch or pacemaker, each and everything which varies between 4 to 40%. They have not standardized any data, or they have come up with any guideline to define paravalvular leak, prosthetic mismatch or any migration of the valve. Acute kidney injury, which is most common with this one, is the type 2 and type 3, which carries high mortality on a second or third day. Prosthetic mismatch, what they are claiming, prosthetic mismatch is very less with the TAVI, but it is not there. There is no proper guideline, no echo guideline to define prosthetic mismatch is less with the TAVI. Permanent pacemaker, it is also there are various data which shows 6 to 40% depends on the calcifications and operators. How can we do study of any implanted device in the body? If we know ASD device which has come in the market, but after second or third decade in the post-mortem study, lot of paper now they are coming, the ASD device which shows distortion of the aortic root, alveolar obstruction, severe aortic regurgitation. So, after implanting TAVI, we have to wait for long-term results, this device will do the changes to the aortic root and certain things. Look for complications which are awaited with the TAVI's long-term results. Tissue overgrowth or pannus, new conduction disorder which are coming in a high rate after 5 to 6 years. 5 to 7 years. Distorted anatomy, which is most common with the TAVI in a midterm results. Pacemaker implantation, annular injury, paravalvular leak, heart failure, and into TAVI's results, still it is not acceptable. various TAVI and various designs which are available. Thousands of valves are available in the market. So, what TAVI? More than 100 documented designs are available, more than 1,000 trials and short-term results of trial conducted only to the all-cause mortality within 2 years only. The all immediate results they are saying about the all-cause mortality within 2 years only. TAVI entry point is also not standardized. Every company which comes with a new valve and new trials, so there is no standardization of the procedure. Final goal of the safety and long-term results are awaited. So as a surgeon, we always look about the economics. Economics is very important in our country. What are the limitations of the TAVI? Because there is 3 types of the device which are available: balloon mounted, stand mounted, and self-expanding. No near zero fixation of the tissue which is present, crimping of the valve which also gives bad long-term results, overstretching ones which is not implanted properly, they do repeated overstretching of the tissue, no proper transportation or tamper-proof delivery system which is available for the TAVI. Some form of the medicalization may not be better described as a disease mongering, extending the boundary of treatable illness to expand the market for the new product. That is main motto behind TAVI in a low risk group. How many now see the industry? What are the numbers of the TAVI versus SAVR? There are 2 lakhs TAVI which is performed at present all over globally, and surgical AVR is 2.5 lakhs per yearly. So what is industry behind it? If you see US dollar market, in US dollar, 10,000 millions business at present with the TAVI, they are expecting 34,000 million market in 2023. So CAGR is around 40%. So every industry is behind this to achieve more and more their financial target. Thousands of companies are behind R&D and new design with their product. Each and every company, mind well, each and every company with a mastermind analyst show the data and outcome very intelligent with their valve trials. They are smart enough to manipulate everything. So why they require proctor? Because they want to keep their results, outcome, everything by their own in their own circle. So if it is a simple procedure, they can be reproducible by any cardiologist globally also. Various trials, more than 100 trials which are published, and so still there are another hundreds are in pipeline. So see the limitations of the trial of TAVI over SAVR. Immediate results, they are only talking about 2 years result with the all-cause mortality. Mid-term result prematurely to commit with the limited published data. Still, mid-term results are not come up properly to understand where we stand with the TAVI. Long-term results, not yet to say anything. Technology of valve, lots of design, more confusion, and redo TAVI is also very difficult, or only few operators they can also do it. So medical science has made such tremendous progress that there is hardly any healthy human is left with this type of the things. TAVI was indicated up to high risk group and partially intermediate group, but now industry wants all cardiologists to implant tissue valve percutaneously in low risk or younger age group. If you see, they are in low risk trial, they are only talking about 1 or 2 years stroke free at 1 or 2 years, rehospitalized the 1, but that's enough. If it is yes, then where we are intervening early AVR in a younger, low age group, low risk age group. Low risk trials, are there benefits or expectations where we given to our patients? No. Is being alive and stroke free a year or 2 later is a achievement, or is it this result is a really achievement or an expectation? If you see, 2 years outcome will not measure the truth of effectiveness of TVR versus SAVR. Low risk and long-term survival of low-risk patients, benefit of procedures require long-term results, that is most mandatory for the younger age group AVR is concerned. All cardiologists have surgeons based on the, and surgeons who all are based on durability and economics. Low risk, what they are claiming as design will invariably demonstrate the superiority or non-inferiority of the TAVI over the surgery in 1 or 2 years. That is not acceptable by us. They are just talking about technology, percutaneous procedure, minimal invasiveness and avoidance of the surgery, versus surgeon always look about the effectiveness, durability, cost effectiveness, quality of life and economics. So what will the lifetime management of offering a low age group to our younger age group? In life, we require, we should think about one valve for all, and each and every procedure can be done through that valve. That should be acceptable. So whatever will come in the future, we have to think one procedure once for all, and any selection of the patients for low age group, it should be done by the heart team approach. One part in the life and rest of procedure from it, that should be the future, or it should be take a joint decision with the heart team approach. Corporate funding information about the disease should be replaced by the independent information. Thank you.
May I now invite Dr. Geoff Strange to talk on his topic titled Eco IQ, AI for aortic stenosis.
Okay, well, thank you so much. My name is Geoff Strange. Pleasure to be here from Sydney, Australia. And I'm actually here to help you, as the surgeons, keep control of aortic valve repair and replacement. So, these are my disclosures. We have a big problem with the treatment of aortic valve disease all over the world. This data comes out of Harvard just recently, late last year, and it shows you that of the patients identified on echocardiography, somewhere between 30% and 70% of patients are not being sent through for treatment. We need to get control of where these patients are so that they can make their way to the surgical or the heart care team for proper intervention. Only 48% of patients received any form of valve intervention. So JACC, the Journal of American College of Cardiology, editorialized this with Brian Lindman saying that the alarm blares for the undertreatment of aortic stenosis. And this last sentence, I've never seen this in a medical journal before. It says that the status quo is unacceptable. And they're calling for us to change the way that we practice. And I believe the big problem here is the cardiologists are holding on to patients and not sending them through to the surgical teams, the heart care teams, to evaluate for appropriate therapeutic intervention. And I've got a solution for you. So why is this the case? This is the case because we've been looking at this Braunwald curve for about 50 years. We published in JACC in 2019 showing that actually this concept that patients are perfectly fine until they fall off the cliff is completely wrong. And in fact, what you'll find is when you flip this upside down and you look at our data, on 26,000 patients with aortic stenosis across the spectrum of disease, we found that the mortality threshold, the pivot point for where people are safe and then they begin to increase their mortality rate, is actually 20 millimeters of mercury across a mean gradient. So this is a big change in the way that we understand this disease. This has been repeated now by multiple big data at the Mayo Clinic and others, Stanford, etc., that have shown that the mortality of these patients is happening way earlier in the disease evolution. It's as bad as a whole heap of cancers, and we need to change the way that we think about this disease. So time has come for a change. I think that the concept that Stephen Hawking wrote about, saying that the greatest enemy of knowledge is not ignorance, it's the illusion of knowledge, and that's what we've got to overcome here today. So I've been very fortunate to co-author papers with my colleagues from around the world. We looked at the UK specifically with every single president of every society, so the Society of Thoracic Surgeons, the Society of Cardiology, the Interventional Society, and we looked at the UK population data and looked at what kind of prevalence aortic stenosis, what burden it may give to the UK population. And what we're able to show, if my cursor will work, we're able to show that in the UK, so there's only 65 million people in the UK, we're able to show that there's 300,000 patients right now with severe aortic stenosis, and 200,000 of those are symptomatic, requiring intervention. Now, I need to pause for a minute, because if you think that's a problem, I hate to think what it looks like over here. You guys have a massive job. You'll be employed for the rest of your lives, and you'll have thousands and thousands of patients. I think the number's about 3.9 million patients right now today needing your help, needing the junior surgeons that you guys are trying to encourage to come up through the ranks to grow their practice. And I want to give you an artificial intelligence solution to make sure that you keep control of those patients. So why are we missing them? We're missing them because there's a lot of low flow, low gradient patients, and they don't get sent through because the cardiologist sees a low gradient and doesn't necessarily think that this patient's got severe aortic stenosis. And what is the balance of that? We published this in the American Heart Association journal last year. You can see of over 1 million patients we looked at, if my laser pointer works, over 1 million investigations, 622,000 individuals, 12,000 patients with severe aortic stenosis. Half of them are high gradient, but more than half of them are low gradient. And they're the patients that I think that we're missing mostly. And why are we missing them? Well, we're missing them because over time, the parameters that we use to differentiate the outcome become less sensitive. So this is a Cox proportional hazard ratio, and you can see things like ejection fraction over time for men and women become less sensitive in predicting the severity of disease. And that's, of course, because we've got a failing ventricle. Every part of the heart responds to a stiff aortic valve. The atria responds, the ventricle responds, and the pulmonary circulation plays a part in that as well. So beware of confirmation bias. How can we avoid confirmation bias? We can do that by employing artificial intelligence. So right now we have a symptomatic bias, we have an age bias, we definitely have a gender bias, and we have a hemodynamic bias where people don't rely on the aortic valve area to send the patients through to the heart care team. So on the back of our data, the American Society of Echocardiography have said the time has come for an alert system to be built into the reporting of severe aortic stenosis. And the reason that they're calling for a change is because we're missing so many patients, and when they're not just hanging around, they're actually having a huge impact on hospitalization rates, and then they're dying before treatment. So how can artificial intelligence help solve this problem and bridge the gap between the cardiology teams and the surgical or heart care teams to come together for the best outcome for the patient? Well, I want to tell you what we've developed. We've developed a measurement analysis program that enables you to predict the right patients that need to be sent through to the surgical or the heart care team at the right time. We've trained this on 1 million investigations, this 631,000 patients. We trained it on 70% of that population, so 70% of those echoes, 440,000 individuals. We looked at all of their echocardiographic data. So that's everything. Everything from their estimated right ventricular systolic pressure to their septal thickness, ejection fraction, E prime, LAVI, body mass index, looking at the total mass, everything that happens structurally changing in response to the aortic stenotic valve. And then we tested that on nearly 190,000 patients to see whether we could predict the right patients just simply using conventional echo, taking the numbers that are generated, training a model to know which patients need to go through to the heart care team at the right time. So we use this funky little thing called a modified mixture density neural network. And, you know, I'm not going to labour the point in my 15 minutes of fame here to tell you exactly how we built this, but basically we take the input data from the echo. So this is just the numbers, right? This is the echoes performed as it would normally be performed. We take the output of those numbers. Because we've trained it on so many patients, it's able to learn the phenotype of the multidimensional changes that happen in response to that stenotic valve. And we train it and we teach it just like we teach our children. We positively reinforce good behaviour and we negatively reinforce bad behaviour until we get what we want. And so we use a method called back propagation to push the error metric back into the neural network, ask it to come out with a prediction. In this case, it produces a multiple Gaussian distribution. So we're able to see an average of an average of an average, and we're able then to predict the patients with the right error metric that we're happy with to give us a good prediction that the patient has severe aortic stenosis. So what the AI does is it takes this morphological complexity of understanding what's happening to the valve, and it takes all of that multidimensional component into account. So yes, it looks at the valve, it looks at what's happening in the valve itself, but it also looks at what's happening in the atria. It looks at what's happening both systolic and diastolic function in the ventricle, and it takes into account the pulmonary circulation. And so it wraps up the entire bundle of structural changes and gives a prediction for you to be able to know who to intervene at what stage. So conventionally what's happening in echo is we've got all of these multiple DICOM images. You're looking at one screen and then the other screen and you're trying to predict. And the company Echo IQ have developed this product called Echo Solve. Of course, they say it's solving the problems of echocardiography, making sure we can send the right patients through to you at the right time. And really it takes all of those measurements, gives you this multidimensional view, and predicts the right outcome. We've tested this in numerous places. This was on 31,000 patients in Harvard. And you can see here that the Echo IQ was able to predict all of these patients that have either guideline-defined aortic stenosis, have a high risk, or this so-called moderate group, and you can see their survival compared to those in the green line. And that's even when we've accounted for all of these different confounding factors of clinical profile, inpatient, outpatient, their renal function. We've looked at their comorbidities, whether they've got hypertension, coexisting coronary artery disease, etc. All of those confounding factors, the artificial intelligence is still able to predict the right patient that has risk, and importantly, the patient that doesn't have risk. So you can differentiate for the patient population you're looking at. We've recently tested this in a Edwards-funded project in the two St Vincent's hospitals in Sydney, and the bottom line on all of this, and I don't have time to go into the detail in this talk, but the bottom line is that With conventional human diagnosis, we get about 53% of patients. If you use the artificial intelligence enhanced population, you get an extra 386, and you get the entire guideline patient population. So basically what we've got here is we've got an increase in the diagnosis, we've got a removal of the bias we talked about, and that allows us to take what we're doing today and expand that and get every single patient that's at risk sent through to you and your heart care teams. The engine itself works like this. It takes the outputs, it runs it through the algorithm. The algorithm can send that message even if you only have a minimal data set. So even if you only collect the age, the BMI, the Vmax and the ejection fraction, we can still send that information back to you and tell you who's at risk. And we can send it to you anywhere you like us to send it to you. We can SMS it to you. So if this is in your echo lab, you can be set up so that when that patient's identified, that patient can be directly sent back information and alert to you as the head of the heart care team, or your secretaries or your junior staff or whoever you want to know about it, so that you make sure you don't miss a single patient. So ladies and gentlemen, in conclusion, what we're doing is missing up to 70% of patients. We've developed a solution for that can improve the human diagnosis by at least 70%. We make sure that we remove all the bias so that you get the right patient at the right time. And this can be deployed now. It's ready to go. It's going to be available in India. It'll be ready for you to have in your echo labs so that you can get an alert every time the right patient comes through the echo lab ready to be sent through to the heart care team. Thank you so much for your attention.
Thank you, Dr. Geoff. Now may I invite Dr. Rajesh Desai to speak on bicuspid aortic valve with ascending aorta dilatation cases.
Thank you. Good morning, friends. Let me thank the organizer before starting this talk for the opportunity given to me. My topic today is bicuspid aortic valve with a dilated ascending aorta. Am I okay? Yeah. Just a brief background, 1 to 2% of the population have bicuspid aortic valve and only 20% maintain normal over their lifespan. Close to 1/3 develop serious morbidity during their lifespan. Bicuspid aortic valve is responsible for more morbidity and mortality than all congenital heart disease put together. So there is a huge market for screening also for Mr. George. Genetically, it is an autosomal dominant disease. It can be sporadic and familiar. There is 4:1 male preponderance. It is linked to chromosome 15. On this basis, it is necessary to screen all first degree and possibly second degree relatives of patients with bicuspid aortic valve. Pathologically, it is usually an isolated defect. However, 20 to 50% of the patients might have additional cardiovascular abnormalities. 50% coag, 30% interrupted aortic arch, 30% VSDs or Turners have bicuspid aortic valve. All 90% of patients with bicuspid aortic valve have a short left main and have a left dominant system. Bicuspid aortic valve have 10-fold risk of dissection than normal population. 7 to 13% of unselected cases of aortic dissections are bicuspid aortic valve. Interestingly, bicuspid aortic valve dissection occurs in the normal bicuspid aortic valve. Almost 10-fold increase in type A aortic dissection in bicuspid aortic valve patients. Embryologically, it is not simple cusp fusion. It is cardiac cushion abnormality affecting the root, valve, and the ascending aorta. There is deficiency of endothelial nitric oxide synthase, fibrillin deficiency, and increased matrix melanoprotein activity, which is responsible for aortopathy in bicuspid aortic valve. An interesting paper by Mary and co. who found regional disruption in endothelial nitric oxide synthetase. They found that the right side of the aorta, the deficiency is more than on the left side. And that is why we see more dilatation of the aorta on the right side of the surgeon in bicuspid aortic valve patients. Way back, Kuchukos in 1997 recommended replacement of all ascending aorta above 5.5 centimeter. However, they kept a lower threshold for Marfan's at 5 centimeter. Is the threshold still lower in bicuspid aortic valve? Let's see. Tyrone David studied 201 patients of bicuspid aortic valve with ascending aorta less than 50 millimeter, their own patients. In follow-up, they divided this patient into 3 groups: those with less than 40, those with between 40 and 45, and those between 45 and 50. And what they found? Freedom from aortic complication was the worst in those aortas which were greater than 45 millimeter. So their recommendation was anything above 45 millimeter should be replaced. Bicuspid aortic valve, anything ascending aorta greater than 45 millimeter should be attended to have a better long-term results. Cleveland Clinic studied 430 patients of bicuspid aortic valve, and interestingly in their follow-up they found 12.5% risk of dissection in aorta size less than 50 millimeter. Their conclusion was if patients with ascending aorta greater than 40 millimeter is attended, then 95% of the dissections can be avoided. This group did a prospective study of their 35 aortic valve replaced patients which had 20 bicuspid aortic valve and ascending aorta of greater than 40 millimeter. They have 5 aortic events and all 5 of them had bicuspid aortic valve. So they recommend replacement of the ascending aorta in bicuspid aortic valve if it is more than 40 millimeters. Martin and King studied their aortic valve replaced patients in bicuspid and tricuspid aortic valve, and they found that the bicuspid aortic valve patients had higher aortic dimensions than control patients with the same degree of tricuspid valve disease. So it is intrinsic aortic pathology which is responsible for the aortic enlargement. What happens to the aorta after replacement of the valve in bicuspid aortic valve patients? So there's an article by Claudio and Russo. They studied 50 bicuspid aortic valve and 50 tricuspid aortic valve patients of their own consecutive patients. In their follow-up, they found that bicuspid aortic group had 5 deaths due to aortic dissection and 7 sudden deaths, whereas in tricuspid valve patients, there was no event. 2D echo, they found the ascending aorta and sinuses more dilated in follow-up than in bicuspid aortic valve than tricuspid aortic valve. 3 patients of bicuspid aortic valve were operated for aneurysm greater than 60 millimeters. So, ascending aorta greater than 45 millimeter have high incidence of aortic complication and diminished survival. Need to be aggressive in bicuspid aortic valve patients, especially when the aorta is dilated. So Tyrone David studied 514 patients with ascending aortic aneurysm, of which 70 patients were bicuspid aortic valve, close to 13.54%. They found the aneurysmal growth rate of 0.19 centimeter per year in bicuspid aortic valve, whereas in tricuspid aortic valve it was 0.13. Bicuspid aortic valve patients also had higher proportion of repair of the aorta, close to 73%, and they were younger patients than tricuspid aortic valve patients. Edge and colleague in Mount Sinai studied their 206 patients of bicuspid aortic valve with ascending aortic aneurysm. Their mean diameter was 55 millimeter, mean age was 53. Root replacement with open distal anastomosis was done in all patients. Mechanical valve conduit was used in 61% of the patients. Their mortality was less than 3%. And in 18 years follow-up, there was no reoperation for ascending aorta. Survival is comparable to the age and sex matched population. Their conclusion, Bental's operation with open distal anastomosis in bicuspid aortic valve with dilated ascending aorta has no worse mortality than AVR and superior long-term survival and low rate of reoperation. This group of Yasuda studied aortic valve in bicuspid aortic valve dilatation. They studied their patients of aortic valve replacement, and during their follow-up they found that those patients with bicuspid aortic valve who had undergone AVR, the root dilatation of the aorta continues at all levels, from the root ascending aorta as well as to, in some cases, to the arch. So even after replacement, this continues, meaning that hemodynamic effect of the valve dysfunction is not responsible for aortic valve dilatation. It is the intrinsic aortic pathology which is responsible. Peter and Pregner studied their patients of aortic valve replacement, keeping aortic dissection in mind, and they found that high incidence of aortic dissections if the aorta was more than 5 centimeters. And Pregner and colleagues found that all their patients who had aortic dissection were all with diameter of 5 centimeters, and all of them were bicuspid aortic valve patients. So accordingly, it is their practice to replace dilated ascending aorta during aortic valve replacement. Is aortic pathology related to the anatomy of the bicuspid aortic valve? This article by Claudius studied 115 consecutive patients of there, and they divided the pathology into 3 groups: Group A, Group B, and Group C. Group A was the one with fusion of the right and the left coronary cusp. Group B was fusion of the right and the non-coronary cusp, and Group C was between NCC and LCC. Highest number of patients were in Group 1, and the Group 1 patients were younger patients, and they had more ascending aorta and root pathology, higher ascending aorta and root pathology compared to type B and C. So definitely it is related to the anatomy of the fusion. Faisal and co from Stanford University studied 64 consecutive patients with CT and MR angio, and they did measurements at all levels, and they found 4 patterns of aortic dilatation. 1, 2, 3, and 4. First was the only aortic root, which was a small number of 8 patients. Second, ascending aorta alone. The third, ascending aorta and arch. And fourth, root, ascending aorta, and arch. Depending on the dilatation, they recommend customized, tailored approach to aortic replacement in bicuspid aortic valve. This is the 4-dimensional MR evaluation of ascending aorta systolic flow pattern. You can see the flow pattern distinctly different in normal tricuspid aortic valve with normal aorta, bicuspid aortic valve with normal aorta and normal valve function, and bicuspid aortic valve in patients with aneurysm. Edge and colleagues studied normal bicuspid aortic valve patients from their follow-up consecutive patients, 158 patients, out of which 42 underwent immediate surgery. The remaining 116 was put into surveillance, and these patients who were put into surveillance, some of them, close to 45 patients, underwent surgery in a follow-up between 3 to 5 years, when the aortic dimensions increased to more than 5 centimeters. Those which were put under surveillance, they found the aorta growth rate was 0.7 millimeter in normal in their follow-up, whereas the normal age-related expansion is 0.16 millimeter. The growth rate of this was not associated with hypertension, age, sex, smoking, or nor was it associated with initial ascending aorta dimension. So they concluded that patients with well-functioning bicuspid aortic valve and moderately dilated aorta on entering the surveillance protocol enjoy a long-term survival equivalent to their normal peers. Most of us are very clear, we know that nothing to do for aorta less than 4. Definitely something to be done for aorta above 4.5. What happens between 4 to 4.5? And this group studied their own patients with ascending aorta between 4 to 4.5 after aortic valve replacement. And they are of the opinion that they are of the opinion that it is not necessary to replace the aorta between 4 to 4.5 in cases of bicuspid aortic valve. They enjoy an equal long-term good survival. Aortic dissection in patients with bicuspid aortic valve associated with aneurysm. Charles and co. This is what they found, that it is necessary to replace the ascending aorta of more than 5 centimeters to prevent type A aortic dissection. It is not always the exact size of 5 centimeters, but cross-sectional area to height ratio of greater than 10 centimeters square per meter is a better indicator. It takes into account the low profile or the low size of the body surface area of the patient. Gotts and co studied 675 patients of their with root replacement, and aortic root replacement with elective surgery, the mortality was very low, 1.5. Emergency, it was almost 8 times more. So it is better to replace or attend the root in the first operation rather than go for an emergency surgery. Same was the case with this European study by Gelsomino in their 72 aortic root replacement patient. Elective surgery is definitely more beneficial and has better longevity. Aortic root and ascending aorta replacement after a previous cardiac surgery is very challenging. Even in high volume centers, the mortality is 5.4%, and in some series it goes to 17%. So it is safer and better to intervene in the aorta during the first operation. So brief recommendation, bicuspid aortic valve patient, normal bicuspid aortic valve patients, aorta needs to be attended if it's greater than 4.5. Root replacement for abnormal sinuses, mechanical valve conduit is a gold standard. For abnormal bicuspid aortic valve, greater than 40 millimeter AVR plus root replacement, ascending aorta replacement, sinus remodeling with ascending aorta replacement, or abnormal sinuses root replacement. These were the guidelines published in 2010. It has been subsequently revised in 2014. But I still like to stick to these guidelines. I'll tell you why. These guidelines suggest echo, CT, MRI assessment of the aorta in bicuspid aortic valve, yearly evaluation of the aorta if it is greater than 4 centimeters, replace ascending aorta in bicuspid aortic valve patient if ascending aorta is greater than 5 centimeters or growth rate is more than half centimeter per year. Replace ascending aorta in a bicuspid aortic valve patient if he is undergoing any other cardiac surgery if the aorta is greater than 4.5. Bicuspid aortic valve is associated with aortopathy independent of the aortic valve disease. Replacement of aorta in bicuspid aortic valve, the threshold is lower than in tricuspid aortic valve. 5 centimeters for isolated surgery, 4.5 centimeters with other indications for surgery, or growth rate of half centimeter per year. However, bicuspid aortic valve is normal functioning aortic valve, mild to moderate aortic dilation, can be managed with surveillance for a long period of time. So what are the options for repair in bicuspid aortic valve? Mainly root replacement as I suggested. However, in those patients where the coronary osteas are not displaced, separate aortic valve replacement and ascending aorta gives equally good early and late results. I just want to end the talk by suggesting this article in Annals of Thoracic Surgery in July 22 about consensus statement on bicuspid aortic valve. And there is another article in Journals of Thoracic and Cardiovascular Surgery 2018, practical management in cases of bicuspid aortic valve. Now the recent guidelines in 2014 have increased the threshold to 5.5. I think most of the surgeons, practicing surgeons, would not agree to it to treat conservatively an aorta which is more than 5 centimeters. Probably I think they want to accommodate bicuspid aortic valve in TAVI patients. Thank you very much.
Dr. Rajesh Desai for analyzing this topic very nicely. May I now request Dr. Meherwal to come to the podium and discuss tricuspid valve repair.
Chairpersons, friends, very good morning to you all. Let me first thank Bhupesh and Gaurav for inviting me for this Techno College, and I must also congratulate their scientific committee for putting up an excellent scientific program which covers wide topics of the cardiovascular thoracic surgery. I'm sure it's going to be useful for all the attendees. So I've been asked to speak on the tricuspid valve repair, indications and techniques. I think one of the suggestions which I had made last time in our annual meeting, and I'll make this suggestion this time also to the organizing team, it should always be a laptop on the podium for the speaker. You know, he has to change the directions. If you try to look at that point, it may not be very clear. And I made these suggestions in our last annual meeting that should be standard for organizing all our meetings. So I've been asked to speak on the tricuspid valve repair, the indications, and the techniques. The tricuspid valve surgery now has become more common, particularly the repair of the tricuspid valve for tricuspid regurgitation. And functional TR is the most common type of the tricuspid valve pathology. And it is most often caused by annular dilatation, which is secondary to the left-sided heart failure due to myocardial disease or valvular heart disease. Almost 50% of patients undergoing mitral valve surgery for mitral valve disease, they have moderate or severe tricuspid regurgitation. And a good proportion of these patients, they develop tricuspid regurgitation late after previous left heart surgery. Now, why this is important? Because obviously there are many patients who are operated in the past, and they are coming with the significant tricuspid regurgitation, and the surgery for tricuspid regurgitation on a patient who has undergone previous cardiac surgery with some RV dysfunction is significantly higher as compared to the first surgery. The tricuspid regurgitation, the commonest is the secondary tricuspid regurgitation, and the left-sided heart disease causing LV dysfunction or because of the valve disease resulting into pulmonary hypertension is the commonest cause of secondary TR. Any cause of pulmonary hypertension, either because of chronic lung disease, pulmonary thromboembolism, or left to right shunt, will lead to secondary TR. And any cause of RV dysfunction, either myocardial disease, RV ischemia, or RV infarction, will lead to secondary TR. The primary TR is relatively uncommon. In fact, in some of the studies, the secondary TR was present in almost 90% of the patients, and primary TR was only in 10% of the patients. And the causes may be the rheumatic, myxomatous, Epstein anomaly, endocarditis. But I think a very important cause of the primary TR now, which we are seeing, is the pacemaker leads, the ICD leads, and the CRT leads. In fact, in some of the studies, the commonest cause of the primary TR is these leads. So what happens basically when there is dilatation of the right ventricle, there is dilatation of the aortic annulus. There are three leaflets, as we know, in the tricuspid valve. The septal leaflet is relatively fixed, so the dilatation occurs mostly in the anterior portion or the anterior leaflet and the posterior leaflet. The diagnosis is made by the transthoracic echo, which is the initial screening, and it is the main investigation for initial evaluation, both for the etiology as well as looking at the severity of. We, in our practice, do it routinely. It's not always required, but it certainly may be required in certain situations. For example, when there's a poor window of the transthoracic echo, there's a concern for endocarditis, and if there is pacemaker leads, which may interfere with the imaging. Now, when to repair the tricuspid valve if the patient has tricuspid regurgitation? The indications are primarily based on two things: the severity of TR and the annular dilatation. For a long time, we have been managing the TR based on the severity, and obviously the severe TR is repaired. But the annular dilatation now is being considered as a very important criteria for the repair of tricuspid valve. And this is because the functional TR is highly dynamic, and we all know that. It can vary widely in the same patient depending on the volume, loading, and hemodynamic conditions. So at one point of time, you do an echo, and you will find that the patient has mild to moderate TR. At the other point of time, the same patient may have a severe TR. And therefore, assessment of annular dilatation is an important factor in the decision to perform concomitant tricuspid repair. And what is a dilated annulus? A significant tricuspid annular dilatation is defined when there is a dilatation 40 millimeters or more than 21 millimeters per meter square, as measured at Anne-Dashley in the apical four-chamber transthoracic view. Even though this has limitations because the tricuspid valve is three-dimensional, and we are measuring in the two-dimensional, but basically this is the criteria which is taken into consideration while defining the dilated annulus. These are the latest ACCHA 2022 guidelines as to when to repair the tricuspid valve. And as you can see, the only class 1 recommendation are in patients who have severe TR undergoing left-sided valve surgery. So this is class 1 recommendation. These are 3 class 2A recommendations. That means that the tricuspid regurgitation should be considered in patients who have moderate or progressive TR undergoing left-sided valve surgery. It should also be considered in patients with signs and symptoms of right-sided heart failure and severe primary TR. And third, also in patients with signs and symptoms of right-sided heart failure and severe isolated secondary TR, which is attributable to annular dilatation in the absence of pulmonary hypertension or left-sided disease, who are poorly responsive to medical therapy. So these are class 2A recommendations. If you look at the European Society of Cardiology and European Association of Cardiovascular Thoracic Surgery guidelines, they also are by and large the same. The class 1 recommendation again is in patients who have severe secondary TR undergoing left-sided valve surgery. This is for the secondary TR. And there are 2 class 2A recommendations. One are in patients who have mild or moderate secondary TR. So as you can see, patients who have mild or moderate TR, but the annulus is dilated more than 40 millimeters or more than 21 millimeter per meter square, the tricuspid valve should be considered for repair. And also in patients with severe secondary TR with or without previous left heart surgery, who are symptomatic or have right ventricular dilatation in the absence of severe RV or LV dysfunction and severe pulmonary vascular disease or hypertension. Now this is very important, that if the patient has a severe TR, you are contemplating repair, but if the patient has a significant RV dysfunction or a significant pulmonary vascular disease, the outcome is going to be very poor. And these are the recommendations for primary tricuspid repair. So it is recommended in patients with severe primary TR undergoing left-sided surgery, and also in patients with isolated severe primary TR without severe RV dysfunction. So these are the class 1 recommendations, and the class 2A recommendations are in patients with moderate primary TR undergoing left-sided valve surgery, and in asymptomatic or mildly symptomatic patients with isolated severe primary TR and RV dilatation were appropriate for surgery. Again, it says appropriate for surgery, which basically means that patient should not have a significant RV dysfunction or a pulmonary vascular disease. Now, this is a very important article which was published by Professor Dreyfus many years back, and what he looked at is whether annular dilatation may be an important criteria to repair the valve. So what he did, he compared, he analyzed 311 patients and divided them in 2 groups. One, those patients who underwent only mitral valve repair, and the second one who underwent tricuspid valve repair along with the mitral valve repair. The patients, the decision to repair the valve was based on the annular dilatation, which was measured intraoperatively. So any patient who intraoperatively had annulus of 70 millimeters or more was repaired. So on the arrested heart, that's how we measure the tricuspid annulus, and if it was more than 70 millimeters, the tricuspid repair was performed. And these were the results. The hospital mortality and actuarial survival at 3, 5, and 10 years were not different between the 2 groups. The NYHA functional class significantly improved in group 2, and the tricuspid registration increased by more than 2 grades in almost half of the patients in group 1 and only in 2% of the patients in group 2. And these were the conclusions of this study, that remodeling annuloplasty of the tricuspid valve based on the tricuspid dilatation improves functional status irrespective of the grade of regurgitation. So many of the patients in this study had mild TR, and therefore a considerable tricuspid dilatation can be present even in the absence of substantial TR, and tricuspid dilatation is an ongoing disease process which will with time lead to severe TR. So briefly, how we repair the valve, it's a very simple standard technique. We just need to know the anatomy, and I think the important thing which we need to know is that there are 3 leaflets. As I mentioned, the maximum dilatation in the anterior and the posterior annulus, the septal is relatively fixed. The most important structure, I think, which we have to keep in mind is the AV node, because one of the important the technique of annuloplasty is simple. You take simple horizontal mattress sutures on the annulus, approximately 1 centimeter wide and 2 to 3 millimeter deep, and The sutures are taken 1 to 2 millimeters outside the hinge point between the leaflet and the anterior wall. I think the two important things which we have to remember is the complete heart block because of the injury to the AV node, and it occurs in about 4 to 6% or 4 to 8% of the patients, depending which literature you are looking at. But it is important to avoid this because the transvalvular pacemaker, which will be required in these patients, is associated with much greater recurrence rates after the repair of the tricuspid valve. Uncommonly, or I would say very rarely, there can be injury to the right coronary artery. Whether ring is better or the suture annuloplasty is better, this is a meta-analysis which was published in 2014 to look at the early and the long-term outcomes after tricuspid repair of the suture-based versus prosthetic ring annuloplasty. And what they found that in the early mortality was better in the annuloplasty, but in the long term, there was no significant difference in the survival. But the freedom from moderate TR was significantly better in patients with ring annuloplasty. And the conclusion of the study was that ring annuloplasty is associated with better outcomes, and it was a protective factor for early mortality and long-term recurrence of tricuspid regurgitation after the repair. So the take-home message would be that functional TR is common in patients requiring left-sided surgery. Annular dilatation continues after left-sided surgery if not corrected. Serious consideration should be given to the tricuspid valve repair at the time of left-sided surgery, and ring annuloplasty is associated with better outcomes than suture annuloplasty. In our practice, when we repair all the valves which have severe TR, and any patient who has even mild or even a moderate TR with dilated annulus, and obviously a lot of the patients we are getting, which we had operated about 20 or 25 years back, coming back with the significant TR. Thank you very much.
Thank you, Dr. Mehrwal. Now we have come to the last paper of this session, presentation about aortic root enlargement in adult patients. I request Dr. Hiramath to please come and give his presentation.
Good morning. At the outset, let me thank Dr. Bhupesha and Dr. Goel and his team for inviting me to deliver this talk. Well, there were two topics in the scientific program, aortic root enlargement in adults and aortic root enlargement in pediatrics. So I thought I'll put it as small aortic root, what fits the Indian population. Well, aortic root enlargement is an invaluable surgical technique which every cardiac surgeon performing aortic valve replacement should be familiar with. The technique allows the insertion of an appropriate sized mechanical or a biological valve processes in a patient with a small aortic annulus to mitigate patient processes mismatch. Performed properly by an experienced cardiac surgeon, the technique is safe and reproducible. As we all know, the small aortic root quantification, which was put forth by Dr. Rahimtullah, his classification of stenosis at distinct levels were obstruction to the ventricular outflow, stenosis at the ventricular aortic junction. Causative factors bringing about patient process mismatch were size of the process inserted limited by small annulus, reduction of effective orifice area due to endothelialization and tissue growth. Is aortic root enlargement worth the effort? Well, as the ratio between effective orifice area and body surface area, which is indexed, that is the indexed body surface area, when it is less than 0.85, it is considered as a small aortic root or patient process mismatch, and if it is less than 0.65, we put it as quite severe or critical, whereas 0.65 to 0.85 is moderate. I request all to read this landmark article where patient process mismatch definition, clinical impact and prevention, wherein they have defined very clearly what size valve and what is the effective orifice area which fits in. What is the sequel of the small aortic root? Well, measured effective orifice area is similar to the reference effective orifice area. When it is less than 0.85, it may be mild or moderate ppm, and if it is less than 0.65, as I mentioned, it is severe ppm. And anything more than 0.85 can rule out increased LVOT velocity due to hyperdynamic state or subvalvular narrowing. Other technical pitfalls can be ruled out. Well, as we have our Rowlett or Kirkland normograms in our operation theatres, I would request all of us to have this chart in the operation theatres. This is a very effective chart wherein anything falls into the red, definitely there is patient process mismatch. And the best part of this chart is, irrespective of whichever valve we use, the size of that valve indirectly to the body surface area, when you match it, it gives us the effective orifice area for that particular person, and that makes a difference for that left ventricular to knee model. As I mentioned, what is the sequelae if you don't take care of a small aortic root? Less regression of LVH, less recovery of coronary flow reserve, less regression of mitral regurgitation, less improvement in function class and exercise capacity, increased incidence of late cardiac deaths, increased incidence of bioprosthetic structural valve dysfunction, negative impact on short-term and long-term survival due to LV dysfunction, increased risk of arrhythmogenicity, which we see commonly in post-operative patients, especially in hypertrophied ventricles. Well, reduce post-up gradients across a rigid orifice, foresee demand overgrowing the supply orifice, anticipate patient process mismatch, reduce afterload for LV hypertrophy to reside. Well, there are controversies, especially when effective orifice area is less than 0.85, and when we have to do a DVR, that's a challenge. Stentless valves, improved LV mass regression, and tolerance by age, more than 70 years we need to look into. Of course, TAVI has come into. The anatomy of the aortic root, I need not go into details as we are all aware of this. This is another diagram, one especially for the postgraduates, one has to be familiar with the surrounding anatomy when we are doing a root enlargement procedure. This is an pathology diagram from courtesy from Dr. Anderson, which I had borrowed, and this shows about the surrounding anatomy of an aortic root. Well, coming to the augmentation techniques, there are various techniques, I will come to which we commonly follow. There are posterior approaches, that is the Nix, Nuez and the Manoogian-Seabold technique. The anterior approach, the Kono-Rastan, the Wuhe procedures and the Ross-Kono. The combined techniques are the Otaki procedures and the myotomy procedures. And of course, the alternative strategies are left ventricle to descending thoracic aorta valve conduit or the ascending aorta valve conduit, especially in redos or re-redos aortic valve root enlargements. And of course, the end result, the cardiac transplant also is an option for small aortic roots. Well, I will not go to the details as we are all aware of in the Nix procedure. As we make a NIC in the NCC, it usually invariably gives only a single size enlargement. Other posterior root enlargements, wherein normally we end up using pericardium, non-treated pericardium for all the root enlargements. We can use a treated pericardium or a Gotex patch, but invariably at our institute I use a non-treated pericardium itself. The Nuez is between the NCC and the LCC, and even this also gives a small single size enlargement of the valve. And this is a commonly done technique by us, wherein we end up extending our incision between the LCC and the NCC into the mid part of the AML, that is the Manoogian-Seabold emptying technique, and we end up increasing valve size by at least 2 to 3. And we implant the valve almost in at an angle of around 30 degrees. We create a new annulus which is part of the pericardium itself. About 30% of the circumference of the valve becomes part of the pericardium, and the valve seats at a 30 degree angle. Normally in this picture what it is shown is a diamond shaped patch. I used to do it with a diamond shaped patch, but I found it not very much helpful, so I switched on to a rectangular patch. So with that patch definitely a good enlargement is obtained and the post-operative gradients are also quite less. This, as I showed Manujan, it's up to the midpoint of the AML. The other anti-root element are the conorastan, wherein our incision extends to the left of the right coronary ostium, and we do create an VSD, and the VSD is in turn created closed with a separate patch, and the RVOT with an additional patch, and the same patch extends up to the aorta itself. Sometimes we may end up doing the anterior and the posterior root enlargements. Here in this technique, what the books describe is the VSD patch is closed along with the anterior root. Sometimes that may not be very much feasible. We end up using a separate patch for the VSD, and also for the RVOT patch, an additional separate patch has been utilized. The Ross Cono is a modified conotype with, of course, utilizing the pulmonary valve per se. I'll just come to our series of from 2012. We have operated around. These are the alternate techniques. I have not done this, especially in a redos. We do have an LV to aorta conduit. These are the alternate techniques one should be familiar with. Either into the descending aorta or into the ascending aorta, we can plan to implement this. Yeah, coming to our experience from 2012 till date, around 55 patients operated with a mortality of 2 cases. The main all-cause mortality was one in the case of a low cardiac output, another was malignant arrhythmias. Diagnosed to be possessing an inadequate LVOT annulus, assessed by thoracic echo and also transesophageal echo. The final decision was on table with the P gradient and the left ventricular end diastolic pressures. Well, these were the sizes commonly utilized. We had the 23 size valve, and most of our valves were either Chitra valve per se, and this was the effective orifice area with Chitra valves, and the next common valve what we had used is the St. Jude valves. And of course, we have used daffodil valves and one or two of ATS and Perimount valves also. Well, as I mentioned, technique employed in most of the cases was posterior root enlargement, that is Monogen-Siebold technique. 2 cases only double root enlargement, that is anterior and posterior root enlargement was done, and the remaining were Nix and Newes procedures. Well, the following things were looked into, especially improvement in the functional class, decrease in the left ventricular end diastolic pressures, decrease in gradients, and regression of LV mass. And definitely the function class also has been improved over a period of time in the 1-year follow-up. The gradient also have reduced significantly in the 1-year follow-up. LV mass has regressed over a period of time. And this was published in Journal of Cardiac Surgery last year in 2022. And our experience. After this, we have done around another 7 cases till date. I have not added those numbers because still the follow-up is due. Thank you for attention.
Thank you very much, Dr. Hiremath. Now we have come to the end of this session. We have about 5 minutes for discussion. We have almost a dozen senior and experienced cardiac surgeons in our audience today. So I invite them to make comments if they wish to. Students are also there, they can ask questions. The floor is open now. Thank you. Any comments, any experience, any tips or tricks? Dr. Kunal Sarkar, please.
that is the summary where STEM stands today. You don't see short-term thrombosis anymore, but what you see is a steady decline in stent patency over a period of 5 to 10 years. So the stents have started behaving like grafts. So do you expect to see that kind of polymer experience? And Dr. Strange, one question to you will be, so aren't you trying to redefine the guidelines? And if you are, then why don't you do so? Because if you have a guideline that says 50 millimeters radiant is a cutoff, and you through artificial intelligence are trying to tell the naturally stupid people that do something which is not there in the guidelines, I think that will be a little bit contradictory. Community is all your lab data and few selected centers going for a good picnic is fine, but whenever you gather the population data of tissue valves, that 15-year longevity of romance was not lived through. Is not there. So let us be frank. Tissue valves have disappointed vis-a-vis their 15 years. So when Paramount was coming to that phase, that questions will be asked about the 15-year sustainability. They did a very smart thing, they lifted the valve off the market. So I wonder what's going to happen to your stuff.
So, same way, polymer, and that is why I was very surprised when I saw all this data, and people are not even working on sour valves. They've gone straight away to work for tower.
Yeah.
And that's amazing. If it doesn't work surgically, I doubt it's going to work through tower. The other problem, which we have seen in the vertex slab valve implanting, and this is what the company believes, a slight injury, a slight metal touch onto the valve leaflet, and that progresses into a tear in the leaflet. So imagine putting all these guide wires in and out of a tower valve. Where will the plastic stand? We all know you make a small cut in a plastic and you go into 2 pieces. So that I think is.
But honestly, your plastic may do well
as surgical valve
compared to tissue.
Yes, and long term, I'm very sure in some time the true replacement to a valve will be a polymer valve. But yes, the trade-off between the thickness of the leaflet and doing a tower is going to be the biggest thing. Whether they can get the polymer right, because there is a cross-link in the polymer.
Yeah.
The thicker the leaflet, the more the cross-link. Thinner the leaflet, less the cross-link. So that can make a difference.
The stents have accepted it.
Yes.
That is
Same
what
way.
happened. They have accepted.
Sir, thank you.
Okay.
Geoff, would you like to comment?
Yeah, I'll answer quickly. The first statement is that the guidelines originally were based on a population of 622 patients. So that was out of Patricia Pellicer's group out of the Mayo Clinic, as you know well. I think that we need to deal with the evidence that's at hand. 28,000 individuals across the spectrum of 20 years of follow-up show that the gradient of 20 millimetres of mercury is indeed the inflection point for survival. What we don't know is whether putting a valve in or intervening earlier on will make any difference to the outcome. And unfortunately, I've not done that study yet. That's a job for you all to do.
You should put your AI into the machine.
Yeah, I agree completely, and we'd love to do that. We're working hard with a lot of our colleagues to make sure.
You don't need 2 separate machines.
Yeah, I agree. I agree completely.
It's such a huge piece of furniture.
Put it in. It's a little algorithm. It's very light. You can just plug it in. Yeah, so I agree.
My question to Dr. Strange as well. See, your EcoSolve, EcoIQ, that's a software, AI-based software, machine learning technique that you introduced. So, like, the main Eco machines are like Siemens and Philips and GE. Do they have their own programs like this, or is it just your company has generated, you are the only one person right now, or?
Yeah, so there's a lot of different methodological techniques under investigation and a lot of image recognition software.
Yeah.
We're the only ones that have taken the output data and actually trained the algorithm to understand that phenotype and its association with risk. So we've got an ability to plug that in pretty much anywhere, as long as we've got the right partners.
No, the thing is that I read a paper recently, somewhere, I can't remember, where they've compared the operator versus AI, and the results are actually not much better, or it's not inferior to the cardiologist or echocardiographer based analysis.
Yeah.
So how do they do that?
That was David Oyang's group.
So logistically, you keep the echo machine and there's another machine that is connected to it, or how do you do that?
So because we've trained it on such a large population, it already knows without all of the other measurements. So you don't need any of the LVOT. You don't need any of that to form a continuity equation, because the algorithm can already paint that picture by understanding a few of the measurements, and the algorithm builds that association to be able to predict those other outcome measurements and put the patient into the right risk category.
Because the latest GE echo machine has already got some AI-based program built in, where you can predict your ejection fraction and your three-dimensional LV volume and everything. It gives you an ejection fraction.
Yeah. So we can take that output and use that output to predict the patient at risk.
So, sir, in addition to the cardiologist holding the probe, there's going to be AI holding the probe as well. Yes. Thank you very much for a very lively discussion and a good session. May I now request Dr. Sukumar Mehta and Dr. Debashish Nayak to present the mementos to all the speakers. Dr. Anil Jain, can you please come on the stage? After that, Dr. Bhupesh Shah, Dr. Jeff Strange, Dr. Rajesh Desai, Dr. Meherwal, and Dr. Hiramat. Dr. Anil Jain. Let us give them a big round of applause for Dr. Bhupesh Shah. Yes, yes, please. May I request Dr. Anil also to stay on? We'll take a group photograph at the end. Dr. Jeff Strange, thank you. Dr. Rajesh Desai. Dr. Meherwal. Dr. Hiramat. Thank you, sirs. Can I request all the speakers to...
It's not replacement, definitely not.
Thank you, sirs. I'm sure the discussions will carry on into the tea break. We'll have a short tea break and we'll assemble again in about 10 minutes. Thank you, sir.
In any machine? Not yet. It can take the information from the machine.
ओके भैया
Pause है. सही कर रहा है.
થોડુંક આને આમ કરી દો. Set.
Yes, sir. I'll do it.
एक मिनट हो, मैं देख के आ रहा हूँ। डॉक्टर
I need your this thing, not this one. Yours. Yeah. अरे
Type C.
no, we don't have any video, no audio. Because when I need to connect the audio also.
Thank you, friends. I think check. Come. Thank you, friends, and let's start off with the second session of the morning, which is on the coronaries. May I request the chairpersons, Dr. Siva Muthukumar, Dr. Vishal Gupta, and Dr. Bhavin Desai to please come on stage and take your place. Dr. Muthukumar, please come, sir. Vishal, Dr. Vishal Gupta. Please come on stage. Dr. Tyagarajan, yep, please come, sir. Bhavin, Dr. Bhavin Desai. Is he here? Okay. We'll start off with this session. We have 15-minute talks in this session. The first talk is Dr. Lokeshwar Sajja. We have 15 minutes of discussion at the end of the session, so may I request the chairpersons to conduct it accordingly. And like the previous one, at 13 minutes, you will hear a buzzer so that it gives you time to conclude your session. Talk. Thank you.
Good morning, friends. Welcome you all for the interesting today's session. Now, we have 5 legends in our specialty to discuss on the coronary surgery. The art and science of coronary surgery is so unique that it's evolving every day, and we need to update ourselves with trials and studies and the practice of coronary surgery, and update ourselves with the techniques to deal with complex anatomy in this current era of aggressive percutaneous interventions. So let's start with clinical trial, discussion on the clinical trial by none other than Dr. Lokeshwar Sajja, the president of IACTS. Welcome you, sir, for your talk.
Good morning, everybody. At the outset, I would like to thank the organizers of the IACTS Techno College CME 2023, particularly Dr. Bhupesh and Dr. Gaurav, for giving me the opportunity to talk to you on insights from clinical trials in coronary surgery, the reflection on Indian experience. Randomized controlled trials are important tools in evaluating effectiveness of medical interventions, including cardiac surgical interventions. In India, cardiac surgery is a rapidly evolving field due to the rising incidence of coronary artery disease and RTCs or randomized controlled trials are necessary to ensure that these surgical procedures are effective and safe for the patients. And implementing RCTs in this setting can present several challenges. The evidence supporting surgical procedures has traditionally been based on the observational studies. The paradigm remains true for cardiac surgery as well, where a significant reduction in the number of randomized controlled trials has been seen over the past 20 years. This is one of the temporal trends that showed the difference between the published cardiac studies and the randomized controlled trials. Gardino has discussed in a very beautiful way in a JOC review on conducting surgical trials in cardiac surgery. Studies suggest that RCT design can only be applied to less than half of the treatment questions in surgery. Although registry studies have an important role in reflecting the real-world practice and patient heterogeneity, randomized trials are the only approach to minimize the bias and hidden confounders. If you look at this slide, you see the percentage of published trials comparing the interventional cardiology and cardiac surgery. The surgical interventional trials are much more in surgery, whereas device-related studies are more common in interventional cardiology. The industry-sponsored trials are much more in interventional cardiology compared to the surgical trials. In the surgical trials, many of them are investigator-initiated trials. If you look at this graph, that all the trials that are registered will have a successful completion, and there is a lot of disparity between the registered trials and concluded studies that is much more common in surgical trials. There are several challenges in implementation, designing the cardiac surgical randomized controlled trials. Some are related to trial design, trial implementation, and data analysis. Coming to the issues with trial design, equipoise is a situation where there is no clear evidence that one intervention is superior or inferior to the other and is the prerequisite for the design and conduct of any clinical trial. There can be individual equipoise, that is individual surgeon, clinicians have, whereas collective equipoise, that is a clinical equipoise that applies to the profession as a whole. It is expressed in guidelines or consensus statements. Equipoise in surgery is more complex than in medical field. It is the key that equipoise exists not only among the surgeons, but also in the cardiologist community, medical community, and even in patients community. The surgeon expertise plays an important role in designing a trial. A volume outcome association has been demonstrated for several procedures in cardiac surgery. Unless participating surgeons have expertise in both the procedures, there is a potential for a differential crossover due to the technical reasons which has been shown to affect the outcomes of RCTs in cardiac surgery. Eligibility requirements for the surgeons to participate in a trial based on a minimum volume of the specific procedure have been used in many trials. Choosing the right threshold may be challenging. If the threshold is too low, the surgeons recruited into the study may not have enough experience to perform the procedure safely and correctly. Conversely, if the threshold is too high, it may be difficult to recruit enough investigators and the external validity may be jeopardized. There are several examples in the published trials in cardiac surgery data where divergent results among the trials may be explained by the surgeon's eligibility requirement. In one of the landmark trial, the R2 trial, a higher than expected crossover rate from experimental to treatment group was present, about 14%, with values for individual surgeons varying from 0% to 100% crossover might have influenced the results of our trial. Art surgeons who enrolled more than 50 patients had different results than the surgeons enrolling fewer than 50 patients, further suggesting that there is a volume outcome effect may have taken place. Defining intervention is important and most important in the clinical trials, and as well as the outcome definition. A trial can only be reliably address a single research question based on the primary measure. Therefore, most efforts should be made in defining the outcome. The defining the outcome in RCT should follow 3 steps. One is the clinical description of the intervention should be provided according to the standard practice. A more detailed description should be provided, including the operative procedures and recommended technologies, and a clear statement on the justification how this differs from the standard practice is needed. The third one is the same information should be provided to the control procedure as well. Defining composite clinical endpoint. Composite outcomes are used to evaluate the treatments. A composite outcome may be composed of a clinical event or measures such as survival, disease-free survival, and even non-clinical outcomes. Coming to the challenges that are associated with trial implementation. Funding is one of the key challenges to the success of any randomized controlled trial. For surgical trials, obtaining adequate funding is particularly difficult. The majority of the cardiac surgery trials recruit slowly. The recruitment and retention of this patient is very important for successful conduct of the RCT, and majority of the cardiac surgical trials recruit slowly, which may affect the outcome and results in early termination of the trial. The key factors for successful RCT, a priori establishment of clinical equipoise is the key to the trial success. A second key factor is the effective screening process for the recruitment of patients, and the third factor is engagement of the patients throughout the follow-up period. Coming to the challenges that are with data analysis, the randomization allows comparability of the trial arms for all measured and unmeasured characteristics. Many factors such as crossover, withdrawals, or loss to follow-up disrupt the randomization process. This form of non-compliance causes the loss of statistical power to the trial. Issues with the data analysis. Statistical methodology to mitigate the bias introduced by crossover and loss to follow-up include instrumental variable analysis, imputation techniques, and account for the potentially differentiable dropouts across the study arms, the marginal structural models, and other models to account for the informative censoring. These approaches are probably preferable to as treated analysis. The learning curve effect, particularly for the surgical techniques, very crucial. During the learning curve for new technique, the trial results may be affected by the degree of expertise acquired by the participant surgeons. The health economics, particularly related to cardiovascular trials, the RCTs often offer an opportunity to capture the data on the research consumption and measures the health outcome, and this can be used to estimate cost effectiveness of the procedure. Coming to the challenges in implementation of RCTs in our country, one of the major challenges in conducting RCTs in India is the limited resources and infrastructure. Many hospitals and clinics may not have the necessary equipment or expertise to conduct high quality RCTs. In addition, The cost of conducting such trials can be prohibitive, particularly for smaller institutions. Another challenge is the ethical consideration of conducting RCTs in our country. India has a diverse population and it has got more than 1.4 billion population, and it is important to ensure that the trials are conducted in an ethical manner that takes into account the cultural and social context of the participants. Despite of all these challenges, there is a strong need for RCTs in cardiac surgery in India. These trials can help to identify the most effective surgical techniques and treatments, as well as to identify any potential risks or complications associated with these procedures. In order to address the challenges associated with implementation of RTC in cardiac surgery, it is important to establish partnership between researchers using multi-center trials, healthcare providers, and also governmental agencies, particularly ICMR. These partnerships can help to provide the necessary resources and expertise, as well as to ensure that trials are conducted in an ethical and culturally sensitive manner. We have participated in several of the multinational trials, multi-center trials from India. Stitch trial is the one initially conducted long time back, and R2 trial, the coronary trial, and recently a trial is going on, the Roma trial, and another sub-study that started is Roma woman. In the Stitch trial, about 10 centers from India participated in the Stitch trial. The coronary trial, there's about 6 centers participated, and the R2 trial, 2 centers from India, Escorts Hospital and Hyderabad, they participated in the trial. And the Roma trial, there are 3 centers, 2 centers from Hyderabad, Coimbatore and Delhi, and the latest is the Roma woman trial. Reflecting from the Indian multi-center studies, we have published the Promote Patency trial, the first RCT in cardiac surgery in India, and we are also conducting currently the Predict study, which is a ICMR funded study. The first study we have presented at the AATS 2018. The results were published in our own journal, Indian Journal of Thoracic and Cardiovascular Surgery. The Predict study, which is currently recruitment is going on, it was ICMR funded study, and the trial was registered in CTRI, which is a requirement for any trial to conduct, and 17 investigators participating in the Predict trial. There is also single center studies we have published from India, the off-pump and on-pump CABG, non-dialysis dependent renal insufficiency, occult renal disease, and also the yoga-based cardiac rehabilitation after CABG. This was the study that presented the AATS annual meeting, which was published in JTCVS, and also there was a write-up on the study from Thoracic Surgery News, and the occult renal disease, which was presented at the International Coronary Congress in 2016. And this is published in Indian Heart Journal, the yoga-based cardiac rehabilitation. To conclude, although a substantial amount of cardiac surgical work is performed in India, limited publications are available due to the modest clinical research in the field. Indian research is frequently overlooked internationally due to lack of publications in high-impact journals. To increase the global recognition of our practice, it is crucial to prioritize outcome analysis and publications, particularly publications from RCTs. I conclude with a quotation by Abdul Kalam: "Never complain about the difficulties in life, because a director always gives the hardest roles to his best actors." Thank you for your attention.
Thanks, Dr. Sajjan. That was a fantastic talk on the trials and everything. Now, we are living in a world where we are constantly in a battle between fake news and reality, We are surrounded by social media that's putting in our mind in constant confusion between realism and magical realism. And now Dr. O.P. Adava, our editor, is going to talk about myths and realities. Over to you, sir.
Mr. Chairperson, ladies and gentlemen. My disclosures, but none related to this presentation. Ever so early in the course of evolution of CABG, the clear superiority of IMA graft over the saphenous vein, its relative immunity to atherosclerosis, and it's not only providing improved patency, but also improved clinical outcomes was realized. And therefore, it was not without a reason that there was a clamor for extended application of arterial grafts, and that came embedded with it certain myths and some controversies too, which we're going to discuss, and I label them for you the dirty dozen. In this clamor for total arterial, is saphenous vein down and out? Is the IMA the holy grail? Patency same in all territories. If Lima to LAD is good, 2 arterial grafts are better than single. And if that be so as a corollary, 3 better than 2. How does Rima stack up to the radial artery? What are the risks associated with the arterial grafting? We know the muscular radial artery is prone to spasm. Is that applicable to elastic arteries? What about skeletonization? And I'll end with some of my, what shall I say, random musings. Now we're going to delve into each one of them a little in details, but then it will be more in a bullet point fashion, rather rapid. With no distension, better storage, and better handling of the saphenous vein, Samano et al. Have shown that the results could be virtually as good or matching a Lima to LAD patency. And therefore, the guidelines give use of saphenous vein a class 2A indication, so please be advised, those who use saphenous vein in certain clinical situations, they are not committing a harakiri. Moreover, IMA also fails. We don't realize up to 2.5% may fail before discharge. In the Cappage Compass study, Lima failed in 6.5% of patients at 1 year, and in the Prevent 4 trial at the same time frame, 8.5% of IMAs had failed. And though we talk of Lima to LAD patency of 95% and above, but when it comes to circumflex and RCA, there is a 5% sequential downgrading of the patency rates, with probably the reduced runoff and competitive flow being the mechanistic basis for this reduced patency. Even the Rima patency to the circumflex is much less to the LAD, and therefore we have to compare apples to apples when we look at Lima to LAD and vein or radial to the circumflex artery. Is 2 arterial grafts better than single artery? Well, there is a lot of observational data. The answer is a categorical yes, they improve survival. Bruce Lytle from the Cleveland Clinic showed not only the survival is better, but even the event-free survival is better. And I can go ad nauseum with the observational data, Rocha, Chikwe, Locker et al. There is a 20% roughly reduction in long-term mortality with bilateral arterial grafts. And this has been borne out by a number of systematic reviews and a big meta-analysis by Takagi et al. However, randomized trials have not yielded the same result. We all know the ART trial failed to show any superiority of bilateral IMA. But then we also know that the ART trial, 40% of patients did not receive the treatment that they were supposed to receive. And therefore, when a secondary analysis of the ART trial was done, as an as-treated analysis, there was a survival advantage for bilateral IMAs. And when the inexperienced surgeon was accounted for, that increased survival increased still further. And we have got a Roma trial which is, ongoing and looking at this issue. So if bilateral is better than single lemma, would 3 be better than 2? You have a large Australian database, 10-year survival statistically highly significantly better with total arterial. Even in a meta-analysis by Royce, look at the forest plot, it favors total arterial revascularization. Very recent publication, just a month or 2 back, total arterial reduced long-term mortality, and the same borne out with a number of meta-analyses. Even the ART trial, when the analysis was done, there was reduction of mortality of 32% with total arterial versus non-total arterial. So there is enough evidence that arterial grafts work. Now, how do the arterial grafts compare? There is not a single trial which shows that the right memory is better than radial. Couple of them showing radial is better, majority there is no difference between the two. Compass Cabbage and the radial studies show the radial is superior, but at the RAPCO trial, the 15-year results have been published, and you can see radial artery reduced mortality by 31% overuse of right internal mammary artery. However, when you look at the STS national database, at 16 years, the two performed equivalent, and the same was the finding of Abul Hassan, who concluded the choice should be guided by patient characteristics and surgeon's preference. So if the patient has got risk of mediastinitis, then radial artery may be a better thing, but if it has got moderate stenosis, then probably a right internal mammary artery may be a better graft. Is it safe to use arterial grafting? Yes. In a meta-analysis, short-term, absolutely the same. Godino et al., another meta-analysis of 8 very high-end studies, arterial graft was absolutely safe. Tetali's large Australian database of 34,000 patients, in fact, the mortality of the total arterial was less than the non-total arterial, and that had a significant p-value. Even deep sternal wound infection in this large US study of almost 300,000 patients, there was no difference in the deep sternal wound infection even with the use of bilateral IMAs. Now, is IMA immune to competitive flow? The answer is a categorical no. As the stenosis reduces from 100 to 50%, so does the IMA patency also reduce. And it has been borne out even in the prepared force trial, where it has been shown if the stenosis is less than 75%, or if you give an additional preventive graft to the diagonal, which we used to do some time back, it predicts IMA failure. In the Compass Cabbage study, if the stenosis was less than 90%, failure rate was 8%, but that dropped to virtually half if the stenosis was more than 90%. And IMA also can go into a spasm, has been shown by a number of other studies. The skeletalization has been touted as one important measure to provide global revascularization, and it has been given a class 1 status, especially in diabetics. However, for all its advantages, a lot of people have been raising a red herring for it, that it causes endothelial injury. And it has found some clinical traction lately. Compass Cabbage study shown skeletonization increases graft occlusion and increases MACE. And even in the post-hoc analysis of the ART trial, secondary outcomes was worse with skeletonization. So we do not yet have a final word on this aspect. Can IMA be used in all situations? Certainly not. If there is proximal atherosclerosis, if you do some iatrogenic damage to the IMA, if there are dense adhesions, life expectancy is low, or the patient is in cardiogenic shock, we should not use probably the IMA. Also, some caution must be exercised, not absolute contraindication, but in morbid obesity. Our trial showed chronic obstructive airway disease and deep sternal wound infection in insulin-dependent diabetics can be much higher with bilateral IMAs. However, it can be used in high-risk clinical situation all across, no increase in 30-day morbidity or mortality with using total arterial. It has been validated in LV dysfunction, validated in diabetics to reduce long-term mortality, validated for women, and it is also indicated for elderly patients in number of these studies. So total arterial can be used in all of these. And yet with all this knowledge, there is an underuse of arterial grafting. Look at this data, relatively old, but Spain virtually, mind my words, virtually zero use of total arterial revascularization. That's the discrepancy in the Europe. And if you look at STS database, 5%, Europe 12%. And in our very own Indian result, just spoken before me, President Sajja conducted this study. Bilateral IMA were used by barely 1/3 of us in India in 5 to 10% of patients. In a UK survey carried on by Caterino and David Taggart, the reason given for underuse was there is increased morbidity, increased mortality, and proof of benefit is lacking. And I've given you so much proof. They are totally oblivious that even the guidelines give class 1 recommendation to arterial grafting. So, ladies and gentlemen, Wren et al. In a very recent article very correctly points out these are attitudinal or psychological barriers and they are not accurate perceptions and we need to, bust them. And lastly, ladies and gentlemen, some of my random rapid-fire musings will please be sensitized that the arterial grafts reduce the progression of natives' atherosclerosis throughout the coronary system. It is not just distal or proximal. We are talking of entire native stenosis or the burden of atherosclerosis that is reduced by arterial progression. We all know that complete revascularization is better than incomplete, and incomplete translates into survival loss, but arterial grafts negate the effect of incomplete revascularization, not one, multiple studies. And these are very important. A lot of us feel that we don't use them. That was borne out by such a study or survey of Indian cardiac surgeon. We have inadequate size of the coronaries. Nothing can be further from truth. Leddy et al. Have measured these sizes and shown that the arterial conduits in Indian population are of adequate size. We can't use them in left ventricular hypertrophy. Lima flow may be inadequate. Prepas et al. Has shown that the reserve flow in the pedicle IMA is more than 3 times the full myocardial blood flow that is required. More than 3 times. And if it is suboptimal targets, we should not use them. Ladies and gentlemen, when we do endarterectomy, sometimes we put a saphenous vein only patch if it is a big arteriotomy. What happens? We introduce 3 components, a native artery, a saphenous vein, and IMA. These have different compliances, creates energy losses and altered flow dynamics and increased thrombosis. It's been shown if you use an IMA arterial only, there is improved endothelial remodeling and there is increased patency. So worse the distal coronary circulation, more is the need for arterial grafting. Composite grafting has same patency as in situ grafting, and composite grafting does not reduce the patency or the flow of the inflow. Also, one must realize that left IMA-based composite grafting is better than the right IMA-based composite grafting. That is also as good as given. Aortic top ends, one of the reasons for IMA improved patency is that it's a second generation artery arising from the subclavian, hence the DP/DT is low. So when we do an IMA top end to the aorta, the patency reduces by 20%. However, for the radial artery, this does not apply and the patency is same. whether you use it as a Y or T graft, or whether you use it as a perpendicular or a diamond or a parallel anastomosis, all those are technical issues and individuals' preference. However, for proximal RCA, there is enough evidence. Early results with saphenous vein may be better, so we must have little caution that we have critical stenosis. However, here also, 10-year arterial results are better than the venous results. So to conclude, ladies and gentlemen, there is enough angiographic and clinical evidence that IMA is good for LAD. And mind it, there is a nuanced change in the guidelines. It is not Lima anymore. The guidelines themselves say it is IMA, so it could be Lima or Rima. However, for other arterial grafts, there is a lot of observational data. Randomized data is emerging, but there is quite convincing evidence that they are effective. Rima versus RA, equivocal evidence, and the myths I told you need behavioral change, and we need to make arterial grafting a defined quality matrix which should be incentivized. Only then the surgeons will take to it, and that is very important. Thank you very much.
ये भी निकाल दो वो रखो हाँ यस एक ही नहीं नॉट देयर वो ठीक नहीं आ रहा है यहाँ से ये कनेक्ट करो नहीं आ रहा
Many thanks to the organizing secretary and president and my chairman. You have been listening to many talks today, this morning, but mine would be a little different kind because I thought that I'm talking to students and they would be very, very interested in knowing the technical aspects of doing all these things. Two things people must realize is that what we are doing when a patient comes to us, he says, I have no problem. Then the question is, you have to instill in their mind one thing, that there is a debate between demand and supply. Now we are going to see that the supply is adequate so that they can meet with the demand. And the demand is when they do the exercise and all that thing. So in a resting period, many people will come and tell that they are asymptomatic. But that's not really true. Second, if once an angio is done, then I think we should stick to the angio rather than to the symptoms of the patient, because symptoms could be extremely deceiving. And I felt that as days pass by, if we have to continue in this business, and not given to the stents, we must do more and more advance in cleaning up all these arteries. And then there is nothing like that, I can't see the artery, so we can't do a graft over here, we can't do a graft there, I think it is already totally blocked. So all sorts of things we keep on hearing, but I think we should be very, very aggressive and do the necessary things. Today, as I practice, people were asking me, how many cases have you done? I said, I have not done many cases, but I can only tell you that I am practicing for last 40 years. So this is my record. So I am still practicing, and I feel that we have advanced quite a lot in this practice. Today we do most of them in a beating heart, and we do total arterial. If we require for an unstable patient, we would rather use an intra-aortic balloon. We'll rather use an intra-aortic balloon pump. Ejection fraction is not an important issue for us. I think what is more important is what is the muscle thickness and how much is the hibernating myocardium. Whatever said and done, you would increase the blood supply, whatever ejection fraction it may be, and keep the balloon pump ready. That's all. And try to do multiple areas of anastomosis, even if they are small. There are few options when particularly depending upon the size of the septals and the anatomy and the diffuse nature of the disease. We have multiple options for LAD particularly that we can anastomose to the distal and then do all endarterectomies on the proximal area and keep the last proximal loop intact. Now it is something like this, that we have kept the loop over here, and I think I will use my oh no, it's not working. Anyway. Here you can see over here, I don't know, no. Anyway, the second option is that we perform a sequential You can see over here that we have done the proximal, the distal LAD with the internal mammary artery, and here we have taken the two loops and we will open up the proximal and do the endarterectomy. With this, if you maintain some kind of balancing situation, then you can keep on taking up all these diffuse disease patients and do a cleaning up of all the jobs. The next is we sometimes do all the jump grafts into the diagonal so that the LAD is free for us to do a endarterectomy and do a direct closure. Here you can see over here that we hardly see Another is to make a long arteriotomy, split the plaque and do it. We should see to it that we maintain a certain amount of circulation on the anterior surface if you are doing a on-pump, off-pump bypass surgery. And if our arteriotomy is a long one, then many times I join two shunts. Like here, we are joining two shunts. Here we are joining the two shunts. And then we can get a long shunt also. So never say die. There are methods of handling how you have to go ahead with making a long arteriotomy and do an endarterectomy or an onlay patch. Now here you see me making a long arteriotomy. it is no good telling that let us find out a soft spot and do it. I think we should open it up fully. A lot of septals will get opened up. And you can see over here a septal is bleeding from here, a septal. Be prepared to lose a little blood. Don't be absolutely restless about little bleeding here and there. And tell the anesthetist that there will be a little loss. So here we will be putting a long shunt. See, there is a little bleeding, but we are not bothered about it. We have to split it up and see the two RMI shunt is being put over here. I don't put a vein graft first and then put an internal mammary. I would rather split the internal mammary and put a long patch graft with the internal mammary artery. You can see over here the patch, this will look practically the same, that there is not a difference. This is what I have already mentioned. Now here you can see over here again another picture of the shunt. You can see over here the shunt. You can see the shunt over here. We better learn this, otherwise we will be without business, because the cardiologists are going to block all of them right and left. Arteries are going to be blocked. We have got to be bold enough to attempt cleaning up these vessels also and do an endarterectomy in these areas. And it is sometimes you will be so happy with the opening you will get out of taking out a whole internal whole of the stent out, but sometimes you may not be. But I think it is worth trying it at least. And nothing will happen if you have adequate distal flow in the LAD. Next, you can see over here how we have cleaned up the native vessel here, and this is the internal this is the stent which has come out, but not very nicely. Sometimes you will get a stent coming out like this, but then we keep on attempting to do everything to see that we clear up the vessel. This is that last one. This is rarely you will get a situation when you can clean 2 or 3 septals and get an LAD clear up like this. But here again you see that you have got the full stent out and you have got the intima as well, the disease part of it. Many a times these diffuse disease patients require multiple endarterectomies. Don't be scared of it. I think we should go ahead and do it. The only thing is that if it is not a complete one, then you are in trouble. Now here you can see over here that to make it a complete one, I have made another arteriotomy and then again taken out the rest of it. So you would have to do it many times, that it is an incomplete one which is coming. Please complete it, otherwise you are in a trouble again. If you enter into this game, you have to be ready with a lot of patience and that you are going to do a complete job. If we establish a distal flow first and then do all these things in the proximal area, you are very, very safe. Now, we believe that the diagonal God has given us and it has also a role to play, and it is not that the diagonal is blocked, so let us do one LAD and then skip off and start doing the OM. We must at every stage when we take up a diffuse disease try and handle all these properly. Now you can see over here, what I want the people to realize is that you have to roll over, gradually do this job. Don't just pull it, it will never come out like that, it will break. So please have patience and gradually keep on pulling it. You would see the side branches opening up. And what is important is that sometimes, see how we are doing it? We are rolling over the whole of the tissue over this. And then you may have to apply a little counter traction, and then a tapered end will come out. You have to have enough patience to do this job, and then you can do the grafting. I don't know why this color has come. Oh my God. Why has this color come? It's okay. Now here, again we have got a diagonal. We would not just leave it like that, because otherwise there is hardly any vessel you are given to bypass. So patient had all these vessels opened at one stage in his life. So let us give him an adequate revascularization and take care of every of these vessels. So see here again we are removing it and giving a little counter traction to the whole thing. See the counter traction we are giving. We have to be extremely gentle and keep on giving counter traction, and then keep a very gentle pull on it. You would in that case try and get a full single piece out. Otherwise, if we just keep lose our patience and pull it, we will be in trouble. It may take you a few minutes to do it, but please have patience. Don't just pull it off like that. Here you give a counter traction gradually. I'm showing you this so that don't get disheartened. You will also get long arteriotomy. A single piece, you can take out the whole of this. See, the diagonal has come out beautifully. Also, I wanted to tell you, I won't show you the full surgery, but I will just take you to we make a fairly large opening and make a Y graft over here. Here I want to show you how we do the obtuse marginal. Here there is an here you can see that this is an intramyocardial LAD which we have dissected. Here again the trick is you must gradually, very gradually tease the muscle fibers above and take out the muscles which is covering the LAD. Rarely you may go into any of the chambers. If you by chance go into any of the chambers, please put a small fat lobule and take a stitch to close it with a lot of fat, and you should be through. Mostly the danger is opening the right ventricle. Here I want to tell you that when you are doing the obtuse marginal or OM branches, we must keep the pull on the vessel in the direction of the artery. Like, when you make an arteriotomy, don't pull it out immediately, the obtuse marginal, because it must go in. If you are doing the proximal, it must go distally. You must keep the pull properly. In the right coronary artery, many times I think we always choose to put it in the posterior descending. Here it is an obtuse marginal again. So the pull is, see the obtuse marginal has been opened up. And gradually again keep on pulling so that you can get it out in a single piece. Once again the distal area is cleaned up with all its branches. In the right coronary artery, we believe that we can put a graft into the PD, and after we have put a graft into the PD, we can clean up the crux. With this, you would get both the PD and the PLV branches opened up, and the crux can be directly sutured. And the graft is already done in the PD. We have anyway, we have started doing, if there is no clot, then we believe that we can do even linear aneurysmography by this method. Here I would like to show you that even in an inferior aneurysm, it's not opening, I think. Most of the surgery these days I am doing is on beating heart. And whenever I need for pressure and all these things, I would use an intra-aortic balloon pump and do this surgery. Thank you very much.
Thank you very much, Dr. Bhattacharya, for sharing your experience. And the next is going to be Dr. Kunal Sarkar. He's going to give us a talk about trials, post-syntax, implications in our current practice. And we know that a lot of controversies have been raised in the parliament currently regarding the syntax trials and the indications for coronary bypass versus PCI, raging controversy going on all over the world. And every week we are getting new reports about the superiority of the CABG over PCI, etc. Over to you, Dr. Kunal Sarkar.
Could we have the slides up? Yeah. Well, thank you very much to the organizers. It's a very humbling opportunity. And after the fantastic set of speeches and a great set of exposition of skill by Dr. Bhattacharya, we again come back to the political history of coronary artery bypass surgery. It's got a lot of special effects on over there. Okay. Right. Looks better. Okay. Thank you. So quickly, I think a lot of it has been already repeated to you. It's not. Okay, all right. How do the slides go? Boss? Slides are not moving? Oh, it's working. Well, you see, I mean, we won't spend a lot of time on history. It was about 600 years before Christ that some chap called Daniel, was studying the effect of vegetarian diet versus meat-eating diet, which is supposed to be the origin of clinical trials in history. But fair enough, we've come a long way from that, and we quickly look at these set of questions. The ongoing debate, or rather the sibling rivalry between PCI and CABG, where do we stand today? Left main revascularization has created a lot of noise. Where does that stand today? Have we made up our minds regarding the use of conduits, and is the on-pump, off-pump debate still on? Now this sibling, I'm okay, don't. Not necessary, this is a pretty low-tech presentation, thank you, yeah. So, all these things basically started when all over the world, at different spans of time, with the evolution of the drug-eluting stents, you had CABG being resoundingly taken over by PCI. Now, in the pre-Syntax era, what was happening politically in the background? You had a whole buckets of trials coming on, and each and every one of these trials, they set out to look at things like repeat revascularization, myocardial infarction, and they all ended up concluding that the mortality rates were equivalent because obviously repeat revascularization was much higher. So this was a complete set of academic skullduggery and confusion, and in that setting lies the importance of syntax. So we are supposed to go to the post-syntax era, and syntax sometime in the year 2014-2015, having started off in 2005, it leaves us with a set of impressions saying that in complex triple vessel disease, coronary surgery did better in terms of, repeat revascularization, infarcts, MACE, and etc., etc. Now, when we, it's like the post-truth world. When we talk about the post-syntax world, we quickly run through a few other data sets. Now, the FREEDOM trial, which primarily looked at a large number of patients with diabetes, is not purely post-syntax, but what it is there is a lot of time overlap, but it looked mainly at the diabetics. What was the conclusion of FREEDOM? Now, FREEDOM trial, it is a misconception. I've heard a lot of cardiologists say this, that FREEDOM trial did not look at the syntax score. That is farthest away from the truth. FREEDOM trial basically found that CABG outcome was better irrespective of the syntax scores, which is totally different from saying that FREEDOM trial did not look at the syntax scores. So there is an essential difference in this. This fellow is not working still. After FREEDOM trial came something that was called FAME-3. Because by this time there was a bit of whispering going on in the cardiological community that if we revascularized more selectively with the use of the FFR, then the PCI outcomes will be better. That was FAME-1, FAME-2, and they wanted to extend the same idea to CABG. They compared FFR-guided CABG to FFR-guided PCI. And this trial, I'm not going to run through all the numbers, look it up. Basically, in terms of repeat revascularization, MACE events, CABG outperformed, FFR-controlled CABG outperformed FFR-controlled PCI to such extent, FAME did not go through their entire set of recruitments. But it was true that if you looked at the MACE rates and the repeat revascularization rates with FFR, they were slightly lower than the syntax trials because obviously you were revascularizing lesser vessels. So at the primary endpoint, even in FAME 3, they had, they had to kind of swallow a humble pie because a lot of them were cock-a-hoop with the idea that PCI is going to show better results, but it did not. Then you had Dr. Kim. Dr. Kim is to PCI, is to, what, he's like the Taliban of angioplasty. He believes that the only contraindication to an angioplasty is rigor mortis. And in that setting, Dr. Kim had this trial called the BEST trial, and it is the first time that he even admitted defeat. An 11-year-old trial was stopped at 2 years. So the BEST trial, you don't hear a lot of good news about the BEST trial, was stopped at 2 years because well within 2 years in triple vessel disease, the grafts were diverging. Fair enough. But once Dr. Kim, the Ayatollah of PCI had to take a back seat, then came on something called syntax at 10 years. And that was called syntaxes. Now, it was not the same group of people doing it. It was separately funded. And all they wanted to say is, after the 5 years incremental mortality of syntax, the mortality graphs were really now beginning to hug and kiss one another. Fair enough, whether you are a part of a trial or not, it is difficult for a person to die twice. A set of people have already died at 5 years, so they could not, for the sake of academic completeness, come back at 10 years and die again. So it was quite natural that all the incremental mortality was taking place between the time window of 3 to 5 years, and hence it was automatic that at 10 years, your survival grafts will tend to come nearer one another. It has taken me a long time across 100 meetings to convince the cardiologists of this plain truth. Now, consider this situation. This is pretty critical. Now, in all this academic turbulence, we move over from the 2011 guidelines to the 2018 guidelines. So till 2011, LAD was holding on to it, proximal LAD was holding on to its surgical preference. By and large, triple vessel disease was holding on to the surgical preference. So in spite of the fact that through syntax, through FAME, through BEST, you did not have comparable performance with PCI. Remember, the door was kept a little bit open for non-complex triple vessel disease. And through that door slipped in your 2018 guidelines. So in the 2018 guidelines, what affects us today is the 2018 guidelines that proximal LAD was given the green flag for PCI, and non-complex triple vessel disease of lower intensity was kind of waved the green flag for PCI. Now, who rates? Who does the syntax score? Who distinguishes the complex from non-complex? That has gone for the toss. But before, a kind of segment of triple vessel disease was opened up for PCI is something that has changed practice. Ischemia trial, we have spoken about it before in the post-syntax world, was honestly speaking a crazy, crazy academic happening, because so far it was a kind of sibling rivalry between the stent and the surgeons. And now the tablet has come in between. If you have to understand the politics of ischemia trial, it is the tablet community which is coming into the stent community and the surgical community, and on wafer-thin thin evidence. Based on wafer thin evidence, ischemia trial did a whole lot of outlandish things. They took down the recommendation for CABG in stable coronary disease. They downgraded the indication for CABG in compromised left ventricular function. And like the rest of the world, who completely, rubbished the findings of ischemia trial, IACTS also joined in. I'll show you the substance of the paper. And the limitations of ischemia was a short-term trial, under-enrollment. CABG and PCI were given a kind of clone definition of revascularization, and based on which very overreaching and far-reaching conclusions were arrived at. And IACTS, led by Dr. Yadav, gave a very, very, very tacit, very terse kind of rebuttal to the ischemia trial. Read it up if you've got a minute. Where did we come on to left main? Now, left main has been a lot of water under the bridge. The cardiologists were basically itching to come into left main. And Dr. Stone has now, whether you call it famous or infamous, it is more infamous than famous. He came up with 5-year data of Excel trial, which basically said that your all-cause mortality, your endpoints were comparable. They were obviously not. There were 3 problems with Excel trial. One, the surgeons were stupid enough. Half the people in the trial committee were surgeons. They conceded to the fact they did not include repeat revascularization in the beginning as one of the parameters. Then, halfway through the study, the definition of periprocedural MI was changed. There was selective enrollment, and when people looked under the bedsheet, they found that even mortality reporting was very, very insincere. An Excel trial did not find a lot of credibility. Yes, it found a lot of noise, a lot of discussion. And almost happening in tandem with the Excel trial was the Nobel trial. And Nobel trial for left mains looked at repeat revascularization and came to an entirely different set of conclusions, saying that obviously CABG was giving the better outcome. Is on-pump, off-pump an issue anymore? The short answer to it is no. And some of the data which has come up on the on-pump, off-pump world, especially the Ruby at 10 years, honestly has not done off-pump a lot of credit. And if off-pump has to look anywhere for a bit of surgical support, it has to look to India, because the promote data as submitted by us, which is now more than 5 years, was the only angiographically supported data which said that, look, we were giving comparable results. OP and others have referred to it, the great conduit confusion. There are 2 great warfares happening in the world right at this point of time. One is Putin versus Zelensky, and the other is David Taggart versus Andre Lamy, because this kind of conclusion of the superiority of bilateral mammary, which was primarily based on non-angiographic survival data, now looks highly vulnerable. RAPCO trial already showed us that REMA was performing better than the radial. ART, which has been referred to over here, was a kind of academic failure in trying to prove that bilateral IMA was better. But the kind of bomb explosion which has happened in the last few months is the post hoc analysis of the COMPASS trial. And in the post hoc analysis of COMPASS trial by Lamy and other investigators, more than 3,000 grafts were studied angiographically, and that showed a 26% occlusion of right internal mammary, 10% occlusion of saphenous vein, 9% of radial arteries, and 6% of lemma. And they have, I don't know, but they really seem to have gone out with a mandate and analyzed that what were the problem rates of the right internal mammary in all these locations. in the right artery, in the circumflex area, in the RCA, as in situ, used in continuity, and in every formation. Look at the figure, read up this paper. You will really can't sleep well at night if you look at the rather sad set of occlusion rates, graft patency rates for right internal mammary. This is bad news, and this is bad news for the bilateral IMA lobby. I'm sure a lot of conversation, a lot of stones will be pelted at one another, and let us look for where the academic equipoise stands. What is the state of today's practice? Now, when we look at the impact of trials on practice, look at this thing. This chap is working. Now, if 5-year syntax did not come out, if 5-year syntax did not come out, for sure this would have been the trajectory. This is STS database. This is STS database, the number of total procedures and the number of CABGs happening from 2010 to 2019. So if the 2014 to 2015 data of syntax at 5 years did not come out, then CABG without a doubt would have headed southwards and would have crash landed, God knows whether on water or on land. But it is managing to hold itself. 2019, 2020 data is a bit confusing because of COVID. So STS shows that they are kind of holding on to 1,60,000 to 1,64,000. But you know, with the mixed practice of United States, they seem to be holding on. But what is concerning is the data which is coming out of Europe. The data which is coming out of Europe shows that in spite of whatever the 2015 syntax did to you, their numbers, this is the British database, this is the Spanish database. These two countries do a fairly good job of keeping on their scoreboard. The numbers heading southwards, both in UK and in Spain and in Europe, where you have a fairly well-monitored national health system. Why is this happening? I'm not entirely sure. So compared to the North Americans, the Europeans are not managing to hold on to the numbers, and if you analyze this decline would almost reach 5 to 7% per annum. So there is some food for thought over here. This is a slide borrowed from Dr. Meherwal. We cannot in India, based on a credible set of figures, give you a trend over the last decade. But this is where our numbers are. We are kind of hanging on to our numbers. Are we hanging on to our numbers because we are competing in an uneven field, mostly propelled by the low-paying scheme patients? We are not sure. Because when you compare apples with apples in a same set of reimbursement mechanisms, would CABG in India be hanging on to its numbers is a really a very critical question at this point of time. So how do I see it? How does it stand at the point of time? We have to stay content with the fact that with PCI having grasped some of our territory in the triple vessel segment, CABG is definitely left doing the heavy lifting. We are left with the rough end of the stick. We are left with complex disease, and we are left with 25% of the pie. Because even in India, with whatever eyeballing you do, the ratio today stands somewhere around 1.4, in some regions to 1:1.25. So we are left with 25% of the pie. We are doing the heavy lifting. Probably left main is mainly in the surgical domain. As far as angiographic data is concerned, the RITA or the RIMA lobby is in deep trouble. And as far as the global practice is concerned, each country has their own ratio. Off pump, on pump is not a big issue. Thank you very much. Thanks.
Good afternoon, everybody. Dr. Kunal Sarkar, your slides are pretty frightening, but well, let's hope that it doesn't go down the way you're saying. Ischemic mitral regurgitation has been my passion, and 20 years ago, or maybe more than that, I started doing a lot of patients with left ventricular dysfunction, and we had poor results, and we used to see that, we didn't have so much echocardiography at that time, but we realized that ischemic mitral regurgitation and need for left ventricular restoration were two procedures that possibly could have changed outcome in many patients. And that is when I visited Netherlands once, and I saw Dr. Steve Bowling and the geoform ring, and I realized that maybe that makes sense, and we should do something to the MR that is there in ischemic patients. Over the years, I've done maybe 600, 700 repairs for ischemic mitral regurgitation, but I have great regret that I don't have all the data together that I could put up a big paper. Recently, I do have one, and I'll show a little bit of that too. Now, ischemic MR is a very bad pathology, and if a patient got severe mitral regurgitation and nothing much is done for it, the mortality or the survival at 1 year would be only 30 to 40%. So MR is something that we have to take seriously, and right now there is not much cardiology intervention except the mitra clip to correct it, and if Dr. Kunal is right, I think all these plasties will give a lot of inferolateral myocardial infarctions in time, and we may see a lot of MR which will need to be corrected by surgeons in the coming years. So what happens if there is inferoposterior myocardial infarction? The posterior papillary muscle moves downwards, there is stenting, and there is development of mitral regurgitation. But mind you, nothing happens to the leaflet. The valve is absolutely okay. It's only the movement of the papillary muscle that leads to the mitral regurgitation, and the increase in LV size that causes the problem. So this is something that can be corrected without too much trouble. Now, what happens on survival? Multiple papers have shown that if there is a myocardial infarction without MR and a myocardial infarction with mitral regurgitation, the survival in patients with mitral regurgitation is going to be very less. They have a high mortality rate in the years to come. Hence, it proves, or it says, that something has to be done for mitral regurgitation. So how do you address mitral regurgitation? There are many things that you have to consider when you think about treating mitral regurgitation. The first is, what is the effect on long-term survival? If you correct it or don't correct it, what will happen to the patient? Next would be that challenges of intraoperative assessment of MR. Many times what happens is, preoperatively you see severe mitral regurgitation on an echo. Then you do another echo, it will become moderate. And you come to the table, there is no mitral regurgitation. So mitral regurgitation is very dynamic. It depends on loading, fluid status, contractility, drugs, treatment, everything. Then what if you do only CABG? Revascularization, controlling ischemia can influence mitral regurgitation. And at the same time, you have to wonder, what if I don't correct the mitral regurgitation? On the table it looks okay, but post-operatively will it recur? So multiple things come into play when we think of treating ischemic mitral regurgitation. So it's everything you have to look at: the LV, the ischemia, the size of the heart, the leaflets, the way the papillary muscles have been affected by a myocardial infarction. So there are multiple things. And then, like many other things, the battle comes in: repair or replace. So what should we do when we think of treating ischemic mitral regurgitation? One, of course, we know patients would need revascularization. Second, that the mitral annulus will need an restrictive annuloplasty. And at the same time, you may need to do some subvalvular surgery like chordal cutting, or maybe neochordy if there is a rupture chordy. You may need to do some Alfieri, and ventricles, if they're too dilated or too bad, then you may need an associated ventricular remodeling procedure too. Now, to do all this, one needs very good echocardiography, especially if you're going to do treatment for ischemic mitral regurgitation. Echocardiography is the mainstay. You have to keep repeating echoes, have a good look at an echo before you take a decision. You can have a small heart with good muscle and severe MR. Those are the ones that definitely would get okay with the revascularization. But if you've got a huge dilated heart, a large LV with a lot of tentacle leaflets, thinned out papillary muscle and infero-posterior scars, then these are the ones that are unlikely to get better with just simple mitral valve or just simple CABG. Again, one also has to look at chordae, ruptured chordae, what's the leaflet motion, is it purely restrictive or is there prolapse of leaflets? So I think a good echocardiogram is one of the most important things, or it's the mainstay of treating patients with ischemic mitral regurgitation. I'm sorry the echoes are not working, there's something wrong with the connection, but MR moderate or more than moderate is something that you have to take seriously. But at the same time, look at the size of the ventricle, look at the tenting, look at the annulus. You have a patient with ischemic mitral regurgitation and an annulus is 28. There is not much you can do for it until unless there is a leaflet rupture, a caudal rupture. So one has to have a very good assessment on echo before you think of treating ischemic mitral regurgitation. Of course, one of them is working, but I don't know why the green color. And repairing these ischemic mitral regurgitations requires a ring, and if well done, it can change the outcome of the patients. One more important thing is, we always believe that ischemic MR is like the pressure cooker whistle. It releases the pressure of the heart. MR never helps a patient. MR begets MR, and if you leave MR alone, the heart will dilate and the MR worsens. So a decision to correct an MR at times may be better than leave it there. So that is something we always have to think about. I'm sorry for the color. I don't know why it's happening like that, but these are the preoperative and postoperative echo pictures. So is it only about surgery? At the same time, if you're going to treat ischemic mitral regurgitation, one has to treat these patients preoperatively. Sometimes just a little dehydration, proper medication can take away the MR, and these patients don't need correction. So don't take a patient with ischemic MR who just walks into the hospital and put him on the table and say he needs mitral valve repair. Optimize the treatment, look at the MR, and then only intervene in these patients. So they need beta blockers, nitrates, dehydration, Millicor in preoperative times also. And if required, an intra-aortic balloon pump. If we place an intra-aortic balloon pump, it will reduce MR and change your judgment as to what to do. So an echo should be done before an intra-aortic balloon pump is placed to decide whether you want to treat it or you don't want to treat it. About surgery, many people say that the left atrium is very small when you are going to do a repair for ischemic mitral regurgitation. That is true. And I personally have been, a proponent of going trans left atrium only. I don't do septal superior, whatever the size of the left atrium is. But I make sure that I dissect the SVC, IVC totally. I go through the interatrial groove as much as I can. And also I see that the pericardium on the left side is totally released so that the heart drops down. So the heart should rotate downwards if you're going to have a look at the mitral valve when you go through the atrium. Why? I don't do transeptal because that takes time. These patients are ischemic, they are sick, and you want to keep the cross clamp time down. I also use a two-stage cannula, simple two-stage cannula, a good opening in the left atrium, and slowly you can take stitches and do it and do a correction of this particular pathology. I'll show a little bit small video on it. This is through a simple transatrial approach. Once you start taking stitches near the P1, you can keep pulling them up, and that way you can, go around the annulus totally. And this is something that I have done. I don't know. It's just going black on its own. There's nothing I can do about it. Well, sorry about that. I don't know why it's giving these colors. Yeah, it's moving here, but it's not moving there. So it just shows like photographs. So this way all the stitches are placed all around, and then most of the times, I'm honest, put the stitches, it takes 15 minutes, put a ring, it takes another 15 minutes, and in 30 minutes you can put the ring down and get it corrected. 80%, 70% or 80% of ischemic MR just needs a ring, that's all, nothing more than that. And that takes half an hour of extra clamp time, and I don't think that is too much. वो चल रहा है यार, कुछ उसका और प्रॉब्लम है वीडियो का आपका कंप्यूटर के साथ. So that's how the ring is placed, and then just test it. Most of the time it works. So this approach can be used if you want to. You can go transseptal. Oh, now it's totally gone. Post-operatively, these patients need a little extra ventilatory support. They need inotropes and at times intra-aortic balloon pump too. After surgery, do an echo pre-discharge, and I always try to put them on ARNIs nowadays for better long-term results. What is very important is how to treat them. One must realize that the anterior posterior diameter goes up, the P2, P3 comes down, and any ring that we place has to be such that it reduces the AP diameter. Two very important things about putting rings in ischemic mitral regurgitation. One, it must be a complete rigid ring. Flexible rings are associated with high recurrence rate of MR. And second, downsizing is very important. And this was placed in the guidelines also. Complete rigid undersized ring for annuloplasty. So undersizing is very important. For example, if you think okay, the 28 size is okay, go to 26. And most of the times, most of my patients get a 26 size rings, and the long-term results are very good. Many rings have come for ischemic mitral regurgitation and gone out of the market too. IMR McCarthy, IMR Etiologics was very good. It had a P2, P3 that used to come in and was very good for correction, but somehow it's disappeared. There was the geofoam ring. I must have implanted maximum number of geofoam rings in the world, but somehow that also got withdrawn. And nowadays I've been using the 3D profile ring, and that's been giving a fair enough results. So that brings us to the question, why should we repair ischemic mitral regurgitation? Does it really improve the long-term outcome or otherwise for patients? Yes, this is the data from, this is a very nice article on predictors and prognosis of ischemic MR. And that shows that if the ERO is more than 0.2, then the mortality over time is much more than if the ERO was less than 0.2 centimeters square. Hence, this makes a case for correcting. Many data, a lot of data has come around that ischemic mitral regurgitation leads to early mortality, poor outcome, hence the correction is necessary. And repair of this, repair of mitral valve shows an improvement in NYHA class. Many patients, you can do CABG, send them home. If they have MR, they may not have angina, but they'll still have breathlessness, and which is not good. And overall, over time, they will have deterioration of LV function. So that's not a good idea, and they worsen. So correcting it shows improvement in NYHA status too. Also, what is very important is reduction in LV size. Imagine the preload that an MR gives. So all that blood just going back and forth because of an MR, even a moderate MR, is too much for the heart to handle. And MR worsens MR. Over time, the LV keeps dilating. Whereas if MR is corrected, the LV diastolic and systolic sizes go down, and that also improves the ejection fraction of the patient. So it is very important. I personally believe there is nothing worse than MR in a patient with ischemic heart disease and LV dysfunction. They're the worst. The LV thins out and the patients die. A lot of meta-analyses are there which have shown, this is a big meta-analysis that shows that if you repair it, then the results are better than replacement. So now it comes to whether to repair or to replace. And they've shown in a 30-day mortality was 5 with repair group and 13 with the replacement group. So multiple big meta-analyses have been done which shows that repair is better than replacement. But, and this is by Vasila et al., who showed that early mortality was 2.5 times greater in replacement group than repair group. And it also shows that survival is better in repair than replacement. So there was a lot of data in this area. Then suddenly one paper comes up called the CTSN network, that was Cardiothoracic Surgeons Network Trial Group, which suddenly brings us up to a point that says that initially repair is better, but over 2 years, the repair mortality and the replacement mortality match up. And there started the big controversy, whether repair is good or replacement is good. So this is what Acker et al. Had said, and they said that patients ultimately had recurrence of MR, they did not do well, and there was more mortality and replacement is better. But this was contrary to most of the data around the world that showed that repair is better. So now we come to a point, what is better? There is this very wonderful debate written by Rankin and Bhadawar that I suggest if you want to read about repair and replacement. This is some paper everybody should read. And here he says that, like, for example, the Duke's data showed that in CABG, if repair is done, the survival is better than replacement. So what happened in the CTSN network trial? As a paper, it was good. It was a randomized trial. Everything was done all right. But it is seen in this particular paper that there was a 32% post-repair MR recurrence in the first postoperative year, which is not acceptable. So these people had a very high recurrence. So who and how is the repair done is very important. This is comparison of Duke series and the Acker et al. Series, which the red one shows that the mortality is going up in the repair patients, whereas the Duke series does not show such a high mortality going up because their repairs must have sustained. So, end of the day, it is like that repair gives survival, replacement is associated with mortality, but repair works only if it is done properly, like caudal sparing, caudal cutting, proper leaflet correction, correct sizing of the ring. Everything is important. In the Acker et al., that is CTSN network, the size of ring used generally was 28. It was not even sure whether they did a reducing annuloplasty or not. So how the repair is done is very, very important. And they say that the mortality cost seems to be associated with mitral replacement, whereas repair failure is likely a surgically controllable phenomena. Hence, if the repair is done well, then the results will be good. If the repair is not done properly, then the results will be bad. So whether replacement or repair for IMR will depend on who and how it is done. But replacement will be with mortality and repair will not be with mortality. I will skip a few slides for the want of time, but ultimately recurrence depends on how well the repair is done, and replacement is always going to be with higher mortality. This is the guidelines, and what is interesting to see is in 2016, the guidelines said that if there is an inferoposterior aneurysm, then one should only go for replacement and not repair. Whereas in 2017, that has changed, and it is said that you can use caudal sparing techniques, certain caudal sparing techniques, try to do a better repair and try to do a repair if possible as against replacements. So maybe the world is seeing better results with repair than with replacement, hence the change in guidelines. A few more slides. We've done something like 295 repairs in 3.5 years at our hospital. This data is yet to go in for publishing, but I'm very seriously writing this paper right now. And we had 295 repairs, out of which 219 were for ischemic pathology. That multiple type of diabetes, hypertension was common in patients. We had moderate MR in 10% patients, moderate to severe in 3%, and severe in 86. Like 86% patients with severe MR. And after surgery, we had severe MR only in 2%, or moderate to severe totally in 2%. So we had excellent early 4-year results of patients, and there was, most of the patients were in mild and moderate MR only. And their ejection fraction also showed significant improvement. Patients did well, 100% at annuloplasty, and there were multiple procedures also done for patients. And in this whole follow-up period, 23 people died throughout early and late, and our mortality was around 10.5%. So I will end my talk by saying that repair ischemic MR or MR must be attended to. If it's a sick heart, there is MR, correct it. It takes 30 minutes, that's all. But do it. At least do an annuloplasty for them and see what happens. But MR should be corrected. It will change the outcome, and it is the best way to learn mitral valve repair, because it's a very simple procedure to do. Put a ring in. Take the patients that have simple problems initially, and as you go by, you can take ones that have complex. But correcting MR changes everything. Thank you very much.
Thank you very much. Excellent talk and fantastic results. Thank you very much. So now we come to the conclusion of the session.
Thank you, sirs. May I just request you to...
Time what is it? 45 minutes late.
We are running very late, sir. So can we continue the discussion over lunch?
Sure.
So my suggestion is, sir, I request you to present the mementos to our speakers. Dr. Lokeshwara Sajja, please can you come on stage, and Dr. Bhattacharya. Dr. Yadav, Dr. O.P. Yadav, Dr. Kunal Sarkar, and Dr. Anil Jain. May I request Dr. Tyagarajan and Dr. Muthukumar to present the mementos to our speakers. Dr. O.P. Yadav, sir.
Oh, yes.
Next generation.
Just stay on. Lokesh,
Now this will be very strong.
Dr. Kunal Sarkar.
The second time around photo.
Dr. Anil Jain again. Sir, may I request you to come and take group photographs? Just group. Thank you, sirs. May I request a group photograph of the moderators and the speakers? Thank you, sirs, for this wonderful session on coronary arteries. We move on to our next session before lunch, which is on aorta. May I request our moderators, Dr. Prasanna, Dr. Rajkumar Yadav, Dr. Rajkumar Yadav, Dr. James Raj, Dr. Mrityunjay Kalmat, please do come on the stage, sir.
Loaded? Yeah.
Loaded?
Yeah.
See the pen drive and play.
What time? This is backward. Okay.
Slide is not changing. No. Yeah. Highly complex procedure. As somebody has said, when I touch the olden days, I was saying, when you touch the aortic arch, the soul leaves the body. That used to be so mentioned earlier, but as we all know, it has gone in a long way. Even now, the open surgery is carries little higher risk than any other procedure. So this classification is from the Penn classification, where supraaortic debranching is done in distal arch aneurysms. Type 1, when we do the grafts into the neck vessels with or without opening the sternum. Type 2, when the ascending aorta is replaced with a synthetic graft, so that the landing zone is in a synthetic graft when there is ascending aortic dilatation or whether there is atheromatous disease. And type 3, it could be a frozen elephant trunk as we do now, or initial debranching plus arch replacement and endograft done at simultaneously. Because this is a type 1 without sternotomy, you can see a distal aneurysm, which is, we did a carotid and carotid subclavian, a simple procedure. And this is an angiogram done after about 8 years. There is another one where we do a arch debranching with a sternotomy when the aneurysm is big, when patient is not fit for a open procedure with the circulatory arrest. This angiogram, this is also another patient who had a coronary bypass surgery done about 15 years ago with all grafts functioning with the distal aortic arch. You can see the functioning. Where is the pointer? Yeah, this is the carotid and carotid subclavian bypass, and that is a Cook stent which has been put. This is another patient who had a renal transplant. You can see the kidney functioning here. She was operated almost 12 years ago. She underwent a second kidney transplantation after that. So these type of patients, it's a very effective procedure without less morbidity and mortality. And this is another patient we have done recently where the ascending aorta was dilated and there was atheromatous disease in the ascending aorta. You can see there is a wrapping here done. When the ascending aorta is dilated and the patient is not fit for a cardiopulmonary bypass, you can wrap the ascending aorta so that the landing zone will be there. So in type 2, the Dacron is used to replace the ascending aorta so that what happened?
I think that connection is loose up.
There's a video is coming. Yeah, okay. So here we create an ascending aortic synthetic zone with a synthetic graft. One of the problems, as we know, when you're landing the graft in the native aorta is retrograde dissection, especially in patients with connective tissue disorders. This is a patient who had ruptured sinus of Valsalva with aortic incompetence and a type B aortic dissection. We did still again is going. Just see what is happening. Video is not, yeah, just I'll have to hold it or something. Sorry. So we did a aortic root replacement. You can see in the post-op CT aortogram, we did a ascending aortic root replacement, arch debranching, and endograft. He is being followed up for the distal aorta screening. He definitely will require a secondary procedure later on. This is also another patient with the same type 2 hybrid with ascending aortic replacement. Another patient, same. Most of these patients undergo a CT aortogram once a year, first year, and then we usually follow up after every 5 years. Repeat CT is done to find out the distal aorta. This patient came with a leaking type B aortic dissection. So it was a Marfan syndrome patient, so we had to do it in a hurry. We didn't have the endograft available, so we did an arch debranching and did a endograft on the same day. Fortunately, she is living almost 8 years, even though she is Marfan's. Definitely, all these distal aortas needs some sort of surgery or endovascular procedure in the future, especially those with connective tissue disorders. Open surgery is better. So the problems of antegrade, the type 3 DVAR, the next is type 3 antegrade TVAR. That is where we replace the, my God. Yeah, I think I have to keep holding. Yeah, in this technique, what we do is, I don't do it nowadays because the frozen elephant trunk graft is available now. When this was not available, we used to, can somebody hold this please? It's wasting time. Yeah, no. Is it coming?
Take 1 minute, 1 minute.
Nothing is happening.
Put it back. Put the old thing back if it's not working. And so somebody hold it, please.
Put the old connection, please. It's a waste of time. Will work. Up. Thank you. Sorry for it. So this is antegrade TVAR done with two separate. You do the arch replacement first, and then either on the table we first do the antegrade deployment of the graft is done first, followed by arch replacement done at a circulatory arrest. So first we do the pass the guide wire, especially in dissections in this graft. Otherwise, most important thing is to put this graft into the true lumen. So after passing the guide, it is important to give anticoagulants, very important, because one case we didn't anticoagulate the patient after putting the wire. There was a lot of clots when we opened the aorta. So give heparin about 1 milligram. Then pass the guide wire after that, and afterwards we do the go on cardiopulmonary bypass, depending upon where the heart is adherent to the sternum or not. And in this patient, we went on bypass and only did the stenotomy because the aorta was very close. He had a ascending aortic replacement for aortic dissection done elsewhere, and you can see the graft kinked, in the previous surgery. So we did axillary artery and femoral cannulation, that is the opening the graft after giving cardioplegia. And we use as you know, the fluoroscopy monitor from the orthopedics department we borrow for passing the guide wire. And when you open the aorta, you can see the guide wire. After that, the temperature is cooled up to about 24 degrees, and you clamp the innominate artery, and always we do bilateral carotid perfusion. Most of the cases we do that. The Foley's catheter is in the subclavian artery. The next step is to prepare the distal aorta. This particular procedure, this was done about almost 10 years ago. I don't do this now because the FET graft is available now. When the FET graft was not available, we did almost about more than 30 cases with this technique, which I will show the data later on. And after preparation of it's a very laborious procedure. You antegrade, you deploy this graft. First of all, these grafts are not made for dissections. Actually, it was the only one available. We had some problems with this graft. So the distal aorta behaved badly, a couple of cases. Now, when you release it, you can see the barbs projecting. You have to cut the barbs, then fix the distal aorta, and then put the arch graft. Then we suture it, and then that is the postoperative result. I'll go to the next one because of lack of time. So these are a few of the cases which we have done before the FET graft was not available. This is actually patient had a root, arch, and elephant trunk. This also same. Patient who had a coronary bypass done, came with aortic dissection, and we did the same procedure. That's also same post-op picture. Now with the Evita, earlier we were using Evita graft. Now the new one is available now, Thoraflex. So the first step is passing a guide wire, as I showed in the previous thing. Then cool the patient. Anti-grade perfusion we give through the carotids. And cardioplegia, normally for long procedures, I prefer to use custodial because you can go for 2.5 to 3 hours if necessary, and another dose also. It's very good. Preparation of the aorta is very important. Distal preparation with the Teflon felt outside, and then deploying the graft. You see the guide wire has to be passed through that so that the graft goes into the hybrid graft, stent graft goes into the true lumen. Usually in aneurysm cases, there is no need to pass guide wire. Dissection is important, you should pass the guide wire. Then you release after putting the graft there, you cut the suture. When you pull that blue thing, the graft gets deployed. And then you remove that wire so that the tip gets open. It's very important when you are pulling that, somebody has to hold the cuff of the graft, otherwise the endograft will come out. It's very important. Usually we put 2 mosquitoes and then somebody, that is the frill of the thing, we have to suture it. So it can be actually, at this stage, sometimes we start the lower body perfusion. The graft expands, it may not bleed much. It is easy to take the suture. It's important that sutures has to be taken carefully. After that, we just do the arch anastomosis in the usual way. First this is done, we do the subclavian anastomosis, is the most difficult one, and then start the lower body perfusion. So now the lower body perfusion is being started, and then first we do the aortic anastomosis to the proximal part so that the myocardial preservation, the blood flow to the coronaries are retained, so that myocardial protection is good. Then in sequence we anastomose all the other things. This we did one FET in acute dissection. Acute type A dissection, it's a complex procedure. Unless it's very straightforward, we don't do. With the first case we published in our journal. And these are the few cases of Thoraflex which we have used. The angiogram done, CT angiogram done after 2 years. You can see how the false lumen is nicely thrombosed in this case. It's a very good, actually. This is also another where the false lumen is nicely thrombosed. Nice remodeling of the aorta. And proximalization from the zone 3, that is at the subclavian level, to the proximal to subclavian is very good in good suturing, ease of anastomosis and hemostasis, and avoiding injury to the recurrent laryngeal nerve. And this was the Evita graft with the new one which we implanted first time. This also was reported. But this graft slowly they have withdrawn because there was a lot of bleeding problems with this graft. So we had 2 cases we did. Still in Europe, a few of the surgeons still use it. They have modified this graft. But the main graft available is the Thoraflex in India. And this is the original technique we published in Journal of Cardiac Surgery to expose the radial, the subclavian artery. You can see by cutting the this sternomastoid, it can be easily, you cut the sternomastoid muscle, the sternal head, the subclavian artery is right in front of you. So the future bleeding problem, everything can be avoided. So we have this from the industry data, only less than 80 hybrid processes is sold in India so far. At least 1 debranching procedure per week is performed across the country, approximately 180 to 200 procedures since November 2019. Debranching versus FET is 2:1. Still more people in India do debranching because of the availability of grafts and lack of experience. Because to do FET is not very easy. It is one has to have a good experience in doing the procedure. And is debranching better or FET with equal results? I would say FET is much better than debranching in the long term. If one can do it, that is a good procedure. The reason being, you need fluoroscopy. Rigid TREVAR grafts are not ideally for this procedure. It is time consuming and problems are more. And late complications can occur like endoleaks. It can occur in the subclavian artery. These are the problems. Or retrograde type of dissection, which is lethal. rigid stent graft leading to late rupture of distal aorta. This we published in 2019, our experience with all hybrid aortic, about 56 cases. Majority are male patients. These are the type of procedures. Now, this is the FET in our experience. Type 3 hybrid, like separate graft and arch graft, we did in 19 cases. Thoraflex, we have used the maximum number in the country. About 21 plus 2, 23 we have done FET. And the trend, nowadays we do more of FET rather than the type 3 procedure, because it is, we have become more experienced in doing it, that our results are also good. So we continue to do that. Pathology, chronic dissection is 64 and acute in 7%. And these are our age group. We had about almost 13 patients who we did reoperations. A lot of cases who come after previous aortic dissections with the type A ascending aortic repair come for distal aortic repair. So 30-day mortality, we lost about 3 patients. 2 of them are in aortic dissection, delayed neurological, which completely recovered, and only 1 case of paraplegia in our series. Western countries, one of the problems more with the paraplegia, I think it is more related to the disease pathology. They do more for aneurysms rather than dissections. Younger patients, these are the other, we didn't have any. We delayed sternal closure, we have done, it's a very good, I find in my experience, doesn't add to any infection or other morbidity. When a lot of oozing is there, they pack the sternum, and then next day we just close the sternum. So in conclusion, hybrid technique is a safe option in patients who are not fit for open repair. Retrograde type A dissection can be avoided by performing type 2, like interposing an ascending aortic graft. And the frozen elephant trunk is better than type 3 hybrid with antegrade TVAR. New devices and ease of implantation definitely will increase the ease of anastomosis. Zone 2 implantation, as I have shown, proximal to subclavian, is more advantageous than zone 3 implantation. Thank you very much. Yeah, really. Any questions? Anybody else got? I can go.
Any questions from Bossy?
Oh. Sorry, I had to leave.
Yes. Yes, fine.
Dr. Amdul is there? Yes, yes. He is speaking on type B, aortic dissection, correct strategies.
Hi, good afternoon, everybody here. I can see very sparse crowd here. It's lunchtime, I know that, so I'll make it quick. And before I start, I would say that this presentation was made for residents and junior colleagues, which I hardly see them anywhere, more of faculty. But anyway, as a presentation, I'll continue and maybe skip a few slides which are too primitive for our faculty. So I think after the stalwart talking on aortic surgeries, I think it's just demeaning this topic by me talking about it. And as we see that this figure, this picture is very apt. Management of aortic surgery is like walking on this tie rope in between 2 mountains. We just don't know when we are going to fall, and whether we'll reach the end of the rope walk. Because I've seen that when I started, we used to start surgery with all possible enthusiasm, but the next day morning, after 8, 12, 20 hours, we used to have a patient which we used to just hang our head down and whole team tired and just lost confidence. But then that's how it goes. I think these are the very demanding surgeries and institutional surgeries, and eventually once we started doing more and more and things started picking up, the whole thing has to be geared up. So it is never a one-man surgery. It is a team work. Today, whatever we are doing is just not just a surgical skill. It involves a lot of things. So as we see that this is I call as a problem statement, because it is the most common catastrophe of aorta, and it's a time-sensitive and rapidly fatal disease, high risk of morbidity and mortality, increased incidence of prevalence because maybe the diagnosis has been pretty apt now with the availability of CT scan in smallest possible centers and awareness between our residents that on picking up such cases. And the last and most is an unpredictable outcome still, in spite of we are doing more and more cases, because I feel that still it is not about an individual, it is about an institutional work that results into better results. So I had made up this from resident point of view, defining each and every part and taking through the how type B aortic dissection has to be handled or managed and the current strategies. So by definition, as I said, is a result of an intimal tear with proximal descending thoracic aorta just distal to left subclavian artery, causing separations of layers of aortic valve. That's how we know about aortic dissection. And in type B dissection, as a natal study, why it starts from after left subclavian, he has seen that this is an area of maximum shear forces and which cause a lot of turbulence maybe at, or maybe maximum pressure at that side, and that is why we find most of the entries at this just distal to the left subclavian artery. Normally the dissection occurs in media, separating intima and from the adventitia, and that is where is the false lumen we all talk about and worried about. So adventitia being the stronger of the unit, then what happens is the expansion of the false lumen becomes very easier by pushing the true lumen inside. That's why when we see the CT scan, we see a very streak of true lumen and a large huge false lumen. Is just because of the strength of the advential tissue. And what really matters to us is it compromises arteries of viscera, spinal cord and extremity, that is which is cause of concern in the management of type B dissection. And what another thing that we have seen in pathophysiology is the dissection is always spiral, and because of this the spiral dissection nature, the left renal artery is always been ripped off from the true lumen and end up arising from the false lumen, while we see that the other visceral like celiac and superior mesenteric and right renal normally ends up coming from the true lumen. So this is what we always know about, that Stanford classifications. Anything coming from ascending aorta is type A Stanford dissection, and coming anything beyond the left subclavian is type B dissection, which we are going to discuss here. But we have to go further with the advent of tower. We have to start zoning them, and that helps us to in the following management of this patient. So anything from root to the first artery, the innominate artery, is zone 0. Then if you see then that is normally the type A dissections. Anything between arising from between the innominate and the left carotid is zone 1. Zone 2 is between left carotid and left subclavian. Beyond that, the just where is the zone 3, and down descending is zone 4. Zone 6, 7, 8 are the where the visceral vessels come through, and zone 10 are our bifurcations, that iliac arteries. So we have to remember this now, along with what generalized classification of Stanford, to just differentiate between type A and type B. We have to much move forward. What is the clinical presentations? The most common thing what we see is when we hear on the phone also, patient had excruciating back pain and just become morbid after that. This what gives you, we should raise the alarm that it is it's a dissection. And it helps by creating an awareness in general practitioners or doctors that such type of pain when a patient comes through should not be ignored, and we should start, and that is how it has helped to pick up now a dissection in bigger cities. Now, the basic concern is not just chest pain or back pain, it is about a malperfusion which results, and this is because of the end organ ischemia and resulting into abdominal pain, suddenly no urine coming out, oliguria, or if the dissection has compromised the blood flow to the lower limb, then lower limb extremity ischemia, resulting into paresis or paraplegia, patient just not able to move. So all these are where the clinical presentation can be. If it is rupture, which is a complicated dissection, then it is they end up with abdominal distension, sudden hypotension, and we may just lose the patient in front of your eyes. Nothing, no one can do anything for such patients. It's just a matter of minutes and seconds. Now, the availability of diagnostic tools like CT scan, CT angiography has been a gold standard for the diagnosis of dissections, and this is readily available. This is less operator dependent. It identifies ruptures, end organ ischemia, extent of dissection. That's why it's been more preferred than anything. The other option is to do a TE, but TE is very much operator dependent. You need to find a person a specialist who can do a TE, but then it has its own advantage that it can identify proximal tear, and also no contrast needed, as well as you can assess the cardiac function at the same time, which is important in management of type A dissections. Now, this is what I have seen. You can see the true lumen and false lumens in the dissection 1 CT image. I have put it up. This is image which is 3D image, I think, which shows the true lumen and false lumen. And this is what is an anatomical picture. You can very clearly see the true lumen and false lumen in that. And now another modality is intravascular ultrasound, which can very well tell you the false lumen and true lumen during management or whenever you're doing a tower or any other procedure. So we have to understand another part of it, which is very, very important, is the dynamic obstructions and static obstruction, because this helps us to understand what way of management we are going to do, whether it's going to be a medical management or we are going to enter these patients and taking for more aggressive treatment like surgery or TEVAR. So I won't go much in detail about all those things. The pictures are self-explanatory here. The static is when it is a compression from the false lumen into and completely closing it, and no matter what you decompress it, also is not going to relieve the compression on the visceral artery. But dynamic is just because of the flow. The minute you open it, equalize the pressure, then the dynamic obstruction goes and the perfusion, visceral perfusion and the distal perfusion can become better. So this helps us to do the treatment in type B dissections. Phases, as you know, that anything less than 14 days is acute, then between 14 days to 2 months is subacute, and chronic is after 2 months. We need to know this because that is how we are going to define our treatment in type B aortic dissections. Now, they can be uncomplicated, where there is no rupture, no malperfusion, no high-risk features. And what are the high-risk features? We are talking about refractory pain, refractory hypotension, then or hypertension, pleural effusion, where the start leaking into it. The aortic diameter has gone more than 40 millimeters. There is radiographic evidence of malperfusions and patient coming for readmissions. So these are the things where false lumen is pretty big, more than 22 millimeters. These are all high-risk patients and results into complicated. Straight away complicated TBADs are ruptures and malperfusion, where we need to seriously think about quick interventions. Natural history, what exactly happens? They are uncomplicated cases. Most of the time they can be managed medically without any surgical intervention. 90% of the patients get discharged, and we have to just keep on following up of these patients. And in complicated cases, the mortality is very, very high. They require emergency open surgical or stent graft treatment. So we need to know the natural history also. What is the fate of this type B dissections? Either the false lumen gets thrombosed, or there is a persistent false lumen, or it keeps on expanding over a period of time, resulting into organ malperfusion or ruptures or aneurysms. So after the acute phase is over, then what happens is the minute you have been able to manage it, then it goes into a chronic state, and in chronic state, the dissection flap stiffens and the dissection transitions into a chronic phase. The stiff scarred dissection flaps normally renders aorta less amenable to TEVAR or stent grafting, and then surgery is much more better option in such cases. This is the ECS 2014 guidelines, how to go about. In acute type A dissections, where if it is complicated, we are not talking about it, we just go in for TEVAR or surgery now. And if it is uncomplicated, then we can think about medical treatment, pulling on, and if they become complicated, then go for TEVAR or hybrid procedures. In chronic type B dissections, we are talking about surgery, TEVAR, or just continue medical observations and then intervene when they become complicated. So medical treatment is critical for all TBADs. It's a strict control of blood pressures and heart rate control. Anti-impulse therapy means what we need to do is start them on beta blockers, start them on vasodilators, get the blood pressure down, get the heart rate down, stabilize this patient so that there is no more extensions of the false lumen, there is no more extension of the dissection. And then once we target what we want to stabilize the patient, then over a period of time you know that this patient is settling down. That means we can think about medical management in this patient, because remember that it is all easy to say. When taking this patient into OR, surgery is messy, the mortality and morbidity is very, very high. If you can manage this patient medically, nothing like it. Yeah. So Estera et al. Studies showed that in-hospital mortality is nearly 7.3%, but after 1 year and 5 year survivals are nearly 83 and 75%, and 14.5% end up becoming complicated TBAD requiring, and such patients do have a very higher mortality. Now, with problem, what is the problem then with medical management? Oh, so still a long way to go. So let me. So the problem is, if you keep on putting patients for medical treatment, then they may end up with aneurysm, expansion, progressive dissections, and may end up with much more morbid situation, or intervention can become difficult. So anything rupture rate is of around 30% if the aortic diameter become more than 60 millimeter. Surgical, what is the goal of surgical treatment? Is just to prevent or treat the rupture and close the entry point, and this will result into decrease in the malperfusion. So seal the tear, that is what is all surgical management, the goal of surgical or TEVAR itself. So, or you try to equalize the pressure in the false lumen and the true lumen by causing large fenestration into it. Now fenestration can be caused done by either surgically, or we can do it percutaneously nowadays very easily, and then create a perfusion equalization of pressure. But remember, this is not a treatment. It cannot prevent rupture or late aneurysm. It is just creating a situation for medical management of these patients. Now, in chronic TBAD, surgery is an option, and or secondly, what is coming up is TEVAR. TEVAR initially, because the stents available were not really great, but with the advent of better stent, TEVAR is gaining great grounds in treatment of type B dissections. So what are the indications for elective interventions? Anything aneurysm dilatation more than 55 to 60 millimeters, increasing rate more than 10 millimeter per year, symptoms persisting of pain or malperfusion, and acute redissection or rupture. These are the indications for elective interventions. There is always a risk of retrograde TAD also, an aortic dissection. Now we need to understand quickly, I'll take you through what are the benefits of TEVAR. TEVAR helps in aortic remodeling, better patient management, and better long-term results than medical management. But there are risks along with it, and there are procedural complications. There can be paraplegia, there can be stroke in such patients. These are serious indications for TEVAR, where type B dissection ischemia is then as a type A, 1A indications, and no ischemia can be type 2B or C. So role of TEVAR again is the same like surgical. We just close the dissection, the entry tear, so that we are causing thrombosis of the false lumen. I'm just scraping through. So now in type zone 4 dissections, gold standard is TEVAR, because it has become much more standard and the results are far better. So in conclusion, this paper of Callum Howard suggested that despite significant higher comorbidities in complicated and uncomplicated, the results of TEVAR is the same. Can I have 5 more minutes, if it's okay, with your duties? Okay. So, these are certain things I'm going to show with, about TEVAR, how we go, desired optimal outcome of TEVAR. And this is another endovascular repair suggests that the short-term outcomes improve with endovascular management of complicated type B dissection, and long-term outcomes of uncomplicated, still it is a long way to go. We still don't have the final verdict on it. In the studies, this study said of Christopher, which says that type B dissection, thoracic endovascular aortic repair is associated with improved 5-year aortospecific survival and delayed disease progression. And the INSTEAD Excel trial also said that medical management and surveillance were associated with failure to prevent late complications. So TEVAR was much better in such cases. And now this is how we have seen that false lumen thrombosis is much better in TEVAR. And the prospective randomized comparison also said that there is a better outcome with TEVAR than just medical management. These are certain pictures that I'm going to show you. These are certain TEVAR images that has been done. Very few has been done at my institute, but most of the patients are doing good till now on our follow-up. So these are complications. They can be retrograde aortic dissections, rupture of septum, perforation of aorta. They can be collapse of the graft itself. If you see in the third image, the whole graft has collapsed and closed down. So these are the some complications of TEVAR. So in short, what I wanted to talk about is type B dissections had been always been like a medical treatment and ignored, but not anymore. There are centers which are doing fair amount of work and trying to. So if you intervene in these patients in acute phase also, uncomplicated phase, then the long-term results are far better than just leaving them on medical management. Now, just before I leave, we have started this Indian Association of Interventional Cardiac Surgeon with this thing. We are doing our second workshop in Mumbai in the month of July. I'll give you the final dates. Please, these are the treatment. These are the skills which are required when you have to manage interventions or stent grafting, TEVAR, or whatever newer therapies which are coming. So it is mandatory, and it is important that we all surgeons get our hands on our treatment. Thank you very much.
Thank you, Dr. Andale. Hybrids and type B, they all require high-tech gadgets, cannulas and grafts. And the talk was scheduled at the beginning of the session, but now I request Dr. Idris to come up and present his topic, that is more art crafts and
I can control your notes.
Knowing the versatile player he is, I am sure he will keep up the time and do the job of a finisher.
Good afternoon. So the topic for me is the neografts, and at the outset I'd like to thank the organizing committee for giving me this opportunity. So before starting on, let me move to anatomy. See, the aortic arch as such, the aortic arch is actually a 3D structure. So it starts anteriorly and goes posterior. It starts anterior and goes posterior, and it extends in X, Y, and Z axis. This makes this structure a complex one, and surgery here as well is very complex because a lot of nerves are involved there, and a lot of structures are there, very complex structures, so which we have to take in care. And if there's any injury, we have to call up the neighboring units for our reference. So just for the reference for the junior colleagues, so there are 4 zones in the aortic arch. Prior to the innominate artery is zone 0, at the level of carotid is zone 1, and subclavian, prior to subclavian, there is a proximal subclavian, zone 2, distal uterus zone 3. Okay. So in aortic arch surgeries, we always need to do an open arch surgery most of the time. So when we open up the arch, so there are a lot of organs which is at ischemia. So we need to protect the heart, the brain, and the organs, the bowel, kidney, and the spine. So we need to juggle around the few things. That is, we need to give a continuous perfusion, or if we have a cooling, and we have a plegia. So we need to juggle around these 3 things to protect the organs. So how are we going to do? The most important strategy is the cannulation. So when we are going to So the most common cannulation strategy is ascending aorta. But this doesn't work in all of the aortic arch surgeries, even though it is familiar, because when we are opening the arch, actually we have to remove the ascending aorta cannulation, and we need to change to a different cannulation strategy to protect the lower body. So ascending aorta, the cannulation may not work in a lot of aortic arch surgeries. So the other most commonly used is the innominate artery cannulation. So the innominate artery cannulation is very familiar and easy and convenient, but sometimes we need not change the cannula when we go in for antegrade cerebral perfusion. But in case of redo surgeries, we need to do a sternotomy prior to cannulation. So this may not work in all the cases. And this artery is very commonly involved in aortic dissection. And so it may not be convenient to do an innominate artery cannulation in aortic dissections. And it's when the aneurysm very large, so we not be able to do it in, we not be able to reach the innominate artery in large aneurysms. The other is the femoral artery. Femoral artery is a very commonly used cannulation strategy, very easy, and can be used in case of emergencies and redo surgeries. But there are certain problems there. So there is a problem in aortic dissections. There are problems that because of the retrograde malperfusion. So there can be a retrograde malperfusion can happen, or because of the retrograde in atherosclerotic aorta, there is a risk of atheroembolisms. And is very close to the groin, and there is a risk of contamination is there. And when we are going to do antegrade cerebral perfusion, we need to do separate cannulations for that when we are using the femoral cannulations. There are a few contraindications, like in occlusive disease, like aorta occlusive disease, where infrarenal. So this is contraindicated. And in case of coarctation of aorta, where we won't be able to use this as a sole cannulation strategy, and severe lower limb malperfusion, so severe PVOD disease. So this is contraindicated. In the recent times, the right axillary artery, now even considered as a central cannulation, is coming up very commonly. Is coming up now. So this gives a good perfusion strategy where we can clamp up the innominate artery and perfuse the brain with this strategy. And this, for some reasons, is seldom dissected in aortic dissection. So it is seldom there is atherosclerotic plaque in this artery. So it's becoming a very commonly used artery for cannulation. And even in redo sternotomies, we can cannulate here and then do the sternotomy. So it's becoming a more and more commonly used artery. But only thing is that this artery has it's time consuming, especially in obese patients. We need to dig out the artery before using it. And this artery, for some reason, it's very fragile as compared to the innominate artery and the femoral artery. So it needs to be handled with care. So when we are cannulating, we have two strategies, whether we can use a direct cannula, where some authors prefer that one, but some prefer using a graft. Some prefer a graft. So the graft can be connected to a cannula or to a quarter 3/8 connector and then used. So we prefer the second option, where this avoids a malperfusion of the vertebral artery, number one, and then this is being a fragile artery, we can avoid damage to the artery because direct cannulation. And when we remove it, the future stenosis can be avoided, especially in Indian patients when the artery are very small. So this graft is very useful, it's a chimney graft. And this carotid cannulation is becoming commoner now as well as the right axillary artery. It's very easy to access the artery because it's very just retract the sternocleidomastoid masseter muscle, and the artery is right in front of you. And in case of redo surgeries, this cannula is actually very useful. And in case we want to give a redo surgery, when we want to give antegrade perfusion, it's very helpful. So this is being used, but we have to be very careful in suit scenarios. When scenarios where the circle of Willis is incomplete, we may land up in a stroke. And when there is one artery dissected, it's very common in aortic dissections where one of the arteries is dissected, we cannot go in for the other artery because the patient can go in for a stroke, because we don't know how is the dynamic malperfusion being occurring with the dissected artery on one side. So these are scenarios where carotid artery situation has to be stopped, cannot be used. And other option is like the cannulation through the side branches, which can be used in aortic arch and the thoracoabdominal surgeries. So now we are always confused which one to use. So always the one dress cannot suit in all occasions. So, and during circulation, especially in aortic arch, so the organ perfusion has to be interrupted. So we have to suit so cannulation which will be able to protect the organs. And we always have to be prepared for intraoperative surprises, especially in aortic dissections. So we have patient factors like obesity, dissected vessels, or atherosclerotic vessels will dictate which artery to be used. And surgeon familiarity and the institute familiarity is very important. And certain times the graft may not be available, so those kinds we have to cannulate, we have to depend which graft to be used. I'll give you a scenario here. This is one of our case which we published, a huge aneurysm of 13 centimeters. This is aneurysm where we could have cannulated axillary artery or femoral artery. So then, when we do a sternotomy and indirectly we open up the aorta, boom, that is it. We won't be able to see anything. So the field is full of blood and our visibility is lost. And this time, before we dissect that out and get the aorta for cross clamping, the brain will be ischemic and we may lose the brain as well and in fact the patient as well. So instead, what we did was actually cannulate the carotid artery, open up and cannulate the carotid artery, and then we start opening. In case we rupture also the aorta, we can clamp the aorta, we can clamp the carotid artery and continuously perfuse the carotid artery. So and the brain is protected. So these are the scenarios which we have to sit down with the radiologist and prior planning is required. So moving on to the next segment, the newer arch devices. So the arch devices, there are a lot of arch devices. I'm not going to touch upon the endovascular rings, only the surgical part. So they work on few doctrines. One is that the distal anastomosis, how are we going to make, because this is one of the Achilles heel where the hemostasis is very difficult. And then at a second stage where the supraortic arch vessels, how are we going to take care? And that is when we will be reducing the TCA time. And the fourth one is like, how are we going to help the patient for planning the next surgery? And then the fifth one is that in the present era of wire skills, how are we going to help the patients with the catheter-based skills? If we are going to, so as we go on to the presentations, you'll know what I'm talking about. So in technique-wise, the proximalization of the distal anastomosis is advancement. To put things in perspective, this is the zone 3 anastomosis. So you see that, the distal anastomosis is actually, when we are seeing from the, not able to get the pointer. So when we are seeing the, when we are entering through the chest, this is the deepest anastomosis which you will be able to see. And once the patient cross clamp is released, we won't be able to see this anastomosis at all when the patient is bleeding. So there are procedures we have to proximalize when it comes to zone 2. So this is where we will be able to see. So zone 2 anastomosis, that is prior to subclavian artery. When we even more, when we even more proximalize, you could see all the structures are even more comes in more front. So the anastomosis and the bleeding hemostasis are well taken care in after the surgery. So initial stages, this is where the Carroll's patch was only thing. We had only straight grafts, so we have to do only Carroll's patch technique, where all the 3 supraortic arch vessels are taken as a single patch and implanted into this straight graft. So there are some problems here, like only after the distal anastomosis, we won't be able to clamp at this space and start the perfusion of the femoral artery because we don't have any space for doing the arch vessels. So we have to give a prolonged TCA time, or else we have to give an intermittent perfusion, and then at a later stage only we have to go for again TCA to do the supraortic arch vessels. So then after doing the supraortic arch vessels only we will be able to cross clamp, and then from the innominate artery or the carotid artery we will be able to perfuse the lower body. So the TCA time is more. And there is a very short distance between the subclavian artery and the distal anastomosis. I'll come to the significance later. So this eventually will increase the TCA time, and there is a difficulty of hemostasis is there, and there is a short distance between the left subclavian artery and the distal anastomosis. So that is when this individual branch graft, this is called a 4-branch plexus graft, which is come into work. So where we can anastomose, the distal anastomosis is done, and then each of these anastomoses of the branch vessels are done. There is a separate side branch through which you can put a cross clamp here and start the perfusion to the lower body. So the TCA time is significantly reduced in these patients. The second advantage is, so here the subclavian artery can be ligated, and this third branch, pointer is not working, and this third branch can be used. This is called a zone 2 anastomosis. That is, prior to the subclavian artery we will anastomose, and then we can do the subclavian artery anastomosis, and then this will be helping. And there is we can give a good distance between the subclavian artery and the distal anastomosis. Why this is important? In the present era, if this distance is good, we can give a good landing zone for the TVAR grafts. So this cannot happen, as I already mentioned, like in that Carroll's patch technique. This cannot be happening because we cannot mobilize that the Carroll's patch more proximal, which can be done in this branch grafts. So eventually, which will reduce the TCA time, and hemostasis is much better, and there is a good landing zone for which we can implant the TVAR grafts. And this is an advancement which is like the George Matlanis group from Australia have been popularized. It is called branch first technique, where it is called a tap graft, which is available from the thermome. Their individual branch grafts are divided, and then, so innominate artery grafts is divided, and then with the innominate artery, then the side perfusion can be done through the other arm. So the perfusion is continued through the brain, and then sequentially to the carotid artery and the subclavian artery. Both of them, all the three are sequentially done, and then through the side arm, the perfusion is continued. I'll take another 3 more minutes, please. Okay, and then the distal anastomosis is done, and then the proximal anastomosis is done. So this eventually reduces the TCA time, and then we have a good landing zone as well. A good landing zone is there, for which in dissection patients, we can put a TVAR graft at a later stage. So this was popularized by George Matlanis. And this is called a Lupe graft, again available in thermome. This has a big bovine trunk where all the 3 branches come out with a 4th branch. So this branch is available, but it is not popularized from the it is from the Italian group, so this is not much popularized. So here the concept is similar. So from the single branch, all the 3 branches are there, and this also has a good landing zone where we can implant the time. So moving on to the big next concept, the elephant trunk segment. So this was proposed by Hans Prost way back in 1883. So this is helping in mega aortic syndrome. After doing the arch, it helps in performing the lower abdomen thoracic aortic surgery at an easier stage. So this was proposed. At a later stage, this hanging graft was converted into a TVAR graft in early 2000s, called as a frozen elephant trunk. So in the classical elephant trunk graft, what happens? A long segment graft is inverted inside, and this double graft is then sutured here. So a double-breasted graft is there, and that is sutured to the aorta. And then we have to remove this graft to reconstruct the aorta. This takes a long time. And then the hemostasis is also difficult. So that is when the newer classical elephant trunk grafts have come in. So these grafts have a collar, which is called the Sienna collar, patented by the Thermo company. And then they have a prepared elephant trunk. You just push it in and graft is done. So our elephant trunk is already there. And then they have radio-opaque markers. These radio-opaque markers guide us for the next level stent grafts. So next level stent grafts, when we want to implant into this classical elephant trunk, so these stent grafts will be helpful. This is the newest elephant trunk. And this I already mentioned, the frozen elephant trunk, where this classical, this is the dangling graft, Dacron graft, is replaced by a TVAR graft. So initially when it came in early 2000s, this graft did not have any collar, have only no branches as well. So later, the collar has been incorporated, but there was no branches. And at a later stage, both of them, all 2 of them were implanted, making the frozen elephant trunk a much easier operation as compared to what was in early 2000s. So here, a classical elephant trunk is being done, one of the earliest one which is being done here. So you could see the graft is being invaginated. The invaginated graft is then deployed into the descending aorta. So this is the invaginated graft which has been deployed into the descending aorta. With the descending aorta, the open arch is deep inside into the thoracic cavity where we insert it. And then the double-breasted graft is sutured onto the aorta, a thick tissue. The hemostasis has to be perfect, because once we remove it, we won't be able to see anything there. And then the graft is removed. And this is the initial stage of classical elephant trunk, frozen elephant trunk graft, where there is no collar. Without the collar, the graft has to be implanted, cut out, and then sutured, and then re-implanted again the arch graft, and then it was done. So again, it is a very cumbersome procedure. And this is the latest where we have a good collar. You could see the surgical technique is very easy. You just suture the collar there, and then we are done. So the hemostasis is much better. So I already mentioned about the zone 2 and zone 3 anastomosis. And now the techniques are coming. This is one of the papers which we published in Annals, Cardiothoracic Surgery. So here, the grafts are come where we could implant in zone 0 and zone 1. So when we implant in zone 0 and zone 1, we have a very short distance between the STJ, sonoric junction, and the anastomosis. So we won't be able to incorporate all the 3 grafts there. So that is when these companies have come out with the newer grafts, where it's called a trifurcated graft is there. From one branch, all the 3, one big stout branch is there, from where all the 3 branches comes out. So called a spivogal this. So from there, this is helpful in developing the zone 0 and zone 1 proximal anastomosis can be done. This is a paper which we presented, Innovia graph, Innovia in general cardiac surgery. This is a very new concept. It's used in type A aortic dissections where the zone 0 anastomosis is done and the arch graft is having uncovered stent graft, and then we have a covered part post subclavian. So what will happen is that this uncovered stent segment will push the true lumen and the false lumen together, and the true lumen is opened up. These branch vessels are still perfused, and then the T-graft grafts at the lower end with a covered stent takes care. This is incorporated of the frozen elephant trunk with the T-var grafts. So only 6 patients has been done worldwide. So these are newer concept which is coming up. And this is already mentioned. This is just the development how it has happened. This is a very new concept which was presented last month by Marco Eugenio in Italy. It's called a Thoraflex T segment. So the blue the blue circles here represents the regular arch grafts where all 3 are in linear fashion. What has happened is like he proposed a graft segment where all are in transverse place and giving a lot of ascending aorta segment. The red line showing the aortic segment is a lot of that. So that at a later stage when we want to cross clamp the aorta, we have good space there. So this is how, so you could see that all the 3 are lined up and they have a good cross clamping space at the ascending aorta. And this has a good alignment when we are taking a right radial artery. The wires can be passed at a much smoother panel to deploy stent grafts in the descending aorta, or a renal artery stenosis can be done in this, like in this patient which was presented. Ladies and gentlemen, to conclude, arch surgeries are still challenging, and the devices and the surgical techniques need to be tailor-made to the patients. Newer devices reduces the morbidity and the ischemic time to the lower body, and the newer devices aid in future surgical procedures and a catheter-based technology. I thank for the patients listening to you. I thank you. Thank you one and all.
Thank you, Dr. Grace, for enlightening on the newer devices. They have certainly made our aortic surgery life much easier and comfortable. So, thank you. The next talk is actually Dr. Shiv Chaudhary. The sir is not here, so we'll be playing a video. So, after that, we might entertain 1 or 2 questions. So, we can start the video.
Good morning. I am thankful to Dr. Bhupesh and his team for organizing this wonderful meeting and giving me this opportunity to talk to you. Management of arch in acute type A dissection is probably one of the most Good morning. I am thankful to Dr. Bhupesh and his team for organizing this wonderful meeting and giving me this opportunity to talk to you. Management of arch in acute type A dissection is probably one of the most debated and often confusing topic in current times, and that too more in Indian scenario. Before I proceed further, let's have a look at the Indian scenario. Most of the surgeons have limited exposure to this entity. There is no streamlined referral system and transport facilities. Very often, the interventional facilities are not available to most of us in odd hours. The state-of-the-art monitoring, branch graft and stent grafts are often not available, and on top of it, the cost is an important constraint. We should understand that surgery for acute type A dissection is a life-saving palliative procedure. The aim is to save life, and surgical complexity very often increases mortality and morbidity. Considering these constraints of Indian scenario, I have kept the algorithm very simple and reproducible, and I work with limited available resources without using too much of resources, but at the same time, I prepare for the worst possible clinical scenario that we may come across, but we do only the essential part which is needed to save the life of the patient. To keep the algorithm simple, I have divided management of arch in 3 simple steps. The first step involves, and which is mandatory, is resection of the hemi-arch in all the cases, irrespective of the presence or absence of tear, aneurysm. Hemi-arch replacement is the minimum in all the cases. Second part is that we should resect all the intimal tears and aneurysmal segment. If the intimal tear is along the lesser curvature, then hemi-arch replacement is sufficient. But if the arch is aneurysmal or the tear is along the greater curvature, then an arch replacement is required. The third part is the most debated one. It is performed for prevention of delayed complication of distal residual dissection, and it's purely optional in nature. We put a covered stent graft in the distal arch and proximal DTA, and this is frozen elephant trunk. I should emphasize that the conventional elephant trunk using a Decton graft has no role to play in acute dissection surgery. Before we decide about the use of frozen elephant trunk, we should understand the natural history of acute dissection. If left untreated, distal false lumen may thrombose completely, or false lumen may not dilate further in majority of the patients. So we should know this thing, and that eliminates the need of frozen elephant trunk in most of the cases. At the same time, we should also understand that if left untreated, distal false lumen may become aneurysmal in high-risk patients. The use of frozen elephant trunk increases the chances of false lumen thrombosis and aortic remodeling. Frozen elephant trunk helps in resolution of the malperfusions, but at the same time, the preoperative malperfusion get resolved in majority of patients after proximal repair. So, a radiological visible malperfusion may not always need a frozen elephant trunk. The world literature and cumulative global experience has shown that frozen elephant trunk is quite helpful in selected cases, and these include tear in the proximal DTA, retrograde type A dissection, distal malperfusion, and aneurysmal disease of the proximal aorta. Though frozen elephant trunk has shown the promise, there are certain downsides also. The first one is because of the logistic issue. If we plan for frozen elephant trunk, we may delay the surgery, and it's not available freely in India in all the centers. Secondly, we covered the subclavian and proximal DTA. There are increased chances of paraplegia. In post-operative period in dissection patients, we try to keep the blood pressure nearly 100, but if we cover the proximal DTA and subclavian with a stent graft at this pressure, the patient may develop paraplegia. So there is a tussle between possibility of neurological problem vis-a-vis problem of bleeding. And we should also understand that in acute phase, the intervening septum is quite friable, so there are more chances of aortic rupture if we go with a frozen elephant trunk. Considering pros and cons, I have adopted a middle path. So what is middle path? That we do an endovascular compliant proximal repair, that is hemi-arch replacement or arch replacement, and after 2 weeks period, depending upon the condition of the patient, we do a delayed elective stent graft in selected high-risk patient. Now coming to the actual conduct of procedure in the patients, the preparations are made starting from the drapes and all the cannulation site, carotid, axillary and femoral are kept in the drape. This is the arterial circuit for these patients. The arterial line is quadrifurcated for right common carotid, left common carotid, branch graft or proximal DTA and femoral artery. So the arterial circuit is divided in such a way that whatever combination, permutation combination is needed, it is available to us. I go with right common carotid cannulation in these patients until unless it is dissected, and the same is being used for antegrade cerebral perfusion also. So after completion of the root procedure, we control the innominate and left common carotid artery with soft clamps, remove the aortic clamp on the ascending aorta, and occlude the left subclavian artery from inside the lumen using a 7 French Fogarty catheter. At this stage, we start antegrade cerebral perfusion, so the carotid circulation, and adequacy of cerebral perfusion is monitored with the help of NIRS. If NIRS value on the left side is satisfactory, we continue with the unilateral cerebral perfusion, but if we find that the left-sided NIRS values are quite low, then we start bilateral antegrade cerebral perfusion by cannulating the left common carotid artery from inside. And for this purpose, we use a simple inexpensive solution. This is number 4 endotracheal, cupped endotracheal tube, or we can use a 16-gauge suprapubic cystostomy catheter. Both of these things work very fine. The antegrade cerebral perfusion flow is kept depending upon whether it's unilateral or bilateral. If only unilateral, the ACP flow is 30% of the calculated total flows, and if it's bilateral, then 40% of the total pump flow. If our anticipated lower body arrest time is more than 20 minutes, we start perfusion of the lower body by putting a 24 Foley's catheter in the DTA and connecting it to the extra limb of our arterial system. Now coming to the actual management of the arch. Once now the arch is open in front of us, we inspect the arch from inside. We look for an intimal tear in the arch. Merely presence of dissection in innominate artery or left common carotid artery will not change the surgical plan. It is the tear which will decide the procedure to be performed. So the choice of procedure will depend upon the location of the intimal tear, diameter of the arch and proximal DTA, any evidence of malperfusion and coexisting connective tissue disorder. If there is no intimal tear or there is tear along the lesser curvature and patient doesn't have connective tissue disorder or the arch is of normal diameter, then simply an hemi-arch replacement is enough. Hemi-arch replacement is always performed in an open fashion. We don't do hemi-arch replacement with clamp on. After removing the clamp, the cuff is prepared it can be prepared in multiple ways. This is showing the use of PTFE felt both inside and outside. Once the cuff is prepared, we anastomose this to the proximal graft in a running fashion, and this is completed hemiarch. It looks like this. In some of the high-risk cases who will need endovascular intervention in near future, for example, if there is a tear in the proximal DTO or isthmus, if there is retrograde type A dissection, there is distal malperfusion, or there is aneurysmal disease of the proximal DTA, we debranch the carotid, the innominate artery and left common carotid artery, and connect them proximally on the graft. This leaves a good landing zone for the future endovascular intervention. However, if there is a tear along the greater curvature, if the arch is aneurysmal, or if the patient, if it's a Marfan patient and relatively young patient, in these patients we plan for an arch replacement. In arch replacement also, if we do an endovascular compliant arch replacement, and how do? We debranch both the innominate and left common carotid artery and connect it to the proximal graft. We replace the arch with a simple tube graft, and the distal anastomosis is done proximal to left subclavian in the area of the left common carotid artery. That is what we call it zone 2. This makes the arch anastomosis very easy and hemostatic. We don't do anything with the subclavian artery. If there is a tear in the base of the subclavian artery, we leave it as such, because it becomes very difficult to replace this segment of the arch and do arch anastomosis distal to subclavian, especially in hypertensive patients where the aorta is opened up and unfolded. So this area becomes inaccessible later on. And if there is a bleeding, it's very difficult to control. So we always do distal anastomosis in zone 2. This has simplified the arch replacement greatly. So this again gives us a good landing zone, and one can have an endovascular intervention in near future. This conventional arch replacement with a branch graft is no more used in acute dissections. We do a CT angio after 2 weeks in high-risk patient and plan for a delayed stent graft placement in these high-risk group that we discussed earlier. But this algorithm is very simple, reproducible, doesn't require any sophisticated support and endovascular backup, and very open, and lots of surgeons are able to do an effective arch management in type A dissection following this algorithm. Thank you.
That comes to the end of the session. So any questions on the previous speakers? We can take probably 1 or 2 questions. Dr. Idris can answer for Dr. Bashi's presentation. No questions? Thank you.
Dr. Hamdulillah, today in era of all endovascular procedures, anything left for surgical, only open surgery for type B dissection?
If you look at chronic CVDs, and it is still surgical intervention can be talked about, because we know exactly the clear how much of segment need to be excised, the descending thoracic aorta, we can implant those vessels very properly. So there is a role of surgery, it's not that it's out. But then with the advent of TIVA, the way it is coming up with we can individually put up even
took grafts in our celiac. So this has made things much easier. So eventually, except cost, that's the only thing which is on the negative side for GWAR. But then, if we have better hands, then I think GWAR is an option, and it's a better option. But then surgery still goes on, and it will go on in certain cases because certain patients are not going to afford GWAR in any way. So it's not an end of the surgical era for descending thoracic aneurysms.
With the opinion of Idris, what type B dissection?
Chronic type B surgery plays an important role, especially patients with markers or patients. So there, when we are putting a TVAR graft, the TVAR graft is 100% not of use, because what is happening is, in the major difference between the TVAR and the surgery, where we are going to remove the live tissue in surgery. But in TVAR, the live tissue is still there. The dissected, the aneurysm still keeps growing. And when we are going to place a TVAR in young patients, so they are going to come back up for us for a endodeal. So worldwide, there is for type B dissection in connective tissue disorder, it is not acceptable. So surgery is the only choice, and it is also thoracoabdominal complete surgery. For other cases, elderly gentlemen or aneurysms, there is still a role of TVARs.
Especially when there are huge aneurysms and then it's not possible to put the stent grafts in, then you don't have any other option in surgery. So it's important, one of the slides had shown that it's important that the landing zone and is very, very important for TVAR. And if you're not going to find this, then this is just, option is just out. In those cases, surgery is the only thing. Okay, this in the branch first technique, do you have any experience recently? Have you done any branch first?
No, branch first technique is actually a difficult technique. Even though the mechanism is popularizing, not many centers are still adapted in US or US, because we have to take a very selective number of patients, because not all patients are very suitable for branch first.
Thank you, sir.
Even though aneurysms, what he says that we can do it at the distance. In zone 2, the aneurysms are very large, very difficult to do anastomosis there. At zone 2, so the aneurysms are large, branch 2 become more difficult.
Thank you, sirs, for a very lively discussion and lively session on aorta. May I request the chairpersons, Dr. Kalmant and Dr. Yadav, to present mementos to our speakers. May I request Dr. Mohammad Idris and Dr. Hamdullah to please come on the dais and Dr. Idris. एक ग्रुप फोटो Thank you, sirs, for a lively morning discussions. We are ready for lunch. Lunch is served. It's on this side. And let us assemble in about 20 minutes again to start the afternoon session. I'm sorry we are rushing, basically to ensure that everyone gets the most of the sessions here. Thank you.
Deepak.
Can I have the lights on? The lights, please. Lights on. All set. Good afternoon, everyone, and I'm happy to see all of you back after lunch. Shall we start the next session after lunch? May I request Dr. Debashis Das, Dr. Abhishek Parmar, and Dr. Lalit Malik to please come on the dais and conduct this next session. This is a session on minimally invasive surgery, and I'm sure it is bound to be exciting and interesting. Dr. Brijmohan, please. Dr. Brijmohan, can you please come on the dais? I request all the speakers to try and stick to the time allotted. It just makes things easier. And I request the chairpersons to start the session with Dr. Nitin Rajput.
Very good afternoon to all. And without wasting the time, we'll start the session with Dr. Nitin Rajput.
Good afternoon, everyone. First of all, I would like to thank the organizers to give me this opportunity. Today I am talking about transaxillary video assisted aortic valve replacement, how we are doing at NH Bangalore. So there are few options for minimally invasive aortic valve replacement. The most commonly done is upper mini sternotomy, which is done around 62% of cases, and then right anterior thoracotomy, lower hemi sternotomy, and nowadays recently we have started doing transaxillary aortic valve replacement. There are few relative selection criteria for our team. First of all, we are not doing axillary for heavily calcified valves. So mild and non-calcified valve, good annulus size, aorta size less than 40 millimeter, fair LV function, and relatively young patients we are selecting. History of any pulmonary tuberculosis, lung surgery on the right side, or associated any other pathology, and elderly patient we are excluding from these procedures. Prerequisites for this procedure: endoscope system. Currently we are using 7.5 millimeter endoscope from this striker, and right lung isolation by bronchial blocker or double lumen tube. Now preferably we are using double lumen tube. It is it has been seen that it is better isolates the right lung. MICS instrument set is the compulsory. Femoral cannulae, dilator set, long cardioplegia cannula are the must requirement. CT thorax can be done few cases if additional information about aorta size and other things like any disease in the aorta to be ruled out. TE is the must, not only for the disease evaluation, but also to guide the cannulation. I am not covering cannulation in this video. I am presenting the video next. Already we know, in that case we have done IJV cannulation for SVC and femoro-femoral cannulation for arteriovenous. The patient is a 20-year-old male, severe AR, bileaflet aortic valve, aortic annulus 24, aortic sinus 33, STJ 28, LV function 50%. So as I already told, we have done cannulation and other things, and my video will start from there. So this is the pre-op TE. So the position for this procedure is 30-degree elevation from of the right side with javelin throw position of the right arm. After this, we mark 4 centimeter incision on the 4th intercostal space, just posterior to the anterior axillary line. Incision is given vertical so that it remains hidden in the axilla. It is deepened and 4th intercostal space is opened. After the 4th intercostal space is opened, we don't use rib spreader. Only this wound protector, which is also called soft tissue retractor, is being used to retract the ribs and whatever space it is created. By using this soft tissue retractor, we can reduce postoperative pain. This is most of the time it is because of the rib spreader. An endoscope port is created in the 6th intercostal space. In this case, it is done in the anterior axillary line. Sometimes, or a few surgeons, they use in mid-axillary line also. After this port is created, then we should open the pericardium on the aorta in a vertical fashion to see any adhesions are there. In a few cases, we encounter the adhesions. Once that pericardium is opened, you go on bypass and increase your incision on the pericardium downward toward the right phrenic nerve, exposing right superior pulmonary vein. Once you expose the right superior pulmonary vein, then 2 stay sutures are taken on either side, and they are taken out through the separate stab incision at seen on both of the side, so that the pericardium remains stretched. After this, we need to put a vent in the LV through the right superior pulmonary vein. So here we are taking pus sting for the same. So from here, the surgery will be same like standard procedure we follow for any aortic valve replacement. So here vent, this snugger for vent is created. Now after the vent, we will be ready to cross clamp the aorta. To cross clamp aorta, we are using a flexible signet clamp which is having soft inserts at the tip, and the clamp is done under endoscope guidance to see the tip of the clamp so that it occludes aorta completely. Because it is converted into flexible arm, it doesn't come in your way. Now heart is fibrillated and aorta is opened. Now it has become like anterior and posterior incision. So the posteriorly it will go towards the commissure as in a standard procedure. Care to be taken that we should cut any tissue with only tip of the scissors. Sometimes if you try to cut faster, then it can cut any other structure also. So after aortotomy is done, stay suture is taken on the distal edge of the aorta so that it exposes the left coronary ostia. And after this, we give cardioplegia to the left coronary ostia with the standard cardioplegia cannula. Once that cardioplegia is done, then it is very important to take these stays. This first stage almost at the 12 o'clock position, and it will be tied to the pericardium vertically almost towards the sternum so that it opens up the aorta. And the second stay suture I will take now, it will be at around 4 o'clock or 5 o'clock. And it will be tied to the oblique edge of the pericardium, which we have stretched with the
pericardial stay. So the aorta will open up now, and then we will give cardioplegia to the right coronary ostia. After this cardioplegia, stay sutures at the commissures will be given to elevate the commissures so that the valve comes nearer to you and better visualization can be there. So here I am using video for assistance. I am also using direct vision. Still we are not on total endoscopic for this procedure. Whatever space we are getting through the intercostal space, taking the stitches and confirming it with the endoscope. So after these stay sutures, valve leaflets are being excised using the endoscope assistance and the tip of the scissors. Again, I'm repeating because if you cut deep here, there is no much control and deep cut can be there. So both the leaflet, after excision of the leaflet, here only we have to size the valve by the sizer. Because if we take all the sutures and try to size it afterwards, then the size will not be accurate. Because those sutures are not like thoracotomy or sternotomy sutures, they are not in the line. Because they will stretch it obliquely towards the axilla, so the sizer will not be appropriate. So after all the sutures will be taken, here for suturing, the most difficult is the non-coronary area of the annulus, which is towards you, is the most difficult. This is a bicuspid kit, so that area was not there. Here the standard technique is followed. Now, after all the stitches, holder is removed because we have to tilt the valve so that it goes in the thoracotomy. And we have to do some exercise to make this valve seated because it is far away, and with the help of forceps, it should go in with many attempts. We can use core knot also, but I am using here the knotting technique with the knot pusher. Every knot you tie should be confirmed with the endoscope, whether it is properly done or not. After you finish this all knotting, then here the caution is sometimes either this knot is not tied properly, and so other point I have missed that I am not using pledgets here. Because if you have to redo it with some reason, even a single suture, then you can lose that pledget inside. So it is advisable not to use pledgets. After the valve is tested for the leaflet mobility, all these stay sutures are removed and the aorta is closed with the standard fashion. Magoon is stitched in double layer. So closure of the aorta should start from the pulmonary end because that will be the most difficult part. If you close from the other side, then it will be a problem. Few points here about closure. If your clamp is very much nearby, then you have to take care that your needle should not pass through the soft inserts of this clamp. Otherwise, clamp will not come out. So, otherwise, from here, this surgery is the same. How to do it? I'm not getting arrow here. So, meanwhile, once we are closing the aorta, the rewarming is started, and if we are not, if your incision is very close by, then I give a stab on the aorta and just remove the clamp. And afterwards, once you remove the clamp, you can put the cardioplegic cannula to DAR as standard. This is the post-operative echo, and this is the final incision. So in all cases, we have done 8 cases in the last 3 months, 4 centimeter incision in the mid-axillary or anterior axillary line, and post-operatively, patient is almost pain-free with a normal paracetamol tablet for 3 days and discharge on the 5th day. So this technique is safe, reproducible, especially in young patient with good cosmesis. Thank you.
That was truly a heroic effort, I would say. And one has to go out of the comfort zone to perform it. Call on the next speaker, Dr. Priyank Bhatt.
Take me.
Good afternoon, everybody. I thank the organizers for having me here and inviting me for this talk. Actually, I had kept it very simple, as the name suggests. I had simplified this talk, thinking there will be students in the audience, but I see most teachers in the audience. But anyway, I am Priyank. I work at Sal Hospital here in Ahmedabad. I will be speaking on mini mitral valve repairs. Yeah, so mitral valve repair is a technical surgery. We all know it needs understanding of the anatomy and physiology of the mitral valve, and also very good surgical decision making. Attempting a repair in a very complex fashion, or a very bad valve, a rheumatic valve, and then it failing, and then after 4, 5, 7, 8 cardioplegias, changing the valve, and subjecting the patient for a long surgery, warrants some consideration. We will be looking at 2 aspects here: mitral valve repair itself, whether open or mini, and of course the minimal part of it. So these are the conventional incisions, but for mitral valve we are going to be using most of the times the 4th space thoracotomy. One must get very familiar with the standard mitral valve repair, first by sternotomy and then by minimal invasive, the straightforward replacement. Some of the complications of mitral valve surgeries will be very difficult to manage by the mini approach, like LA appendage injury, whether you have retracted in for the clot removal or while the cross clamp, tear of the groove, or circumflex injury if you suspect it or you encounter it. All these will be very difficult to manage. So good skill as far as the mini and a replacement of valve is required here. Also, one must be very familiar with the knot tying with the knot pusher, because your fingers are not going to reach inside so far away. It will be very difficult otherwise, and if you are trying to push and pull with the hand tying, you may avulse the suture or unnecessary cords, tears, which are very dangerous. I wanted to highlight this as a part of mini, to show that cannulation is probably the most important. Once you are safely cannulated, half the surgery is done, so to say. I cannulate the femoral vein first. Basically, it's a little, it will make the artery sit on the cannula of the vein. The cannulation of the artery will be little easy. Always cut the adventitia over the dilator or over the cannula. Most of the times that is the resisting or restricting part, as when you are trying to push the cannula inside, and undue force may again avulse the artery or tear it. We take the 6-0 purse string around, big purse string around the artery or the vein, and insert the cannula. Just snug it so that there is no bleeding outside. The distal limb perfusion is taken care of, and at the end, if the vein is big enough, you just tie it off, and there won't be any need for repair, especially in the vein. So this is how I cannulate. Just a quick video that the needle, over that the guide wire. Of course, this is done under TE guidance. So the anesthetist is monitoring the guide wire inside. This is the dilator. So dilator is just, it has just gone inside a little. It has dilated the orifice. I mean, but then you use a 11 blade and cut the adventitia above it, so that it will go very easily. Now the dilator can be pushed little more inside very freely. And then the cannula itself, the vein cannula. As you can see, I will be pushing the lower part of the vein so as to make the vein little straighter, and of course with the screwing motion, the vein cannula will go in very easily. It will slide in if the adventitia is cut properly, and the vein will sit inside. The same thing, this is how it will look. The vein in this, the cannula will be across the right atrium into the SVC. So, it's a dual stage cannula, it will drain both. This is how you put the arterial cannula. It's the same way. Ultimately, this is how the cannulation will look. Both the purse strings are snugged and tied. So there are newer generation cannulas which have side holes, so that it will be easy to cannulate. They will glide in easily. Of course, they have side holes, so the perfusion will be better. And by one size smaller cannula, you will achieve the same kind of flows. So, it will be easy to even cannulate smaller arteries. Vacuum assist, Dr. Prasanna, I don't know if he's here. Otherwise, he is the big proponent of vacuum assist for the venous drainage. Works wonderfully well. You can do it with the same one cannula. It will drain the entire heart. If one is not comfortable or not sure or has a shortage of cannulas, only single stage or something, you can ask your anesthetist to put the SVC cannulas under the USG guidance. It will save time because you don't have to cannulate from the inside. Of course, there will be 2 cannulas, so the drainage will be better. If at all you have to go superoseptally, then it will be easier to snare the SVC. And if you have put the SVC cannula either by through the same wound of the thoracotomy or from the ICD wound, it will still clutter the field a little. So it will be easier if it is put through the neck. I always use, nowadays we use del cardioplagia, so that, it will last for the surgery. No need to repeat and stop the surgery, repeat the dose, unnecessary. The retraction will go in a mini patient, and, it will save a lot of cumbersome steps. In a smaller LA, for better exposure, superoseptal approach or even extend it on the roof is a excellent approach. It will open up the entire mitral valve and subapparatus. The analysis of the valve is also much better, much easier. Always, if you are going superoseptally, cut the limbus anteriorly so that the conduction damage does not happen, and then advance it towards the flow. Of course, whether it is open or mini, you put all the stitches for the ring first, lift up the valve, and then start assessment from the P1, and it's the reference point. At this stage, in especially Indians, late presentations, bad rheumatics, if there is a doubt, if there is a dilemma, if one is not sure, it doesn't look good, there are calcifications, annular or valvular, you have a perforation, you don't want to repair, just straight away go for replacement at this stage, rather than wasting time. If you feel it's fit for repair, then repair will be in 2 stages, leaflet related and annular. So this is the open. I don't have a mini video of this, so I've just shown this, that the ring sutures are placed. For leaflet, either it will be a partial or limited resection or cord placement. Limited resection, though we have always, we are taught that we have to respect the leaflet, but a very limited resection is a very good operation. It will make the job very easy. It will, bring back the geometry, and also the repair will be durable. It is not as difficult or as dangerous that now the leaflet is gone. It's the limited resection actually is a more easy approach. Of course, we will support that leaflet with neocords. Complex procedures like chordal transplant or shortening, all this can be done. with time, with experience, this can be done. But placing a neocord and assessing the length and doing that is the probably easiest and the safest method, whether it is by PTFE or loop-in-loop technique. Length of the loop, of course, is the most important, the length of the cord. And for that, you take a pledgeted suture, tie it to the papillary muscle, bring it up to the leaflet level, then put a saline inject, bring the leaflet up to, the coaptation, put a Liga clip, and assess with a saline testing is probably the safest and most reproducible. The Lima forceps, as we call it, the angled Kirkland forceps, especially in a mini patient, holding the clips in place or removing the clips, it is easier rather than the straight forceps, because it will not come in the way of the vision. And clips may slip off and, get lost. The repair, of course, will be cemented with a ring. I use complete rigid and saddle-shaped ring for the mitral valve repair. I may sound dogmatic, but this is just the simplified version of it. Rather than wasting time in which ring and what, correct orientation and correct sizing of the ring is probably more useful in a good repair. Trigon to trigon matching and the leaflet sizing is what will determine the ring size. Earlier days, when the rings were, the leaflet was resected more, we had to probably undersize the ring a lot. But these days, we use same size or little bit oversizing, especially in myxomatous valve, to accommodate the respected leaflets. We have not removed them. There is a lot of tissue. We don't want to bunch it up together. So same size or marginally oversized ring is what will work the best. The rings come with holder and the ring holder itself and the apparatus holder. So apparatus holder can come out in a mini patient, but the ring holder should remain in place so that there is no distortion of the ring. Otherwise, it will tilt or it will conform to the mitral annulus, which is what we don't want. The ring holder, this is one of the things I have learned myself in a hard way, that ring holding mechanisms are different with different companies. Some have some switches, some just go in and you have to use your force to bring it out. So while, one should be familiar with these things before starting. So this is the holder and the ring is tied in place. Saline testing at the end is the standard method. At this stage, it is very important to check for the coaptation height. You mark the coaptation surface with the indelible ink, and then when you suck it off, you should see how much is the coaptation height. This is where most repair fail in long term, where at the earlier stage or at the time it looks good, but the height is not enough, and then over a period of time they will have recurrent MR. So this is the saline testing. We all have seen this probably, so that is fine. And I would lastly advise that don't forget to put the pacing wire when the heart is arrested. Once the heart has filled up or started beating, it is very difficult to put the pacing wire on the RV, which is on the other side from a mini operation. I thank you all for your attention.
Thank you. I'll call Dr. Rehan Sayed to present his talk on mixed deviation.
Good afternoon, everybody. At the outset, I'd like to thank the organizing team, Bhupesh, Gaurav, everyone for giving me this opportunity. My topic for today is MICS double valve or multi-valve repair or replacement. We have since moved on to being almost 100% MICS center, and we hardly do a stenotomy, whether it be a multi-valve or a cabbage valve, or whatever. Like everyone else, we thought we'll have students here, so some slides I will skip through. A couple of them are relevant. I think we'll start with something like this because most of us sitting here are, scared what's with the TAVR and the TAMR scene, whether we will even make it past most of these cardiologists. I think this is Marty Leon. He wanted to put us out of business in 2002. We are 21 years down and we are still very much in business. And this bus broke down in 2002. It didn't carry us much further. So a lot of definitions have changed in MICS. I think the last one where Glauber said that minimally invasive is not related to a specific procedure, but it's a philosophy that requires an operation, specific strategy aiming to reduce the degree of surgical invasiveness. My take on this, my rationale is to be minimally invasive, we have to do as less a surgical dissection that we need to be doing, limit the blood loss, less pain for the patient, early mobilization, lesser length of stay, better post-op recovery, better post-op respiratory functions, early rehab to functional activity, meaning he has to get back to his work. Better cosmesis comes last, and the reduction of cost also is something we need to look into. We'll skip through this because this is just the history of what MICS came through. But I think in terms of approaches, take home would be that you can't just simply jump into doing multi-valve, MICS without knowing how to do a sternotomy. I think then you go stepwise. You first get comfortable with partial sternotomies, be it upper or lower. Then you get then you can move on to the thoracotomies, like the mitral and even the right anterior thoracotomy for the aortics. Once you have done a good amount of these, then you can start venturing into doing double valves. Start off with the mitral tricuspid first, and then keep the mitral and aortic for a little later. And then the lateral thoracotomy or the lamellas technique, the Miami method, is a wonderful method, to do a double valve. It actually makes life very, very easy. I think Nitin showed you how the aortic can be done. Same incision, you just continue doing what the others are going to talk to you about, an endoscopic mitral approach. But first things first, this is what no one looks at. You first have to look at an X-ray. It gives you a lot of information. It tells you which space you need to enter, where is your aorta lying, is there calcium on the aorta, and in a time and place where we actually try to cut costs by not doing CT scans, we will be doomed if we don't look at the X-ray. Because if you go too low, then this operation becomes a living nightmare to perform, and it's not that easy. So you have to get your space of entry absolutely right, and that's where the orientation of an X-ray is very important. Personal opinion, I think everyone should get a CT scan. It is mandatory, and we can't back ourselves in today's time. If we go wrong and something bad happens to the patient, let it be some calcium on the descending aorta which you clamped and it embolized, or whatever it be. I think the CT, apart from telling you how easy the access to the aortic valve is going to be, it's also going to give you a lot of other information to your vascular access. So I run this CT all the way from the carotids down to the femorals, because it gives me an idea as to what I'm getting myself into. If the abdominal aorta is very badly calcified and it is diseased, then I would rethink my strategy. I would do MICS, but I would be aiming towards central cannulation, not through peripheral cannulation. So that also guides you as to how and where you need to go. So these, the distance from the chest wall to your aortic annulus, and the angle as to where this aorta is right-sided, or is it more on the left side, is it coming out too straight, that will tell you how easy this aortic valve is going to be. So we can start our journey doing an upper partial sternotomy. I am Cleveland Clinic trained, so this is what we did when we started off. You can do a J either to the left, to the right, you can do a T, whatever makes you comfortable. You can see that you have very good exposure of the aorta over there, and you see enough of the RA. That's how the cannulation happens. It's central cannulation, so that's the biggest advantage in this method. But it's still a partial sternotomy. It is not a non-sternotomy approach. But with this, just like Priyank had shown, you can go through a superior septal or a transseptal approach, and you can get good visualization of the mitral as well as the aortic valves. And it's pretty straightforward. We all do it through stenotomy. So this is the easiest way to start. And almost clamp times are the same as a full stenotomy approach. So this is one way. Then you move on to the lower partial stenotomy. This is very comfortable for a mitral tricuspid. You can also do the aortic, but I think you will have to make a significantly big sized aortotomy. Just leave a little bit of the posterior wall of the aorta so you can actually rotate the aorta towards you, and then you can, it's a video just to show you the approach, but this is a mitral tricuspid that I did, where I think almost 15 years ago this was. Through a lower partial stenotomy. Those days we used to do around 8 centimeter incisions. As years have passed, we have now come down to standardizing our incisions between 5 and 6 centimeters. I really don't go chasing the number 2, 3, 4 and those kind of incisional sizes. I think I would rather stay where I am at 5 to 6 and keep it comfortable for me and keep clamp times and CPB times down. As you can see, it's a superior septal approach, and you have a lot of comfort in repairing this valve. You get very good access for mitral valve repair, and you can do a good job of a mitral valve repair through this. I think this was an anti-relief-led prolapse, and we did a neocords. I'll move on to showing what we exactly do now. So now we've gone to doing a lot of the right anterior thoracotomy approach. We started doing AVRs through that, but now this is our incision, and that's the field that you will see. And this is just to show you how the REMA goes through it. We try to dissect it out and spare it as far as possible. And yeah. So this is with all the cannulas in place. If I feel that there is a diseased abdominal aorta, I will even centrally cannulate. Otherwise, right now it's a standard aortic clamp. It's just antegrade cardioplegia. I put the SVC also through the same incision, and I've just snared the IVC because I go always through a transseptal or a superior septal approach for my mitral valve. The aorta is open and the aortic valve is actually reasonably well seen. Okay. You have to get used to using also, you don't necessarily need the long instruments in this case, but single shaft instruments or monoshaft instruments give you a lot of space. So I personally would advise you to use monoshaft instruments because they give you a lot of freedom in terms, and as you can see, you have a very good picture of the aortic root, and this is like a standard aortic valve replacement. There is really no difference to it. I think it's the same video. We'll move on. Yeah, so this is how we lower the valve. Everything about this is the same as a standard. Once you get your soft tissue retractor, it actually opens this up quite a bit. There's been a whole lot of discussion on various groups, of the associations as to what is MICS and what is not. My take home for you all would be 6 centimeter incision, put in a soft tissue retractor to keep all the fat and everything away. It also improves visibility for you. And then you can just spread enough to give yourself some working space. Make sure that there are no rib fractures and there is nothing else that goes on over there. And then you actually are giving a true minimally invasive experience because there will be very little pain. We've been running for the last 10 years the SH36 quality of life survey on all our patients, and we've got actually a very good feedback on it from most of our patients. This is actually a triple valve that we did. The mitral, I don't have some clips of, but we did the aortic valve. We did the mitral first, it was a replacement, then did the aortic, what you saw, and then did the tricuspid ring annuloplasty. He is a patient with renal failure, status post renal transplant, whose kidney has failed and was waiting for another renal transplant. He got transplanted 4 days ago and he's doing well. So within 20 days of this surgery, he's been able to go and get transplanted. It's not possible if you do a sternotomy on these patients. It'll take a long time to heal by itself. That's the patient, and so that's basically the scar. It's around a 6 centimeter scar, and This is the right anterior thoracotomy standard. This is another method which is really handy. Once you get used to this, you kind of get very addicted to it because it's very, very comfortable once you start getting used to it. Except that you have to live out of the long instruments, and you may on and off need the use of an endoscope just to ensure that your knots are tied down properly and you're not missing out on something. The one pitfall though I find on a personal basis on this is that I'm not able to actually oversize or even appropriately size my aortic valve. The tendency on the aortic valve is to go one size smaller because you want to see how you're tying the knots. I think that's the only problem that I see, and that I think will be overcome as you keep doing those cases. It's more about doing more numbers of that. So this is a picture just to show the position. For a male patient, it's pretty easy, a thin male. But if it's for a female, you can go this way. Just take the middle of the sternum, draw an imaginary line, and that becomes the point of your incision going towards the axilla. So it's very simple and straightforward. Lot of good pericardial stays, especially near the IVC, and then pull it out through the gutter. Don't pull it out dead straight, so you keep the diaphragm away. Then 2 towards the SVC-RA junction, 2 in between, and around 3 on the aorta. So you pull it up and it rotates the aorta towards you and brings it closer to you. He uses Del Nido, which is the modified version of Del Nido. I use the standard Del Nido and repeat it at 60 minutes. So this is the exposure for lamellas. Beautiful exposure, and I think Nitin also showed you how thoracotomy AVR exposure doesn't change. Mitral is standard. We've all been doing this mitral approach for many years now. So the mitral actually is pretty straightforward and standard. No difference to the mitral. You can do everything that you want, whatever complex repair you want. But the key here is the knot pushers and the long instrument. You have to be good at tying knots, or you have to have the money to use core knots. One of the two you have to do. And that'll be the end, the incisions and thing. But the caveat here is the arm positioning. Position is very, very important. Even now, I come personally to position my patients every single case. Because if that goes wrong, I'm the one who's going to suffer. The assistant is, the boys will just say, sorry. Just 2 minutes and I'll be done. So even data, a lot of studies, Lamellas has his own, he's done I think around 170 odd patients. He now has no criteria. He does everything, every valve operation through this approach. Be it a double or a multi-valve, he only follows this approach. Other groups have started doing concomitant AVR and mitral through this and have good results with good, with very low morbidity and mortality. So these are some of those papers. On the outcomes. We have done around 25 of them, and the results have been pretty good. We haven't lost a single patient, and an average length of stay is around 5 days. So in an era where we are chasing down TAVRs and TAMRs, if we don't move to this and give patients an option, we're going to be really struggling if we're going to keep offering only sternotomies for double valves. I think the future belongs to all of us who are going to chase it. We have now doing it endoscopically with long instruments. We at Manipal do a lot of robotic. I don't know whether there is a significant advantage at this point in time, except for the fact that there's a lot of dexterity to the robotic arm. Other than that, the pump times are very low. But we need to move on, and we need to see how we can master some of these opportunities. Thank you.
Thank you very much. It truly said that it's more of a psychology and mindset than a surgery. I call on Dr. Ram Prasad for his talk on total endoscopic valve surgery.
Where is this one? Good evening, everybody. I'm very happy to be here. I thank the organizers for inviting me to give a talk on total endoscopic valve surgery. It covers both mitral as well as aortic. I'm indeed very happy personally because my boss, Dr. Vinayak Shukla, is sitting here to talk in front of him. And everybody started to practice minimally invasive surgery. All valve surgeries, almost 30 to 40% of the people are doing minimally invasive now. But why do you want to go for the next endoscopic? It's like in a minimally invasive surgery, it's an individual struggle. That individual struggle is transformed into a team comfort when you do things which everybody is seeing. You have a better help from your team, and it's going to be a pre-robotic step at least. This is how I started. I came to Ahmedabad in 2018 to know what mix is. I came to Ivan Mehta, observed, went back. I was even terrified to cannulate the femoral, so I put everything inside, aortic cannula, cross clamp, things like that, everything so clumsy looking, so much struggle. End of the surgery, you feel why you did this minimally invasive for this 5 to 6 centimeter incision. So whenever we plan for a mix, we do bother much about the size of the LA, where the RA opens, where to open, whether to go one size above, down, size of the patient, all those things. In endoscopy, size doesn't actually matter much. Whatever is the patient size, there you can actually have a good visualization because your scope is there to guide you. And this is how the difference between you're doing a minimally invasive direct vision and seeing and doing. The difference between a video calling and hearing and getting something inputs. The team members have a better input in an endoscopic approach so that they help you in a better way. Basic requirements, one basic requirement is you need to have a good hand-eye coordination. That's a must. Other things are routine like mixed instruments, CO2 field threading, femoral cannulation, and you need to have a laparoscopic unit 30 and 0 degree. Initially to start the program you can do with the 0 degree, then you can go to 30 degree. Lung isolation is plus minus. Initially to start with, if you want to get a hang of the endoscope, you can isolate the lung and then try to practice the suturing, all those things. But once you advance on the program after 10, 15, 20 cases, you don't need to have a lung isolation. Directly go on bypass and do. It's not going to increase your bypass time. They asked me to talk on the tips. The tips for endoscopic program is only one: perseverance to adapt the new technology. Slowly you will get into it and then you will master it. Don't try to finish off the endoscopic surgery in the first thing. Endoscopic guided, you can take the help of the endoscope to tie sutures first, inspect the anatomy, then you start suturing inside. If you try to do it in the first, you will not be able to do it, because we lost the laparoscopic skills which we got trained in our general surgery. If you're keeping your VATS, or you're doing some VATS, then it is okay, it is lively. Otherwise, it is little difficult to get the hand-eye coordination. Otherwise, you just keep doing slowly, and then you will know. At times you will be able to master the suturing technique seeing the screen. Here in total endoscopic, we don't look through the incision working port at all. Anesthesia considerations are the same. I'm not going to go into a discussion of the anesthesia at all, because you need to have a proper bailout plan with your anesthesia colleagues in case some catastrophic happens. Single lumen, double lumen, as I discussed, it doesn't matter much. Which camera you need to start with? You don't require a 3D Einstein Vision camera and a 4K camera to start with. You can borrow one of the camera units from your general surgery colleagues or a surgical gastro and then start the program. As you advance on it, then you can have your own setup of it. Setting up of the theater is almost like a minimal invasive. Only thing is the anesthesia machine has to move way away, because your lap unit is going to be positioned, your pump setup is going to be there, your instrumentation, everything has to be. A typical theater with endoscopic program looks like this, where you have an TE with anesthesia people there standing in front of you, the scope and the pump setup and the instruments at the back. You can see the Boyle's apparatus pushed way towards the theater so that it doesn't come in the way for the people to come. You need to drape properly like a CABG, completely have in case some problem happens, you need to do a proper sternotomy. And mind you, patient has to walk home whether it is minimal invasive or sternotomy. The working port for the mitral depends upon the patient as well as your comfort level. It can be transaxillary also. I have done transaxillary mitrals, and it can be 2 to 3 centimeter. As Rehan said, not much people are behind numbers, but initially you can be 6 centimeter, 7 centimeter, 8 centimeter, get a hang of endoscope, then slowly, automatically it will reduce by itself, because you don't need to look inside it. This is how it typically mitral valve looks. And most of the time, initially, we were using a proper rib spreader and then try to spread it across completely. But of late, the last 15, 20 cases, we have not used much of the rib spreader. Pericardial opening is pretty much similar to that of the minimal invasive approach. You identify the entire pleural cavity, see to that there is no. Then you identify the phrenic nerve, go up to the aorta for you to cross clamp. And then in case of mitral or ASD or anything, you need to open the right atrium, you need to go up to the IVC. Otherwise, if you have a dual cannula going into the SPC, you just no need to bother much about the IVC area. This can be done in heart collapsed also, but it is going to increase your cardiopulmonary bypass time. So it's better to put a gauze piece and then try to do this initial things. The pericardial stays can be exteriorized to give additional exposure, especially in aortic valve, but don't take the stays near the aortic area in a mitral valve, because every time the scope goes in, it gives it comes on the way. So it's difficult to navigate your scope. Initially, to start with, you can start one of the small needles. Once you're comfortable with it, with the intracorporeal suturing, then you can go for a bigger needle size. This is for the cost constraint, I'm using a silk on a free needle actually. But initial times you can use the smallest needle possible so that you don't go and hit the heart when you are suturing it. The aorta has to be prepared a little bit. Just you have to dissect the groove between the aorta and the PA for you to accommodate, whether it's a signet clamp or it's a chitwood clamp. You need some space for it to accommodate. And aorta preparation is like you have a low cautery, go inside, and then just enough for the clamp to go across the aorta. That much is enough to dissect. You can advance on the scope and then go inside. Sometimes it will be very difficult to put a chitwood clamp because of the aorta orientation. You may need to put a signet clamp through the working port. Cardioplegia strategy is pretty much similar. If you are going to do a aortic stenosis or a mitral stenosis or mitral regurgitation, mitral repair, you can do a direct root plegia. See to that you take always a pleated stitch so that you don't get into trouble when you remove it. Once you are comfortable with your suturing, see to that the cannula is positioned, don't take the stillet out as of, and you have to cannulate in such a way that it goes in an angle, don't directly go. Choose one of the place which is more convex towards your side, so that gives a little better way not to hit the posterior wall. Allow the heart to beat when you are doing this, and it comes out through the working port. Cross clamping strategy, as I mentioned earlier, it can be either through the working port or through a separate stab incision. The advantage of this is you can go in and see whether you are getting a LA appendage or inside. You can just nicely put the scope inside and then clamp it. You can see that in mix, we used to put a small gauze piece on the LA appendage so that it doesn't get into your way or get into the cross clamp. LA opening and exposure, size of the LA doesn't matter much because your scope is there to go and then guide you. You have to dissect a bit of the Sondergaard's groove, just enough for the LA retractor to go in and then show you the mitral valve. See to that you don't dissect much in the right superior pulmonary vein area, because while closing LA it becomes an issue. Through a separate stab incision, you can position your regular LA retractor, angulate it in such a way and then fix it so that you can ask your assistant to go inside and have a beautiful exposure of the mitral valve. If you are planning for a repair, you need one of these insets to look into the subvalve apparatus. I am rushing fast because I have to show the aortic valve also. Then if you are planning to replace the valve, it's pretty much simple like our open technique only. First incise on the 12 o'clock position, start taking sutures there. As and when you cut, don't cut the valve completely, and then because you have something to give a traction for you to take stitches easily. Once you are done with your suturing, you can size, you can use the regular sizer. Almost all the company has got the sizes that will reach there. Then you can tie the knots with a knot pusher. Of late I am using core knot, but its cost to the entire surgery, it's around 70,000 rupees extra for the patient, but for 12 knots. The advantage of this endoscopic knot tying is your assistant and the entire team will be able to monitor your knot, and they can see the boating of the pleasure, and everything can be seen by everybody. If there is any problem, 4 sutures. Mind you, in the right superior pulmonary vein area, where there is a blind spot, even in the endoscope will not be able to see you, which is on your side. Your tendency to take the posterior wall of the right superior pulmonary vein is there. So in that particular area, try to evert it. Try to evert the See, this is the particular stitch which I told. You have to just invert it, see to that you are not taking the posterior, and then take it, because that place even in endoscope you will not be able to see. It's a blind spot in endoscope also, although we see everything inside. Drain placement depends upon what you expect. Mostly I put one drain, draining both pericardium as well as the pleural cavity. It's always better to have a couple of stitches on the thymic area, so that you don't have to have a problem with hemostasis or later. The surgical scar, it can be, this is a transaxillary, it's roughly 3.54 centimeters. And especially in a young female with a mitral repair, it gets covered under the axilla, or you can put anterior also, whatever you are comfortable with. As you advance on the program, the scar shrinks by itself. We don't intentionally do it. It's actually 3 centimeter now, mitral valve replacement. So coming to totally endoscopic aortic valve replacement, there is no need of rib spreading, and no need to worry about which space, no need to worry about the angle where the aorta is placed, or where is the remo is almost always saved, and you can do transaxillary also. So this is a video of this is a right anterior thoracotomy video. That's how typically it appears. Working port is done, 10 mm scope is put, and you can, under guidance, you can put the 5 mm scope. You can inspect the entire pericardial cavity, the pleural cavity, and then open up the pericardium. In aortic valves especially, you have to open the pericardium way up to the aorta, and if the thymus is too bulky, just remove it, don't try to cauterize it. You put one of the smallest possible soft tissue retractor to give a better exposure through the working port. You start scope, not through the, initially there will be at times difficulty where you have to look into it. Slowly you will get accommodated, and then you will feel you are more comfortable looking into the scope rather than looking through the incision or through the working port. 2 more minutes, 1 minute maybe. That's how the LV vent is put. Once this is done, this particular case is not stenosis, I think aortic regurgitation. So I'm opening up the aorta directly. Under vision you can give the cardioplegia, as Nitin has already shown. You can cut the aorta. See to that the other lip of the aorta is sutured to the pericardium to keep the aorta wide open for you, for the scope to go inside and then guide you in the valve replacement. And it's preferable to do it on the right side first, so that it keeps even more the aorta open for you to do the rest of the surgery in a little easier way. That's a left coronary being cannulated osteoplegia. Once that is done, this is what I told, the aorta is being fixed to the pericardium. Generally in open surgery I use non-pledgeted, but here to be doubly sure, known to have a less problems, we use a pledgeted stitch. And of course if the annulus is very small, we need not, I'm not doing many actually. Once the suturing is done, you can size with the regular sizes, whatever valve you are comfortable with. Here I think Merrill has come out with a little longer sizer, I think, the Miltonia. So once that is done, the valve of the whatever size is there, you can tie it. The core knot helps here also, but only thing is you need to take only 12 stitch, because if you want one more core knot, it costs another 70,000 rupees. So you have to manage with 12 stitch, or else you can, if you are using regularly, then you will have 1 or 2 extra which can be used for the next patient. Otherwise it costs very much. Once this is done, aorta is closed in 2 layer, preferably with a pledget for a proper secure hemostatic. Throughout this surgery, either in mitral or aortic, we use CO2 field flooding to reduce the risk of air embolism. Just a minute. I think one talk is cancelled. 1 minute. That's how the final incision is. So time-saving tips in endoscopic surgery is every time you take out the scope, put in the scope, soak in the hot water, and then try to get your field aligned. After 20, 25, 30 cases, I learned that that is not necessary. You have a working port, take a hot water through the syringe and just try to flush out the area of the camera. It gets, hardly we take it out nowadays, because every time you take it out and then put, that is the most time consuming thing which extends your operating time. Initial cases don't restrict your incision, and of course you do have to weigh between danger and safety. This particular patient, happy that we have finished with 2 or 3 centimeter incision, but after 12 hours he started to bleed. We have to do a sternotomy. It was light pleural bleed, which intercostal was bleeding. So contraindications, any lung adhesions, difficulty in bypass, redos and concomitant procedures, I have not at least encountered, started to do it. For the young people, I tell, please pick up endoscopic work arena. It is easily reproducible after the initial learning curve, and it's going to be a pre-robotic step. Thanks for the kind opportunity as well as listening.
Thank you very much. Questions from the audience? I think we'll conclude the session. Thank you very much.
Thank you for this session. May I just request the chairpersons to hand over the memento to our speakers. May I request Dr. Nitin Rajput, Dr. Priyank Bhatt, Dr. Rehan, and Dr. Ram Prasad to please come on stage and Dr. Priyank, Dr. Nitin. Just wait for a group photo. Priyank, just wait for a group photo. Dr. Nitin. Dr. Rehan. And Dr. Ram Prasad. Thank you. Thank you everyone for a wonderful session on the minimally invasive cardiac surgery. While we'll have a tea break after the next session. Let's move on for the final session before the inaugural ceremony. This is the hybrid era, and may I request our chairpersons, Dr. Prasanna, is he back from the EC? Dr. Surpreet Chopra, Dr. Shamsher Singh, Dr. Zain, all in these. Oh, okay, okay. May I request Dr. Mehul and Dr. Anil Jha to chair this session on the hybrid era. And Dr. Vinayak. He's coming? Three of you, please come on.
he's speaking on hybrid heart surgery, the way forward for cardiac surgery. Dr. Ajay, please.
Forward, backward, huh? Yes. And pointer है क्या कोई? Right, right. Okay. So, I'm coming from, the last meeting was in Chennai. Is it okay now? Yeah. I was yesterday in Chennai and very depressing scene. I mean, it was full, the hall was full on TAVR meeting, and I think most of the surgeons are there. So, unfortunately, this is the fact. It was overcrowded with lots of people there, so sad scene. Now, see, new technologies have always shaped the field of cardiac surgery. You know, Gibbon, he is a surgeon. He gets an idea, he goes to an engineer who executes it, funded by the industry, and then used by the surgeons all over. Who designed the first LVAD? You know, it was Liotta, Dr. Liotta from this Texas Heart. So all surgeons did wonderful work in getting all these things done. Unfortunately, nothing has, there's no new invention after this. These are all long list of things which have been done. Cardiac surgery in 90s, when I was a student, we had bileaflet valve and we had membrane oxygenator. And what do we have just now? Exactly same thing. For the last 20, 30 years, you have nothing. We should be ashamed of this. I'm telling you, I'm very unhappy to be a cardiac surgeon in this era. This is the bad time. We have nothing. We have a valve, a decent valve that is called Percival. You know what is Percival? Percutaneous valve. That is Percival. It was made for a cardiologist. He didn't use it, so it was given to a surgeon. And we still don't use it. So I'm really unhappy about the progress, the way we are going in. Our patients are more and more old, fragile. So we need to be really non-invasive. That's the way forward. Popularity of PTCA, Kunal said lots of things about how good the bypass surgery is, but that is for discussion amongst ourselves. If you go to a patient and show him all these papers, he says, nothing doing. I just don't want anesthesia. I don't want a cut. I want to go home tomorrow. Can you do that? No, I'm going to a cardiologist. Try and understand these things. So, reduction in the volume, decline in the number of patients. So, radical change is necessary. Radical change. Now, see, I do know, let's not get, people who do minimally invasive surgery don't get offended. I call it MICS, maximally invasive cosmetic surgery. It's maximally invasive for the surgeon and it's a cosmetic surgery for the patient. It gives you a little bit of pain relief, but I am not very happy about it. I am really confused. If you want to compete with a cardiologist with MICS, you can never do that. This is in BM Birla, some 20 years back, we have done this procedure, minimally invasive mitral valve replacement. We have seen all these results. This patient came to me for follow-up after 20 years, and he's doing absolutely fine. This is total Lima-Rima Y. So I am doing minimally invasive surgery, but I am not happy about it. This is Lima-Rima Y, 3 grafts. This is a pediatric. This is sub-aortic VSD with aortic regurgitation done minimally invasive. This is triple valve, mitral, aortic, and tricuspid valve repair. Lots of other examples. I don't want to go into that. There is a small cut. A very good thing is no midline sternotomy. That's a good thing. But I don't see any advantage beyond that. We need to change. Please try and understand. If you continue with these meetings, there's a MICS meeting. All rubbish. It is a good procedure. We have to continue with that. Youngsters should do it, but try and go to something else with which we can compete with the cardiologist. We are not understanding that. Our previous generation surgeons who gave us all these things, they actually, research and using new technology is very important. There's a meeting on Osake, there's a meeting on Ross procedure, Lima, Rima, why. Technically these are difficult operations. Try and make them simple so that all of us can use it. We are very happy. In a meeting, tu Lima, Rima, why karta hai kya? Main to karta hu. So I am happy that he doesn't know how to do it. That's a wrong approach. You should make operations so simple that everybody can do it. Now, cath lab is not the only way. We always show photographs. We are in the cath lab. I'm really depressed. Why do you do that? Nobody has an access to a cath lab. Cardiologist won't allow you to enter inside. So there is a way out. You try and develop a cath lab in your operation OR. I'm running through this. I will tell you what exactly is this instrument. We can do lots of things in the OR. This is a BenQ table, a decent table. You get some Chinese table also. You get a Zeem machine, is very good for fluoroscopy. It has a replay facility. If you have all these machines, you can do everything. This is my OR. You can do everything except in coronary stenting. So this is, cardiologists had lots of problems with TAVR, paravalvular leak. They didn't do that, angulate the valve in this way, I can do it this way, you can't do it. They just approached the industry. They said just put a skirt down there and everything is sealed. Make it simple. Make your operations simple. Don't go for this complex procedure. What is there? I mean, you should have operations which everybody can do and produce good results. Divide your procedures into two categories, coronary, non-coronary intervention. Never try and step on the coronary side because then cardiologists will be after your blood. Stay away. Structural heart, the cardiologist started doing only 10 years back. So we are not late. We should start doing it. Now, this is a long list. I don't know whether you can see. See, 80% of the procedures were done by the surgical team. These are cath lab procedures, complex. We have in last 10 years done around 800 interventions, everything. Now, I'm coming to this. This is a patient who had come, thrombolysis failed, everything bad. Can I play this video? Now, how can I play this video? Yeah. Now, I'm just trying to show you that this is CAT8 indigo device where I sucked out all the clots from this patient. And this will show you, this is the image later on. He was in a very bad shape. And this is afterwards the inferior vein. See, everything is gone. And you could see in that, this is IVC filter I put later on just to prevent the further embolization. Now, this is another in which we are doing pacemaker implantation. This is CRTD. I'll just run through this so that we don't. And this is done in the OR. It's not done in cath lab. Okay. This is CRTD that was put. Next one. Now, this is another peripheral. I'm just showing you the spectrum. It will increase your numbers and you don't have to depend upon cardiologist or intervention radiologist for these. You can do all these procedures yourself. This is one of the patients where we did peripheral intervention. Now this was popliteal artery which was blocked. We could have, we tried to do, it was, Fogarty was done somewhere outside which failed. So we had to go. Now this device is Supera stent, which is from Abbott. You can use Covera, Subera with all sorts of dilators. So we first did dilatation, and see this is my team of people who helped me in this. Some of them are cardiac surgeons who are getting trained in interventions, and this is the end result. Next is, this is my favorite thing. This was a patient where I put LVAD around 8 to 10 years back. He was absolutely fine, but he had a psychiatric problem. He always was scared that if he forgets to recharge his LVAD battery, he will die. So he told me, sir, please remove this. I told him, no, I'm not going to remove. I tried to convince him for 2 years, and finally he said, I'm going to commit a suicide if you don't remove it. So I was forced to do that. So what we did was, this was, now, see, I'm very proud. My team designed this. And this is designed by the surgeons who planned. What we did? I don't know whether we can play this video. we have put a Amplatzer device in the, I can't play it. Can we play this one at least? Yeah, I think we can. Can we play this? Where is it? Okay. What I wanted to show you is that outlet limb we had blocked with the Amplatzer device. We used 3 devices, and finally this patient did very well. He had a device in place. He survived for another 2 or 3 years, but later on died in an accident. This is another patient who had come to me. He went to All India Institute, Escorts, all sorts of places, and he had a PS, pulmonary stenosis, with ASD, a girl, 6, 7, 8 years old. So what we did was, in the OR, we did first pulmonary dilatation of this, and then MICS ASD. Now this is important to run. Can we? Yeah, see, this was a case of ASD, which was closed. They tried to close it in Chandigarh, could not do it. The device slipped out because the inferior margin was very bad. So I told this guy, I'll try and close it. If it is not possible, I'll do an MICS. Now this is the advantage. I told him I'll do an MICS closure. So this is our discussion with the cardiologist. This is our cath lab. We are trying to see the procedure. Now this is, the cardiologist is there who is showing me what exactly is the position of the ASD. See, this comes after we have done lots of cases. So this is the ASD device that is being, the sizing is very, very important. So I discuss with the cardiologist that what should be the size, how we should go about it. And finally, we come out to a definite size. He tells me that you should use a particular device, which we plan, we put it. And finally, we have done this. And this is the device. I don't leave it for a very long time. This is stuck with that, spine. And after I'm 100% sure that it's not going to get embolized, we release this. And this is the next one where we have released the device and it's absolutely fine. This is another case where, now there's nothing great in this patient. This is a case of, what do you call it? Thoracic aneurysm. The only good thing was that we were called as proctor to some other hospital by a cardiologist. So that made me happy. And this is now 5th case which we have done as proctor. But of course, these devices are not a problem. It is being done routinely. This is another case in which we did replacement of whole arch of aorta along with descending thoracic aorta. I was worried that the subclavian artery was very important, and this is debranching with you can see these branches going up. Then there is another case in which, I don't know whether I can, most of these videos, I can't play it. Anyway, this was a patient in which there was traumatic rupture of aneurysm. He came in the middle of the night. So fortunately, we got the grafts and we closed it. And this was done. Now this is a very, I don't know whether you can appreciate this, sorry. You can appreciate this stent. There is a stent here, this one, this. This was a case of anomalous, partial anomalous pulmonary venous connection. He had got operated somewhere in one of the hospitals in Punjab, and there was a residual defect. What I did was, you have these infrarenal aortic aneurysms. So one of the limb of iliac artery was taken here and fixed. I tried it 3 times. It slipped. Then I took a snare and pulled this out. And finally, this is what a surgeon can do. Let me tell you one thing. We can change the scene of cardiac treatment if we start doing interventions. It's very, very important. I don't find anybody. We see lots of videos. It's all nonsense. We really have to be passionate about it. This, later on I thought, why don't we do one thing? I fixed this with one knot. I fixed it here in the neck. And today this patient after 4 years is doing absolutely fine. No residual defect at all. So friends, what I want to tell you is, If you want to go for this, this is another thing, the OR, I don't want to go into details of this. Now, very important, if you want to learn this, see, this is ultrasound puncture of femoral artery. I don't know how many of you do it, but it's very important that you should know how to puncture the artery ultrasonic if you want to learn interventions. This is another case of cannulation. This is all done in OR. This is all done in OR. It's not done in cath lab. See, this is another, we have done angiography because the guide wire was not going through. And of course, there is then later ProGlide use. I will close it down. Cannulation. There are lots of videos, but no point in showing all that. My final slide is, understand one thing. Cardio, you know, when I joined Escorts, I was surprised. Merwal is, I don't know whether he's here. So Ashok Seth was, and all the cardiologists were learning TAVR at that time, just 10 years back. And who was teaching them? Thomas Moudin, who is a surgeon himself in France. Why can't we repeat these things? Thank you. Please think over it. Thanks.
Thank you, Dr. Ajay, for giving us a nice perspective. Actually, the line between cardiology and cardiac surgery is getting blurred, with the surgeons invading, I would not say invasion, but entering the cabinet. Thank you very much. Now, may I invite Dr. P.K. Deshpande for the next lecture. Disruptive Tech Hybrid Cardiac Surgery, the way to go. Dr. Deshpande, please.
May I also request Dr. Vinayak Shukla to co-chair the session with
Can you put me onto this slide? No, here. Slides presentation.
It's on slides already.
Oh.
It's on slide.
So what I do?
Forward. Yes. Forward.
Okay. At the outset, I thank IACTS and Techno College for inviting me to deliver this lecture in the plenary session. Thank you, Dr. Bhupesh Shah and Dr. Gaurav Goyal for organizing beautiful congress. At the outset, I bring greetings from Nagpur, where we started in 1985, and that's why I am here. And these are my guru who infused in me to become a cardiac surgeon, Professor Vikram Marwa, and those are the two surgeons, Mr. Cleland and O'Kane, under whom I trained in UK for 5 years at the Royal Victoria Hospital, Belfast. This is my team, and mostly it's a home team. All my real brothers, my wife, and my friends, surgeon friends, right from the surgical career days. This center was inaugurated in 1985, and I have been doing the cardiac cath since then, because when the patient is referred from the cardiologist to me for surgery, I just wanted to confirm that I don't get any surprise. So I used to do the cardiac cath myself, confirm that there is a step up of oxygen, and then operate the patient. So it is not that surgeon cannot do the catheterizations or interventional procedures. This is our earlier operation theaters. But then disruption is a critical element of the evolution of technology. Positive and negative aspects of disruption is a typical pattern, and we go for the better and better things. This is from the former president of Microsoft Window Division and Artificial Intelligence. I had 2 patients in 2008 when I had to refuse them surgery because the patients were not willing, because they were 94 years and 88 years with severe calcific aortic stenosis. And it was very sad for the surgeon not to operate the patient at that age, because the risk of surgery might be higher. That time I got this communication from Beijing, and the title was The Hybrid Approaches to Heart Disease. And to my surprise, when I attended, there were over 200 papers for hybrid cardiac surgery. So I thought I must go and attend it, and that opened the floodgates for me
I know this is the future of cardiac surgery. So my hybrid operation suite was installed on 20th/3/2010, which is a Siemens lab, and this was the first in the country and 37th in the world. Surgeries possible are one-stage CABG plus aorta biofemoral grafting. Completion angiograms after CABG, like the cardiologist, they show the stent opening up the artery after stenosis. Similarly, surgeon can show that the grafts are functioning. So it's a snapshot of your grafts. So I presented a data of 50 angiograms at our Poway meeting of IACTS. One-stage CABG plus renal artery stenting in the same sitting. Hybrid coronary revascularization, one-stage pulmonary artery thromboembolectomy and IVC filter through the right atrium itself, minimally invasive cardiac surgery, TAVI and the mitral wall-in-wall. Coming to the one-stage CABG plus aorta biofemoral graft, the 16 patients, there are 13 bilateral renal artery, 3 unilateral stenting, first patient in 2002. And the procedure was one stage of from CABG plus extra-anatomic ascending aorta biofemoral bypass graft with a ring PTFE conduit. It's a ready-made T graft. The first patient I prepared a T graft. One of the patients we did was one stage CABG plus aorta biofemoral grafting plus bilateral renal artery stenting in the same stage. All patients are under follow-up and doing well. And these are the pre-operative workup. These are the few operative photographs. The ring graft is sutured to the ascending aorta. How can you use the arrow? There with the proximal venous graft, and it is tunneled in the subcutaneous plane anterior to the abdominal wall, deep into the subcutaneous plane, lateral to the rectus muscle. And this is the, what do you click? How do you start the video? And this is the post-operative follow-up CT. Oh, right. Okay. Thank you. Does it work? It's not working. There it was working. Anyway, that shows the functioning graft. You have to stand here. The advantages are technically easy, along with bypass grafting on the ascending aorta. Tunneling is subcutaneous plane, and here one of the Australian surgeons said that why do you take 10 years? Because we presented this at the ISMICS meeting in Boston, and with a 10-year follow-up. And he said, why did you present it so late? One patient died on me because of the abdominal sepsis, because of the graft was taken through the peritoneum. And this would be avoiding the touching to the peritoneum at all, whether it is retroperitoneal, intraperitoneal or extraperitoneal. We go extra abdominal. And these are the various other combinations we did in our center. And this is the radiologist doing the renal artery stenting, and I take this message from Dr. Kaul to do it yourself. And I hope this runs. No, this is not running. I think none of the videos are running. That, can you help me there? It was running there. Can you click? Do you have to click here? Click there. Do you have to click here? No. Okay, then this was stented, and we have the I'm sorry for the video. The protocol is mentioned here, and then we had done, this gives a advantage of this, a one-stop therapy for hypertension. 2013, my son Dr. Swapnil, who is a cardiac surgeon from trained in PGI Chandigarh, he joined me, and then that was a really golden period, and he presented our work of this at the political meeting as well as at the International Coronary Congress in 2014. And the other thing is pulmonary thromboembolectomy. 4 patients, 3 patients had acute pulmonary thromboembolism and all had DVT. 1 patient had acute chronic DVT. This shows the branch pulmonary artery and distal artery thrombi, and so they required the surgical pulmonary thromboembolectomy and IVC filter, and then we thought probably why not do it together. And this was the I'll just try again. No. I'm sorry about that. So we did a surgical thromboembolectomy, post surgery completion angiography, and the trans right atrial pulmonary filter placement. And this was presented at the this is the IVC filter there. This work was presented at the World Society for Cardiothoracic Surgeons in Edinburgh by Dr. Swapnil, and the chairperson were Stuart Jamieson and Michael Madani, who are the father of pulmonary thrombectomy. In fact, doing the thromboembolectomy, intraoperative pulmonary angiography, and the transatrial IVC filter placement, now they have accepted this as a treatment protocol and have taken up this as a project for treatment guidelines at their center. Minimally invasive cardiac surgery, I think for this, the surgeon has to be well trained with the conventional way of doing it, because when you require a conversion to the sternotomy, you should be well versed with the basic technique of doing the operative procedure by sternotomy. We had done 34 ASDs through right mini thoracotomy, right thoracotomy, MVR, AVR, CABG, and there are 3 patients who required conversion to the thoracotomy, to the sternotomy. These are the various protocols. All surgeries were done in hybrid OR. The femoral cannulation is done under fluoro guidance. That reduces the subjectivity of the TE reading and also its potential complications. Sometimes even with ultrasound, the TE control, so one may perforate the IVC particularly. And here we can really put a guide wire and just shove the cannula up into the RA. The coronary completion angiography for all patients who undergo MRCS, CABG or hybrid coronary revascularization. This is important because when we start the minimally invasive CABG program, you have to make sure that even though you have been doing bypass surgery in a way, but you still have to confirm that by doing this procedure you have done a proper job. And in one of the patients who had a lima to LAD, had a ostial stenosis, and we had to redo it. We did an intraoperative graft angiogram that showed a narrowing, so we had to redo it, and then showed that the subsequent anastomosis, the graft is functioning well. So that is the advantage and beauty of the hybrid OR. Then there are a few other MICS procedures, and they were all presented, and we conducted a MICS aortic wall replacement workshop at the Deccan Cardiac Surgeons meeting, and these are the cases. Right coronary stenting as a hybrid procedure, but then cardiac surgeons had to be really progressive. They should not be ending up like a Kodak camera where it is not seen. So all the cardiac surgeon must learn the technique of doing the MICS surgery as well as go ahead and do the minimally invasive endoscopic and surgery. TAVI and TMVR, as Dr. Kaul said, many surgeons were in Chennai, and it's a big white elephant of the disease of the present for all of us. But please accept that these therapies are going to stay there, and have been proven to benefit in certain scenarios. In India, these two stalwarts, Dr. K.M. Cherian and Dr. Prashant, are the surgeon visionaries, and they did the first transapical aortic valve implantation. I attended one of that operative session at the Frontier Lifeline in Chennai, and they are really the one who started this minimally invasive program. I really thank them. And why do TAVI? Because the partner 1A and 1B trial have provided beyond doubt that TAVI is superior to SAVR in high-risk cases. For other groups, I think it is still a debatable point, and surgeon probably has a upper hand in it. Our protocol under 40 years, these are our protocols. And over 80 years, we will be advising TAVI to all the patients and redo patients where TAVI is possible. We had done 13 TAVIs, of which 7 required associated PTCA plus stenting, and there was one patient who had a mitral bioprosthetic valve degeneration requiring valve-in-valve procedure. And there was one patient who had a complication of hemothorax, hemopericardium requiring and cardiac tamponade requiring exploration, and then we had to do a sternotomy, and because she was bleeding from the posterior wall of the LV. I thank the TACS Academy of Cardiac Specialists, Dr. Vaijanath, Anantaraman and Gopal Murugan, who really have stirred the whole surgical fraternity, and they have started this program. Dr. Gopal Murugan, who is our mentor for the structural heart program in Nagpur. So you cannot be just shying away from cardiologists. You have to take the cardiologists with them, because they are the one who are going to help us. But then we cannot be just staying standby with them. And these are a few of the Evolute R and the Sapien 3 implantation. These are the two which we normally do at our place. And the mitral wall-in-wall. So don't be just standby for complications, do it yourself. And Dr. Swapnil, my son, is now into the TAVI operator being taught by Dr. Gopal Murugan. He will be there for standby, but the first operator will be a surgeon. So we really have to, as a cardiac surgeon, accepting TAVI is necessary, as it gives you all the approaches. So surgeon has the advantage of full total solution to a aortic valve disease. Cardiac surgeon and cardiologist and interventional radiologist should work as a team, as an aortic physician, for the better outcome of the patients. The other portions we have done is one stage CABG plus celiac artery stenting, CABG plus radical nephrectomy, aortic valve replacement with nephrectomy, mitral valve replacement with the tricuspid valve repair and the hysterectomy, TEVAR 2 cases, and pulmonary artery LA fistula. The future thing are the mitra clips, the paravalvular leak closures, TEVAR, endoscopic MICS, and coming up the robotic surgery. So I think the young surgeons have a challenging task. They have to learn a good basic open heart surgery by sternotomy, so that when conversion is required, you are well versed with the technique. But then you really have to learn and take good training at the center, which are doing the minimally invasive surgery, hybrid surgery, and probably the robotic surgery. So they must learn, unlearn and relearn, as it is a continuous process. Form a team and everybody progresses together. Cardiac surgeons should not be just surgery team leaders, but hospital leaders, the alpha. When we started our career, the cardiac surgeon used to be on the top, and all the medical practitioners would look at the cardiac surgeon as a specialist. So take just 1 minute. So take initiative proactively and solve the problems by innovative means. Innovation is about imagining the future in advance and implementing the new ideas to cater to the future needs. Better future for cardiac surgeons if they implement cutting edge technologies into practice, World is evolving. Keep learning to stay ahead of the curve. Replacing an existing and technology with new and better ones, bringing new disruptive products affordable to a large base of patients, upgrading the existing treatment options. So, but then they should be patient friendly economically as well. I think I'm sorry for the video, which really is the crux of presentation, but then it's beyond my. I think I had to think something about hybrid about this also. Thank you very much for your patient hearing.
Can I have a minute? I must congratulate Dr. Deshpande for this, because he may not remember, but Anil Patwardhan and I were there with him in Nagpur when he started doing these procedures. And when I went to his theater and all, I said, oh my God, he's doing such an extensive thing in such a small place. I almost, had a shock. But sir, you have really done very, very well. Congratulations.
Thank you. I appreciate that.
Thank you, Dr. Deshpande. Now, may I request Dr. Anumi Bagga to come forward. He will speak on the hybrid cardiac surgeon present in the future. She will, sorry. I'm sorry.
I have to sign So good evening, everybody. At the outset, I would just like to thank the organizers, especially Dr. Gaurav Goyal, for inviting me here as a speaker at the CME and expressing my views as a young cardiac surgeon. So I'll begin my presentation. So the hybrid cardiac procedure. Before I start, what is a hybrid cardiac surgeon? We all know that a hybrid cardiac procedure is a combination of a surgical and a catheter-based intervention. So like PCI combined with Lima to LED vessels, revascularization, or a concomitant valve replacement plus PCI. But this hybrid procedures, they require collaboration of a cardiologist and a cardiac surgeon, and maybe a heart team. But the reality is the heart team concept is skewed towards these cardiologists. So whenever heart team approach is planned, because they are the diagnostic leaders, so they are leaders in these heart team project also. So we need to change this concept. So there are so many papers in the literature that these heart team concept is actually skewed in favor of the cardiologist. So what is a hybrid cardiothoracic surgeon? So this is basically a new profile that we need to develop, which is a cardiac surgeon who can perform both surgeries as well as transcatheter interventions. So we need to change the concept from a standby surgeon to a hybrid surgeon. So as is the theme of the CME, that is we need to be future ready. So before becoming future ready, we need to answer these two basic questions. Will our skills be relevant in 5 years' time? And are we keeping abreast with the industry and the changes that are coming? So this is a young surgeon who is having this question whenever a CTVS branch is planned. So I think that is the main reason. So not many their candidates are opting for CTVS as a super specialist course. So because this is the future, and in fact the present also. So we need to get expertise in these catheter-based interventions. So it is a combination of the cognitive skills, the technical skills, the clinical judgment. We need to know basics about the angiographic equipment, the indications, the limitations, the complications, and the alternative treatment. As the earlier speakers also said, that if there is a complication, we need not be a standby, because we can, as a surgeon, we have an advantage that we are standby for ourselves. We can even convert whenever we need to. So the method of training can be proctored. If you have a case, the proctor can come and teach you. There is on-the-job training. There is formalized training as in the course, it can be as formalized into the course of our MCH curriculum, or it can be a supplemental training as in getting a fellowship course done, or a certificate of added qualification. So there are two ways. We have the fixed mount imaging and the mobile C-arm. So if you do not have access to this fixed cath lab, a lot of procedures can be done under C-arm guidance. So I will like to discuss a few cases. So as in the case scenario, this carotid artery stenosis. As surgeons, we are trained to do carotid endarterectomies. So in my institute, I'm lucky that in my institute, the cardiologists joined later. So I was the one, whenever the medical referrals were there, so the patients, the medicine people sent for my opinion. So I was the one who could decide that if the patient needed an intervention as in carotid artery stenting or endarterectomy. So this is a case of a 50-year-old male who was referred from medicine department with history of 3 episodes of CV in the last 10 years, and he was a known hypertensive chronic smoker. All his other investigations were normal, but his duplex scans showed right CC and ICA stenosis. So how do I play the video? How do I play the video? This one. Yeah. Can you play this video, please? So this is carotid DSA with the, I think I missed the slide. This is a carotid DSA, and then placement of, the next video please, placement of distal protection device, and the next slide. This is the carotid stent being deployed. This is a tapered stent with 4 into 60. So 6 is in the CCA and 4 mm is in the ICA. So this is the check angio post stenting. Next slide, please. So this is the carotid stent in place, and this patient was discharged on first post-op day. So this is case number 2, which is also carotid artery stenosis. But this patient had 35-year-old male who had history of CV and TIA episodes in the past. He was a non-smoker and non-alcoholic. The carotid Doppler showed 100% stenosis with extension into ICA. So this patient could not obviously taken up for stenting. So I did carotid endarterectomy in this patient, but still distal flow, the flow was not there from the okay. This is carotid endarterectomy being performed, but there was no flow from the circle of Willis. So embolectomy had to be done with a Fogarty catheter, and then the flow resumed. And this is the patient, but he was discharged on 5th day. Then another patient was referred to me from the medicine department with subclavian steal. They had diagnosed it with subclavian steals phenomena. He had pain in the right hand when he used to work. So he was basically a cobbler, and he had pain in the right arm whenever he used to lift his hand. So the pulses were absent, and on the ultrasound, there was subclavian steal phenomena present. You have to rotate it. Rotate कैसे हो गया इसको rotate ऐसे? Okay, this is I took 2 punctures from the right brachial and the right femoral, and from the right brachial there is no flow into the subclavian artery, and this is, I think the image has somehow rotated. So no flow into the subclavian from the femoral puncture as well. So subclavian stent was placed, artery stent was placed, and as traditional teaching would go, surgeon would always do a carotico subclavian bypass or a carotico axillary bypass. But as a surgeon, we can give option to the patients. Either we can do stenting, because it's a young male, 32-year-old male. So he was next day he was discharged and he was back to work in 2 days. So all these procedures are very good when we can offer them as a surgeon, because a patient doesn't know whom to go to. It is all that we have to build up an image that we are also doing interventions. So this was, I do my cardiac OPD as well. So this patient, 75-year female, she came with severe headaches and hypertension, and she had severe headaches at night. So she had 6 sinus syndrome on a Holter examination. So a dual chamber pacemaker. Whenever the patient comes, I do pacemakers myself. I do not refer the patient to the cardiologist. So this was another patient who came in the OPD with altered sensorium. So he had complete heart block. So I immediately put temporary pacemaker, but in 2 days his rhythm reverted. So, but I had to refer the patient back to the cardiologist so stenting could be planned. So initially, I am doing this. I have to send the patients, but most probably planning for cath angios, diagnostic angios myself now. So I do regularly these peripheral interventions. Can you play this video? This patient came to my OPD. Can you play this? Cannot play it. So, I don't know. The next one? We did not take it. So, we'll leave it. So, anyways, as the traditional teaching tells us, we do femoropopliteal bypass, but in that patient, I had done SFA stenting. So, this patient had an iliac, right iliac, common iliac stenosis, but in this patient, I did a femoral bypass. So, anyways, at the end, I would just like to say that knowing is not enough. We must apply, because the era is of doing transcatheter interventions as in aortic valves and mitral valves. And as young surgeons, we cannot obviously leave the basic fundamentals. We need to be adept with the open procedures as well. We have to know it so that we do not need to call some other person while we are stuck. But the interventions is the norm now, and we need to be actually future ready, because this will be the basic now. So thank you so much for giving me this opportunity to tell all this. Thank you.
Thank you, Dr. Anil. We'll have 2 of the talks after the inauguration ceremony. So in conclusion of this part 1 of this particular session, may I request you to hand over the mementos to the speakers. May I request Dr. Ajay Kaul, Dr. Deshpande, and Dr. Anumit to please come on the dais and receive the mementos from Dr. Vinayak Shukla and Dr. Anil Jha. Dr. Ajay Kaul. Dr. Deshpande. Just wait on me. I remember that I met you, sir. I came to Nikunj's mother also. Dr. Anumit. Can we have a group photograph? Thank you, sirs. We'll prepare for the inauguration ceremony. Thank you.
जनगण मन अधिनायक
जियो सिनेमा पे टाटा आईपीएल सब देख रहे हैं। ये और ये भी। तो सिम कोई भी कंपनी का हो, टाटा आईपीएल देखो जियो सिनेमा पे बिल्कुल फ्री।
What makes Yas so खास?
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
I welcome all the cardiac surgeons, and I congratulate Dr. Bhupesh Shah and his entire team, the organizing committee, that they are organizing a very big scientific feast here. I congratulate all of them, and they are proud that India, the gadgets now we are making, it is on the view of the Atmanirbhar Bharat. These gadgets are having the same quality, but having the cost effectiveness also. So I congratulate the industry also. And being a surgeon, I feel delighted to attend this mega scientific conference in the city of London. I again welcome all the delegates who are coming from all the corners of the country. There are more than 400 delegates, that is what is told. They are from the different part of the country also. And some of them are from abroad also. This is the objective, it is a cardiothoracic surgery. This conference is regarding the heart. That also, the renowned surgeons are going to participate in it. It is for the betterment of technique, betterment of gadgets, and we can deliver very good result, better result by state-of-art gadgets.
Very good evening to all of you. I welcome you all in the inauguration ceremony of IACTS TECHNO College CME 2023. I'll ask Dr. Bhupesh Shah, the organizing chairman, to escort Dr. Mahendra Munjapra, our chief guest, on the dais. He is Honorable Minister of State for the Ayush and Minister of State for Women and Child Development. Invite our guest of honor, Dr. Kirit P. Solanki, on the stage. I'll invite Dr. Neelu Bajpai, Executive Director of National Board of Examination in Delhi, on the dais. We also invite our honorary guests, Dr. Darshana Deshmukh and Dr. Payal Kulkarni. I'll invite Dr. Lokeshwara Sajja, IACTS President, on the dais. Dr. C.A. Chirimath, the Secretary IACTS, I'll invite him on the stage. I'll ask Dr. Gaurav Goyal, the Organizing Secretary, to felicitate all our guests. Dr. Kirit P. Solanki. Dr. Meenu Bajpai. Dr. Lokeshwara Sajja. उस तरफ. To Dr. Hiremat. Dr. Payal Kukrani. And Dr. Darshana Deshmukh. And our own Dr. Bhupesh Disha. Now I invite Dr. Bhupesh Disha, our organizing chairman for this Techno College, to please give a welcome speech.
Good evening. I welcome all my students, teachers, faculties, all IACTS committee members, ex-president, current president, Dr. Lokeshwara Rao Sajja, and Dr. Manoj. These are wonderful evening in a Hotel Hyatt with more than 400 delegates, and we have two esteemed speaker, invited guests who are busy in their practice, but they have devoted their life for social services. I welcome all of them. Today we have a special guest, Dr. Mujpura. He is a Minister of State for Ayush as well as the Women and Children Development. He carries budget of more than 4 lakh crores in his hand, and Modi sir, he put more faith in him, and the budget to spend for the society which was doubled up. Give great hand to him. We were fortunate enough to stay together in hostel for 3 years. We were just staying nearby the room. Today we have another case, Dr. K.P. Solanki. Today is a special day for me because I have two extremes, one senior and one junior. Dr. K.P. Solanki was my teacher. We learned lots from him. He was dedicatedly and passionate about the surgery. But when to retire, that's what he decided, and he is on the path of the social services. In audience, I think more than 20 or 30% students he generated, and most of them are in cardiac surgery. It is proud for us to have a great teacher like him, and now he is in social services. We have two another guests, Dr. Darshana Deshmukh. Her father was a great social worker of Bharuch district. They served for many decades for BJP, and now she is also in social services. She is a MLA of a Statue of Unity, Kevadia colony, where the all poverty and union territory like this region which is developing, and it is the fastest development all over India for tourism is concerned. Give big hand to her to develop that part and taking this world over with this Statue of Unity. It's the tallest statue in the world, and the development which is going so fast, it will create like a heaven in coming years. We have a Dr. Payal. She is still appear, she will appear for FD anesthesia. She also work in my unit. We worked together for 3 years, but the family background was so strong. Her grandfather was a great Jansanghi, dedicated person. He also went to jail for a couple of years, and she got the opportunity. Give big hand for the future, because she will carry the longest future for politics is concerned. I am thankful to our all AEC member for coming here and making this event wonderful. I am thankful to each and every industry. They supported since last 1 month, day and night, without seeing any time, and financial support. Thank you, everyone.
I'll invite all the dignitaries to please move forward and we'll ignite the lamp. यहाँ लेता हूँ लो एक जलाओ ना Now I'll invite our chief guest, Dr. Mahendra Munjapra, to please say a few words.
Respected Dr. Professor Kirit Solanki, Member of Parliament from Ahmedabad and teacher of the most of students, Dr. Minu Bajpai ji, Dr. Darshana Deshmukh ji, Dr. Payal, Dr. Bhupesh D. Saha, Dr. Abhishek Saha, Dr. Gaurav Goyal, Dr. C.S. Hiramath, Dr. Lokeshwar, and all cardiothoracic surgeons, persons from pharma industries, and all delegates. First of all, good evening, Jai Jagannath, Vadekam to all of you. It is a pleasure to be here amongst you all highly committed and talented cardiac surgeons. I have been briefed by Dr. Bhupesh Bhai about the activities, the concerns and the challenges faced by the association and cardiac surgery community at a large. In a short span of 4 decades, with your efforts, cardiac surgery has developed as a treatment modality and has reached to a point where all can be proud of our achievements. From a few centers, today your efforts have made cardiac surgery available to masses and served the people of country to the best possible outcomes. Friends, as we celebrate our achievements, we also need to be aware of challenges and start preparing to address them. I am happy that IACTS has taken cognizance of the matter and this CME is addressing many such issues. The challenges which we see are related to capacity build-up, which we are working by building new medical colleges, nursing colleges, and institute like All India Institute of Medical Sciences across the country. Skilled manpower is being addressed by Skill India program to make a full skilled and employable youth available to cater our own needs. Equipment related challenges are being addressed by giving due impetus to build capacities to manufacture medical equipment under Atmanirbhar, and medical equipment policies are being built. Immense coverage and penetration has been increased by PMJAY scheme. We are aware of issue related to it, and I can assure that it is a work in progress to make the scheme more inclusive and a win-win program for both service provider and the service taker. Friends, I assure you that the present government always has an air of on the ground, and your impetus and inputs and feedback are not only important but also form the basis for future policy decision. I wish you all very best. Thank you. Jai Hind.
Now I'll request Dr. Kirit P. Solanki to please say a few words.
मित्रों, आज इस सभागार में इंडियन एसोसिएशन ऑफ कार्डियोथोरेसिक सर्जन्स की नेशनल कॉन्फ्रेंस में हम सब के बीच में उपस्थित हमारे आयुष मंत्रालय के मंत्री और लोकसभा में मेरे साथी श्री डॉक्टर महेंद्र मजपुरा, यहाँ उपस्थित सभी देश के जाने माने कार्डियोथोरेसिक सर्जन, मंचस्थ सर्जन, इस ऑर्गेनाइजिंग कमेटी के चेयरमैन और हमारे मित्र डॉक्टर भूपेश भाई, यहाँ सभागार में उपस्थित सभी कार्डियोथोरेसिक सर्जन। पहले तो ये कॉन्फ्रेंस मेरे संसदीय क्षेत्र में संपन्न हो रही है, इसलिए मैं आप सभी का हृदय से बहुत बहुत अभिनंदन करता हूं। मैं आप सभी का हृदय से बहुत बहुत धन्यवाद करता हूं और स्वागत करता हूं। मित्रों, मैं यूँ तो आई एम ए मेंबर ऑफ पार्लियामेंट फॉर लास्ट 3 consecutive terms एंड आई एम इलेक्टेड, मगर जहाँ तक हमारी बात है कि हम पॉलिटिकल पर्सन है, मगर हम मूल मेडिकल अखाड़े के व्यक्ति हैं और आप और हम एक ही अखाड़े से आते हैं। तब यहाँ जब मुझे इनवाइट कर दिया तो मुझे बहुत ही अच्छा लगा कि अपने बंदों से बात करने का मौका मिलेगा और आप सभी को मिलकर मुझे बहुत ही अच्छा लगा है। मैं आप सभी का पुनः अभिवादन करता हूँ। और मित्रों, मेडिकल जो टेक्नोलॉजी का सवाल है, जब हम प्रैक्टिस करते थे तब टेक्नोलॉजी इतनी ज़्यादा नहीं थी। शुरू में टेक्नोलॉजी आई थी, हालांकि हमने जो मिनिमल एसेस सर्जरी उस वक्त हमने आई हैव लर्न द लेप्रोस्कोपिक सर्जरी या मिनिमल एसेस सर्जरी बाय अटेंडिंग सच CMEs एंड लाइव ऑपरेटिव वर्कशॉप ऑल्सो। सो मैं मानता हूं कि इस प्रकार का साइंटिफिक प्रोग्राम हम सबके, चाहे वो टीचिंग हो चाहे वो ब्रदरहुड हो, इसके लिए बहुत ही इम्पोर्टेंट बात है। और जो इस प्रकार की जो होती है कॉन्फ्रेंसेस, हमने पूरे देश में, जब मैं सर्जन था तब आई यूज टू नेवर, कभी मैं एक कॉन्फ्रेंस मिस नहीं करता था और हम सब मित्र वहाँ जाते थे और उसके जरिए हमने बड़ी बड़ी सर्जरी सीखी है, चाहे वो पेंट्रियाटिक सर्जरी हो या लेप्रोस्कोपिक सर्जरी हो या एडवांस लेप्रोस्कोपिक सर्जरी हो। जहाँ तक मेडिकल इंस्ट्रूमेंट का सवाल है, हम लोग देश की लोकसभा में या पार्लियामेंट में, संसद में, दोनों सदन में मिलकर करीबन 54 डॉक्टर्स हैं। और मुझे आपको बताते हुए बहुत हर्ष और बहुत खुशी होती है कि मेडिकल डॉक्टर्स का हमने एक प्रकार का ऑर्गेनाइजेशन बनाया है और उसका नाम है IMPF, इंडियन मेडिकल पार्लियामेंट्रियन फोरम। और मुझे आपको बताते हुए बहुत ही खुशी और हर्ष होता है कि आई एम ए चेयरमैन ऑफ IMPF। ये अभी बजट सेशन का दूसरा चरण भी संपन्न हुआ और उस दौरान हमने मेडिकल इंस्ट्रूमेंट की टेक्नोलॉजी के लिए आत्मनिर्भर भारत इन मेडिकल टेक्नोलॉजी और इंस्ट्रूमेंट प्रोडक्शन के लिए लोगों को कॉम्पिटेंट और एफोर्डेबल मेडिकल इंस्ट्रूमेंट उपलब्ध हो, इनके लिए हमने जो हमारी सबसे बड़ी संस्था है नीति आयोग, इसके साथ IMPF ने बैठक की थी। उसमें महेंद्र भाई भी आए थे और वहाँ हमने करीबन 1.5 घंटा काफ़ी लंबा इंटरेक्शन किया था और उसका विषय ये था कि मेडिकल इंस्ट्रूमेंट के जो है उनका एक प्रकार का हमारा बनना चाहिए, एक प्रकार का हमारा पॉलिसी बनना चाहिए। और मुझे बताया गया यहाँ कि कुछ ही दिन पहले मेडिकल इंस्ट्रूमेंट जो है इनके लिए एक पॉलिसी बनी है। मैं समझता हूँ कि वहाँ डॉक्टर्स मित्र जो मेडिकल, जो देश की सर्वोच्च पंचायत है यानी कि लोकसभा और राज्यसभा में, इसके जरिए हम बहुत कुछ कर सकते हैं। और काफ़ी लोग पॉलिटिक्स को ऐसा मानते हैं कि पॉलिटिक्स इज ए डर्टी थिंग, पॉलिटिक्स के लिए लोगों को जो सूग होती है, पॉलिटिक्स को लोग ऐसे मानते हैं कि इट इज़ नॉट ए गुड थिंग। मगर मेरा स्पष्ट मानना है कि देश का जो नीति निर्धारण हो, देश के लिए जो कानून बनते हो, व्हाट इज अ मेंबर ऑफ पार्लियामेंट, ही इज ए लॉ मेकर। तो इनके जरिए आपको कानून बनाना है, यू हैव टू इनेक्ट द बिल्स। और मैं समझता हूँ कि अगर अच्छे लोग राजनीति में आते हैं, अगर अच्छे लोग पढ़े लोग राजनीति में आते हैं, तो राजनीति में बहुत बड़ा बदलाव होता है और राजनीति अपने आप ऊपर आती है। मैं कहना चाहता हूँ कि अगर महात्मा गांधी राजनीति में नहीं आते तो इस देश को आज़ादी की लड़त का इतना बड़ा नेता हमें मिल नहीं सकता था। अगर भारत रत्न और संविधान के शिल्पी डॉक्टर बाबा साहब अम्बेडकर राजनीति में नहीं आते, ही वॉज ए इकोनॉमिस्ट, ही वॉज ए लॉयर, मगर अगर वो नहीं आते तो देश को इतना बड़ा और इतना अच्छा संविधान नहीं मिल सकता था। अगर श्री नरेंद्र भाई मोदी जी राजनीति में अगर नहीं आते तो देश को एक गुड गवर्नेंस मिला है, देश को एक सुशासन मिला है, देश को नए भारत की जो पहचान मिली है पिछले 9 साल में, शायद हमें नहीं मिल पाती। तो मेरा आपसे, अगर आपको राजनीति में आना कोई बुरी बात नहीं है, यू कैन कंट्रीब्यूट इन द पॉलिसी मेकिंग, यू कैन कंट्रीब्यूट इन द इनेक्टिंग द लॉ। और देश का संचालन कहाँ से होता है? वो देश की सर्वोच्च पंचायत यानी कि लोकसभा और राज्यसभा से होता है। तो मैं मानता हूं कि वहां भी लोगों को अपना अपना योगदान देना चाहिए अगर मिल सकता है तो राजनीति बुरी बात नहीं है। आप लोग इतनी बड़ी संख्या में, मुझे बताया गया कि आप लोग करीबन 400 से ज़्यादा पूरे देश के अलग अलग कोने से यहाँ अहमदाबाद में पधारे हो, तो मुझे हर्ष होता है। मैं दोबारा आपका स्वागत करके अपनी बात को समाप्त करता हूँ। भारत माता की जय। जय जय गरवी गुजरात।
I'll request Dr. Meenu Bajpai to please come on stage and address the audience.
Dr. Mahendra Munjapara, Minister of State for Ayush, Teacher of Teachers Dr. Kirit P. Solanki, Dr. Bhupesh Shah, Chairman Organizing Committee, Dr. Lokeshwar Rao, President, Dr. Hiremat, Secretary of the IACTS, Dr. Gaurav Goel, Dr. Deshmukh, Dr. Kulkarni, members of the Organizing Committee, dignitaries of the dais, distinguished delegates, friends and students. It's a great privilege to be here in front of you, representing National Board of Examination in Medical Sciences. I bring greetings to you from Dr. Abhijat Sheth, President of the National Board of Examination in Medical Sciences, who could not be here today because currently he is in Philadelphia, and actually the day before yesterday he met his counterpart, the President of the National Board of Examination of the United States of America. Well, I could vouch for it that the IACTS is a very robust organization because they run 4 annual courses with such robust activity around the year. And in addition to that, there are many other side scientific organizations as well. For us as a national organization, which has the mandate to impart postgraduate education at the national board, it is a great help to us actually, because we have 1,300 hospitals under us, of which 2/3 are private hospitals. So private hospital clinicians becoming teachers and getting such CME's exposure, as was told by Dr. Solanki, is an extremely important contribution to the educational program of the National Board. National Board has 100 specialty boards. We have almost 30 broad specialties, we have 30 super specialties, almost 30 fellowships, and we have diploma programs which have seeded the district hospitals of our country. Based upon the requirement of the national needs, we pep up and introduce new courses. We have recently introduced DNB, 6-year DNB in emergency medicine. We have introduced DNB in geriatric care because our elderly population of beyond 65 years is increasing. It is now 6.8% of our total population of 1.54 billion. This is the tremendous increase in the last 30 years from 3.3% people who are 65 years or older in 1990. Now that number is 6.8% with the current population of 1.4 billion. So obviously we look at situations, the national requirements, and based upon projections from the national societies like IACTS, we introduce programs. Last year itself, our dynamic Minister of Health and Family Welfare, Dr. Mansukh Mandviya ji, he had introduced 14 new fellowships, and in the middle of next month again he is going to come for our Foundation Day celebrations, and we are going to introduce 14 more courses We get request projections from national organization as to the requirement of skill enhancement courses. Fellowships are skill enhancement courses. So whenever we get to need to introduce those courses on the recommendation of ICTS also, we are going to introduce things that we discussed a few months ago in Delhi meeting with Dr. Hiremat and other members of the governing body, that they need something to think about: pediatric cardiothoracic surgery, interventional cardiothoracic surgery, and vascular surgery, etc. Now, basically, if you look at it, there is technology is also changing gears, as was mentioned by our chief guest. Technology is changing gears from maximally invasive surgery to minimally invasive surgery. Now, many departments are acquiring that. In CTVS, who doesn't know that now the aortic valve replacement is done by catheterization. In nephrology, neurovascular hypertension, angioplasty has taken upper hand. Similarly, in pediatric surgery, the esophageal management of Heller's myotomy is now doing by POEM, which is the per oral endoscopic treatment. So all this is happening. This fast changing scenario also propels us to adapt new scenarios. And for that, the National Board of Examination has going to start the National Skills Center. This is in Delhi. It's going to be a very huge center catering all the students across the board. And again, this has been a contribution, a very positive contribution by our dynamic health minister, Dr. Mansukh Mandavia ji, who had actually given consent to release 150 crore rupees for that center, which is a 45,000 square feet center at Kidwai Nagar. So this would offer hands-on training and simulation for surgeons, because physicians definitely get hands-on training easily, but the surgeons have to get simulation practice before they come to live situation, which makes them more prepared. Now, as was mentioned by our guests, this technology is expensive, and artificial intelligence and machine learning has a lot to do. In fact, when you have to place an aortic valve through transcatheter maneuvers, you need AI. In fact, NASA of USA had actually helped creating that device by putting up a camera at the tip of the catheter so that navigation becomes easy. It's very expensive. Now, we interacted with the 6 IITs of our country, Kanpur, Bombay, Kharagpur, Roorkee, Delhi, and Bombay. And we have now introducing a fellowship in AI and ML. The idea is that we should be able to have a 2-year fellowship. In 1 year, the resident would spend time, or a fellow will spend time in the laboratories of the IITs, and 1 year he will come to the hospital setup to understand, can AI be applied, how effectively? This would reduce the cost. This would also meet the call of our Prime Minister Modi ji that we should be able to make in India endoscopes and other such equipments which could be otherwise very, very expensive. And let me tell you that AI and ML technology is going to pump in almost $500 billion in the next 2 to 3 years to the Indian GDP. So imagine if we do not introduce our specialists into that, we will have to import more and more, and that's where National Board is coming in to introduce this subject. Now, there are many things that the National Board is doing. We calculated, and there were some statements in the Lok Sabha also, that we have a deficit of specialists of 10 to 15 lakh in the country. How do we cater to this? Currently, we are only producing 70,000 postgraduates every year. To meet a requirement of 10 to 15 lakh will take years together. Therefore, the Niti, but we have done a very good work. In the last 5 or 6 years, since Dr. Abhijat Sheth took over as president of the National Board, we have increased our PG seats per year from 4,500 to 13,000 PGs every year, adding to the pool of National Medical Commission. We conduct entrance examination of NEET for National Medical Commission also. So overall, 2 lakh candidates take the exam, and about 70,000 PG seats are delivered. Now, this is not enough. So we looked at how the Niti Aayog said, well, since you can do so fast, why don't you double up your seat from 13,000 to 25,000 in 2 to 3 years? Now we looked at the desk drawing board as to what is causing delay, how we can pep it up. We realized that there are 3 important elements if a hospital has to be accredited for a postgraduate program. One is the number of beds. Second is the case mix for a specialty. And third is teacher eligibility. We found that a lot of hospitals are not able to meet the requirements. We have 70,000 hospitals in our country, and only 1,300 hospitals are participating to produce PG program. We found that if that deficit could be complemented by 2 or more hospitals joining hands together, suddenly they will start participating. So with 70,000, even 10% could participate, we would have 75,000 PG seats instead of 13,000. We have got this cleared in our governing council, which got cleared from the Honorable Minister. So we are going to, by this year, or end of this year or early next year, we will have 75,000 PG seats contributed by the National Board itself. Now, these are all easy to say, but it also brings a lot of apprehensions and challenges. To cater to such a large pool of residents, we should have high standards of training, and we should have uniformity of training across all programs throughout the country. For that, as you all know, many of you participate to contribute the syllabus and the curriculum to the National Board headquarters in Dwarka, Delhi, from which webinars are round the clock transmitted to all the programs. We get case scenarios, we get lectures, symposia, and procedural videos from all the specialties, and they are transmitted live from that. So this way we are keeping high standards and also uniformity. Two quick things I want to say. Sometimes, since it is an organ-specific skill enhancement courses in fellowship, we find that a person after MBBS does 3 years of broad specialty, 3 years of super specialty, and then 2 years of fellowship, long years. And towards the end of the day, he becomes a specialist of that fellowship which he has done. And many of the things he has learned during broad and super specialty are not being utilized. We realized that can we cut this flab? Can we have integrated courses? People who want to do fellowship, for example, in cardiac angiography, for that matter, or interventional cardiology, those people can do only 2 years of medicine and 2 years of cardiology and then 2 years of fellowship, which will reduce the number of years from 8 years to 6 years. This idea I got when I was with Dr. Rao in Hyderabad of Yashoda Hospital. He's a pediatrician, and I was discussing him about the program. He said, our fellows, after doing fellowship in angio, they stopped doing basic cardiology. So it's such a waste. Then I thought that if that is the case, why don't we cut it down and have integrated courses? So these are the things I wanted to share with you, and there is much more which is happening at the National Board. What we have also realized, and it is very important because we have the Ayush Minister here in the dais, post-COVID there is a realization. Around COVID time, there was paucity of beds were palpated. We created more inpatient beds. That economy was about 120 billion at that point of time. It was realized that people after COVID, there was a change in political thinking and social thinking. People now want to do proactive, prophylactic treatment, seek treatment for wellness. And that's where Ayush would come into the picture. There will be a change from inpatients to multi-specialty hospitals in the next 3 to 4 years. And this economy is going to boom a lot. And there'll be billions of dollars of economy in the country itself as far as these hospitals are concerned. So therefore, a change has happened, and this change we should respond to. So as I mentioned, the usual beds inpatient would be replaced by critical care beds, because our elderly population and people who are well will not go to hospital at the drop of a hat. They will only go to the hospital when they are really critically ill. That is why we have introduced the course of 6 years emergency medicine, critical care medicine, and DNB in geriatric care, because that's what our population is going to require very soon. So with these words, I would like to thank you all, Dr. Goel particularly, because he invited me directly by contacting me and the members of the organizing committee. And I think the last day and then these days will be very useful for you as a trainee. Thank you so much.
I'll invite Dr. Darshana Deshmukh, the sitting MLA from Nandod, to say a few words, please.
भारत माता की, भारत माता की. Thank you. Hello, good evening to all senior doctors, colleagues, friends. आज के इस कार्डियोथोरेसिक सर्जन CME में हमारे आयुष मंत्रालय के डॉक्टर मुंजपरा जी, हमारे अहमदाबाद के सीनियर MP एन, जिन्हों से हमने बहुत कुछ सीखा है, वैसे हमारे सांसद श्री डॉक्टर किरीट भाई सोलंकी जी, इस ऑर्गेनाइजेशन के डॉक्टर भूपेश भाई शाह जी, साथ में डॉक्टर लोकेश्वर जी, डॉक्टर मीनू सर और हमारी साथी डॉक्टर पायल कुकरानी, MLA नरोड़ा। मैं बहुत खुश और आनंदित भी हूँ और मैं गौरव भी लेना चाहती हूँ कि मैं बहुत छोटे से गांव से छोटी सी डॉक्टर हूँ। बड़ौदा मेडिकल कॉलेज से, MS यूनिवर्सिटी से MBBS और MD गायनेकोलॉजिस्ट बनने के बाद इसी डॉक्टर को हमारे डॉक्टर भूपेश शाह सर मुझे इनवाइट करने के लिए यहाँ अहमदाबाद से राजपीपला तक आए थे। मैं उनका बहुत आभारी हूँ और आप सभी को मेरा प्रणाम और मेरा वंदन करती हूँ। गुजरात में सालों पहले जो मेडिकल फैसिलिटी अवेलेबल थी, उसके हिसाब से जब हम इस 27 साल की कुछ बात करते हैं ना, तो पता चलता है कि 27 साल में बहुत कुछ मेडिकल क्षेत्र में चेंजेस हुआ है और इसी के साथ साथ बहुत ज़्यादा फैसिलिटीज़ पण हमारे इस गुजरात में ज़रूरी बनी है। अहमदाबाद को मेडिसिटी बनाने में जो किसी का योगदान है तो वो है हमारे वड़ा प्रधान नरेंद्र भाई मोदी जी का। इसी गुजरात में जामनगर में ग्लोबल सेंटर फॉर ट्रेडिशनल मेडिसिन बनाने के लिए कि जिसमें पूरे देश के और पूरे विश्व के मेडिकल रिसर्च होगा, उसकी ट्रीटमेंट होगी और उसी ट्रीटमेंट को लेने के लिए देश में से भी और विदेश में से भी यहाँ लोग आ सकते हैं। ये सोच गुजरात को मॉडल बनाने में और गुजरात को इस देश में और दुनिया में नंबर 1 प्रस्थापित करने में जो किसी का हाथ है तो वो है हमारे वड़ा प्रधान नरेंद्र भाई मोदी का। और हम खुश हैं इसी बात से और हम गौरव भी लेते हैं कि मैं ऐसे इलाके से आती हूं कि जहां पर स्टैच्यू ऑफ यूनिटी सरदार वल्लभ भाई पटेल का सबसे ऊंचा स्टैच्यू प्रस्थापित हुआ है। वो पूरा का पूरा ट्राइबल एरिया है कि जहां पर 80 से 90% लोग ट्राइबल्स है। इसी इलाके को वड़ा प्रधान ने टूरिज्म क्षेत्र में इतना डेवलप कर दिया है कि आज देश में और दुनिया के लोग हमारे नर्मदा डिस्ट्रिक्ट में आते हैं। गुजरात को मेडिकल हब बनाने में भी हमारे वड़ा प्रधान का सोच और उसका अमलीकरण कि जिससे आज गुजरात के साथ साथ आजू बाजू के जो भी स्टेट हैं, महाराष्ट्र है, मध्य प्रदेश है और राजस्थान है, यहाँ से लोग हमारे गुजरात में मेडिकल फैसिलिटी का लाभ लेने के लिए आ रहे हैं। और हम इसीलिए प्राउड फील करते हैं कि आज गुजरात इट बिकम्स ए मेडिकल हब इन इंडिया। बहुत सारी बातें ऐसी है कि मेडिकल क्षेत्र में गुजरात को आज नंबर 1 बनाने में बहुत सारी उपलब्धियां भी हमारे पास मौजूद है। इसमें गुजरात में के साथ साथ पूरे भारत देश में लेप्रेसी को रिमूव करने की बात हो या टीबी की इरेडिकेट करने की बात हो, पर यहाँ पर जन जन के साथ लोक भागीदारी से हर एक क्षेत्र में काम किया जाता है। आज आत्मनिर्भर की बात करते हैं। सर ने हमें बताया कि ये जो रोबोटिक इंस्ट्रूमेंट है उसकी जो प्राइस है उसको ध्यान में रखते हुए अभी जो प्राइस है जिसे यहाँ के हॉस्पिटल में भी ये सेवाएं उपलब्ध हो सकती है। मुझे पता है कि आई थिंक किरण हॉस्पिटल में रोबोटिक सर्जरी अवेलेबल है सूरत में। ऐसी कई सारी उपलब्धियां हैं कि आत्मनिर्भर के तहत भारत में ही सभी मेडिकल इंस्ट्रूमेंट हो, स्टील हो, मोबाइल हो या डिफेंस का कोई भी इंस्ट्रूमेंट हो, वो सब इसी भारत में बने। और इसकी वजह से आज हम भारत कोरोना की इतनी बड़ी महामारी के बाद भी आज हम खड़े रह चुके हैं। इसीलिए बोलते हैं गुजरात अभी भी अड़ीखम है, भारत अभी भी अड़ीखम है, उसे कोई नहीं हिला सकता जब तक हमारे वड़ा प्रधान नरेंद्र भाई मोदी है। ऐसी कई कई सारी उपलब्धियां के साथ साथ मैं आप सबसे एक रिक्वेस्ट करना चाहती हूं कि आपके 2 दिन की यहाँ पर ये CME है, आप सभी से मैं एक रिक्वेस्ट करना चाहती हूँ कि कल वड़ा प्रधान श्री नरेंद्र भाई मोदी का मन की बात का 100वां एपिसोड है। आप सबसे मैं हाथ जोड़ के रिक्वेस्ट करती हूँ कि आप सभी भी इसी 100वें एपिसोड में आप सब हिस्सा लें और आप सब हमारे वड़ा प्रधान नरेंद्र भाई मोदी का ये मन की बात का कार्यक्रम 11 से 11:30 बजे तक जो प्रसारण होगा, जो रेडियो के माध्यम से हमारे प्रधानमंत्री इस देश के कोने कोने तक लोगों के साथ संपर्क में रहते हैं। तो आप सभी से रिक्वेस्ट है फिर से कि आप सभी भी कल मन की बात का कार्यक्रम अवश्य सुने और इसी से मैं आपकी बहुत आभारी रहूँगी। और आप सब ने मुझे सुना, इसीलिए मैं भी आपका आभार प्रकट करती हूँ। और डॉक्टर भूपेश सर ने मुझे इसी बिग CME में मुझे इनवाइट किया, इसीलिए मैं उनका भी आभार प्रकट करती हूँ। थैंक यू वेरी मच। भारत माता की जय।
I will invite Dr. Payal Kukrani. Please say a few words.
गुड इवनिंग एवरीवन। मंच पर उपस्थित मिनिस्टर ऑफ स्टेट फॉर आयुष डॉक्टर महेंद्र मुंजपारा जी, मेंबर ऑफ पार्लियामेंट अहमदाबाद वेस्ट डॉक्टर किरीट सोलंकी, MLA नानोद डॉक्टर दर्शना देशमुख, चेयरमैन ऑफ इंडियन एसोसिएशन एंड CVTS सर्जरी CME डॉक्टर भूपेश शाह सर आदत पड़ेली છે એટલે પછી all the respective president, chairman, secretaries of Indian Association, CVTS, CME and doctor fraternity team, आप सभी का उमंग उत्साह देखकर और जिस तरह से आपने नए संकल्प लिए हैं, जिस तरह से आप इस महान सेवा की प्रवृत्ति में जुड़े हुए हैं, आपका दर्शन करके मुझे लग रहा है मैं अभी अपने आप को सौभाग्यवती मानती हूँ। इन स्पाइट ऑफ बीइंग डॉक्टर, भूपेश सर आप पहले से ही सामाजिक कार्यों में जुड़े हुए हैं, रोल मॉडल रहे हमारे। सर के साथ DNB एनेस्थेशिया के दौरान सर की टीम के साथ काफ़ी कुछ सीखने का मौका मिला। तो वही कुछ एक्सपीरियंस अगर मैं 2 लाइनों में कहना चाहूँ तो वो ये था, हार्ट सर्जरी एज वी ऑल नो needs to be delicate, needs to be precise. It is as much as art as much as it is science. I would like to share one experience that is unforgettable, and that is during final stage of closure जब surgery के अंतिम stage पे हम आते थे, every time it made me feel I was part of some miracle. आप सभी डॉक्टर फ्रेटर्निटी के लिए ज़्यादा न कहते हुए 2 लाइनें कहना चाहूँगी. आँखों में सपने लेकर भरकर सपनों में आशाएं, आँखों में सपने लेकर भरकर सपनों में आशाएं, दिल में है अरमान कहीं कुछ कर जाएं कुछ कर जाएं. सूरज सा तेज नहीं है मुझ में, दीपक सा जलता देखोगे. सूरज सा तेज नहीं है मुझ में, दीपक सा जलता देखोगे. मैं उस माटी का वृक्ष नहीं जिसको नदियों ने सींचा है, बंजर माटी से मृत्यु से जीवन मैंने खींचा है. थैंक यू एवरीवन.
Now I invite Dr. C.S. Hiramat, the Secretary IACTS, to please say a few words.
Respected Chief Guest, Dr. Mahendra Munjapara, Guest of Honor, Dr. Kirti P. Solanki, Executive Director, National Board of Examinations, Dr. Minu Bajpayee, Honorary Guest, Dr. Darshana Deshmukh, Dr. Payal Kulkarni, President IACTS, Dr. Lokeshwar Rao Sajja, Organizing Chairperson and Executive Committee Member of IACTS, Dr. Bhupesh Shah, Organizing Secretary, Dr. Gaurav Goyal, my dear teachers, colleagues and friends. It's an honor to be here in the state of Gujarat. IACTS was started way back in the year 1954. It proudly completes 69 years and entering its 70th year. We from the association, a body of more than 2,500 plus members across the country and abroad, we have a curriculum wherein we do conduct our IACTS national conferences in the month of February. Apart from that, the IACTS core program, the IACTS TECHNO CME, which is conducted here in Ahmedabad today, the midterm CMEs, thoracic CMEs. These are regular academic programs, and the association strives hard to see that the younger generation are benefited and they become good cardiac surgeons. Coming to the theme of this conference CME today, the theme was making cardiac surgeons future ready. Well, it has got a lot of meaning in it. They have seen that the scientific program under the leadership of our Senior Vice President and Scientific Chairman, Dr. Manoj Durraj, they have covered most of the topics, whether it is pediatrics, coronaries, valves. Certain out-of-box thinking is there, not only thoracic, like making a life or in newer innovations. These are the new topics which have been added here, which really benefits for all the surgeons. For the first time, I think, in the government of India, Gujarat is a state where you find many doctors being in the political field. The Indian Association of Cardiothoracic and Vascular Surgeons are really proud of you, sir, of all of you, to take on the dais here today, and really you people make a huge difference in the healthcare sector. Such educated people being in the healthcare sector makes a huge difference for the society. I would like to thank Dr. Bhupesh Shah, Dr. Gaurav Goyal and Abhishek and the entire organizing team for such an excellent scientific program and very good hospitality. In fact, Dr. Bhupesh Shah and Dr. Gaurav Goyal, the way they communicated across the country, they have got who is who in cardiac surgery in India today in this hall. And the way they function, the way they communicate, their relationships, definitely the theme, making cardiac surgeons future ready. Sir, no doubt, I think your two futures are ready going into political field itself. We are really proud of you, sir. They have organized hands-on workshops. Actually, a CTCME or a technical CME is 1.5 day program. They have stretched it to almost double the days. That is 3 days program, conducting workshops, having the best teachers to teach us. I wish all of them a good success and happy learning. Thank you.
Now I'll invite Dr. Lokeshwara Rao Sajja, our President, IACTS, to please say a few words.
Respected Chief Guest, Dr. Mahendra Manjupara, Honorable Minister of State for Ayush and Women and Children, Development of Women and Children, the guest of honor, Dr. Kirit Solanki, Member of Parliament, Lok Sabha, Dr. Minu Bajpai, Executive Director, National Board of Examinations, honorary guests, Dr. Darshan Deshmukh, Dr. Payal Kulkarni, Dr. Hiramat, Dynamic Secretary of IACTS, and Dr. Bhupesh, Dr. Gaurav, Dr. Abhishek, the organizing committee of the CTCME 2023. My dear teachers and colleagues, ladies and gentlemen, it is my great honor to welcome you to the IACTS Techno College CME 2021 at Ahmedabad. This meeting promises to be an incredible opportunity to share the knowledge, exchange ideas, and explore the latest innovations in cardiac surgery and technology. It brings together experts from across the country representing the best in the field to share their experiences and insights. We are fortunate to holding this event in the beautiful city of Ahmedabad, which is renowned for its rich cultural heritage and scientific advancements. As a city, it has always placed great importance on education, research, and innovation. We could not have chosen a more suitable location for this meeting. Yesterday, we had a rapid refresher course for the trainee surgeons, and today and tomorrow we'll be exploring the latest developments in cardiac surgery and technology, including new techniques, devices, and research. We'll also be discussing the challenges and opportunities in this ever-evolving field. Our program included an impressive lineup of distinguished speakers and thought leaders who will be sharing their knowledge and expertise with us. We will also be having an opportunity to network with the colleagues and exchange ideas during various sessions. I would like to express my sincere thanks to the organizing committee, particularly Dr. Bhupesh and Dr. Gaurav and Abhishek, for their hard work and dedication in putting together this exceptional event. And I extend warm welcome to all our guests, and I wish this CTCME 2023 a great success. Thank you.
Now I'll request Dr. Hiramat to please felicitate our organizing secretary, Dr. Gaurav Goyal. And now I'll invite Dr. Gaurav Goyal, Organizing Secretary for the IACTS Techno College CME 2023, to give a vote of thanks. Thank you.
Dignitaries on the stage, teachers, and colleagues, because suddenly I realized that I've grown old. So maybe the weight of organizing this CME on my shoulders have made them shrug. Students who are the future of cardiac surgery, on behalf of Gujarat's Cardiothoracic Surgeons Club, I welcome you all to the city of Ahmedabad for 2 days of extensive learning and brainstorming about our future. I've been passionate about organizing events right from my MBBS days. Dr. KP Solanki sir, my teacher, knows it. I was one of the naughtiest brat about. When I was here in 1994, I came down from Delhi for my MBBS. somehow I feel that such events wake us from the slumber we are going into and give us a future direction that we need to think about, ponder, and most importantly, adopt. There are certain things which I tried to encompass, and I don't know whether I'll be able to do justice to them in 1.5 days or not, but I just wanted to change the format of the Techno College so that the surgeons for tomorrow, especially the younger ones, they have at least a spark and they can really think about where the branch and their lives are going to be a decade later. Even the government plans for 5 years, so at least we should even start thinking in those terms that where our fraternity will be going 5 years down the line, so that we don't miss the bus, and we've missed it several times. With this, I welcome you all, and my apologies if there have been any mistakes or shortcomings in the last day or maybe coming 2 days. And thanks for all the support from my organizing committee members and guidance of my senior teachers, the President IACTS, Dr. Hiremet sir, the Secretary, 2 of my teachers, Dr. Ayyar and Dr. Meherwal, who have been my role model and have made me what I am today. Thanks a lot to everyone and welcome from my side, and have a nice CME, and please forgive me as a junior colleague that if there were any shortcomings. Thanks to all. I will like all of you to stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I will request all of you to be here because बस साहब जीवीए છે આપની કૃપા છે સાહેબ બની ગયા
I'll just take the laptop.
No. इसका you want me to put that this thing ना slides के लिए I have it.
Sorry?
We copied it, huh?
Which one?
Commodis.
Yeah, we already copied it.
ठीक है.
Should I change? Or let him come in then?
No, you change. Correct.
So this is the last one, right?
Yes, this is the last one. Good evening, friends. I think we're in time to listen to one of our stalwarts of cardiac surgery, Dr. Anil Tendulkar. He needs no introduction, but I think the question that he's asking us today is one of the most important questions that we should ask ourselves as individuals and as an association. Sir, I welcome you to talk about who we are and where we are headed. Thank you.
Can these lights be difficult to see anything? Can these auditorium lights? Can this light be put off? Can the auditorium lights be put on? काय रे बाबा. At the outset, I am not thanking the organizers, but I am thanking all of you for being present over here. It is customary to thank the organizers, but I think I must thank all of you for willing to tolerate me even at the end of a day. The person responsible for this topic is Dr. Tushar Shah, who is absent over here. In fact, all the three, out of three, two patrons of this conference are absent. So this is the thirst for knowledge. Ahmedabad, I always visit Ahmedabad, very frequently visit Ahmedabad. And Ahmedabad very conveniently thinks that Anil Tendulkar is anti-modernization. Anil Tendulkar is equal to anti-advances in CV surgery. So, all Ahmedabad will be pro-mix and Anil Tendulkar anti-mix. All Ahmedabad is pro-off-pump surgery, Anil Tendulkar totally pro-on-pump surgery. They declare, they assume, and then they use me like this, that everyone uses this, and I can understand my students because juna khunnas nikalne ka hota hai, so they try to punch me, everybody makes a fun of me, and I purposefully kept a smiling face over there. I have not kept a wincing face because of those punches. Anyway, I thought I am giving a great talk, but when you have got a lot of friends, they told me, till dinner, you have to fill up the time. So this is Hiremat technique, that till dinner, everybody should be kept busy. If you come to the score program, till dinner, till that last, 8 o'clock dinner, till 7:59 seconds, teaching should go on. 5 minutes if somebody rests before dinner, he is scared. He gets worried. So, somebody told me that, forget all that, this is all. First disclaimer that I am neither a thinker or philosopher. Just now, Sanjit told me that he is going to take you all that. In fact, somebody told me, and I also agree with that person, that thinking surgeon is an oxymoron. That moment surgeon starts thinking, he becomes a physician. He can't operate because he starts thinking. So surgeons are basically, as my teacher Dr. Bhattacharya used to say, majur आदमी है, हाथ से कमाते हैं, हाथ तो ही खाने को मिलता है, थोड़ा कुछ दाल रोटी. So we are non-thinkers, that's why we have become surgeons, that's why we can operate. So friends, this topic given to me by my friend Dr. Tushar Shah. He is a very prominent member of Cardiac Surgeon of India WhatsApp group, and on that group, no really, he is Sashi Tharoor of Cardiac Surgeons of India group. Each time he posts something, I have to first go to dictionary and start finding the meaning. Because I am trained in vernacular. Till SSC, 11th standard, I learned all subjects in Marathi. Including English, I learned in Marathi. So if you start telling me Venus, Mercury, I get confused. I know Shukra, Buddha, Ravi, Mangal, those vocabularies. So Tushar, in a very victorious voice, told me on phone, "Sir, we will have this topic, cardiac surgery, co-audis." I said, "Oh my God, what is co-audis?" So I searched, what is co-audis? So co-audis, this is internet, means just now also there was a discussion with another Sashi Tharoor of the group, Dr. S.V. Sri Krishna. He said, "From where you are coming?" I said, "Nahi." Dictionary said, "Where are you going?" So for my convenience, I have taken, I knew only one co-audis, that was shoes from Bata. So there was one famous shoes, co-audis. So now I realize what that meant, co-audis. So always better to give a sugar-coated pills. So first thing, the best thing to happen to cardiac surgery in India was development of Cardiac Surgeons of India WhatsApp group. Believe me friends, see, many people think I am a clown. So even if I am talking seriously, they start laughing. And when I actually joke, they are very serious. So I have to tell you that this is a joke and this is not a joke. I am really serious. This is the best thing to happen to cardiac surgeons in India, is to start a WhatsApp group of Cardiac Surgeons of India. Those who are not member should become member. First time, cardiac surgeons, instead of pulling each other's legs, are now propping up each other. Something rare among surgeon community. Ready exchange of information. Believe me, I have seen, I'm 70 plus, I have seen cardiac surgery of all last 78 till today. So last 45 years, Ayyar will agree with me, best thing to happen is this ready exchange of information, tremendous brotherhood. Whether it is technical advice or uniting against something wrong that has happened to cardiac surgical community, this group has really helped cardiac surgeons. So if you ask me, co-audis, yes, we are absolutely in the perfect track. And here is an example. I hope you can read. See the time. Light nahi aa raha hai. Anyway, see the time, 8:26 a.m. Dr. Zainul Hamdullah has already put up a question. A case of mitral restenosis with ASMS and narrow aortic root is for surgery. Around 8:15 or 8:10, he has put up a question. And he has already received response from Dr. Bashi from Chennai, telling him what to do. Already you can see Dr. Prashant Vaidyanathan is typing. See how people are helping. Dr. Arun Kumar, I don't know from where he is from. He has already posted a video how to do that root widening. This is posting at 8:15. See, by 8:26, the number of responses Dr. Zainul Hamdullah has received while sipping a cup of tea at his residence. Am I right? And the same day, he has not postponed that operation. Same day, he does that operation, does the operation successfully, and same day he posts thanking everybody profusely. And I'm touched by those words. He said, friends, I thought you were all with me when I was operating. I was remembering. You tell me, where can this happen? Has it happened? This is Techno College. Techno College, Techno College, Techno College. A case of re-MS with AS, narrow aortic root, elderly lady or something, if I remember the details. This gentleman gets an perfect advice. Sorry? Yeah, redo. He gets the perfect advice, and there are people who are still, Prashant Vaidyanathan is typing. He also wants to tell something. Bashi has already told what to do. So, see, this can happen, and if this is happening, and this is going to happen, co-word is perfect. We are on the absolutely perfect co-word is path. And more this happens, really, you get fulfilled that somebody wants an advice and gets a perfect, clear, absolutely whatever type of advice you want, he receives an advice. Another great thing has happened, friends, is this association, Indian Association of Interventional Cardiac Surgeons. According to me, it's a great thing has happened. All other associations were almost are part of that, like heart failure, coronary surgeons. These are already existing, pediatric surgeons, existing. This is a totally association formed by, conceptualized, designed and executed by a bunch of young people. Don't take my word young seriously. These are, but 40, 50-year-old people. In our days, for everything, we used to look at Dr. Parulkar, Dr. K.R. Shetty, Dr. Gujral. We wanted them to give us advice. No, these people have not taken our advice. I felt bad about that. But I thought one day he will come and say, sir, kya karu, kuch bolo. Nothing. They have taken legal advice. They have taken financial advice. They have taken all sorts of advices. And I'm very happy. Varun is here. Zainul is here. It's real. They have formed this. And in the afternoon, Dr. Ajay Kaul was crying. What are we doing? What are we doing? Arey, they have done it. They have already formed an association. Sir, they have already conducted one mentor workshop. They have already posted second workshop. After 2 months, already posted. List is posted. Cases posted. So what more you want? So this is greatest thing to happen. And this topic is totally untraveled route, unknown course, and uncertain destination. All other coronary surgeons, pediatric surgeons, transplant surgeons, they know what they are. This is a totally untraveled route, uncharted, and uncertain destination. And they know there is a hostility. First thing people will ask him, suppose this happens, what will you do to me? Protect me. People are constantly giving them tension, worries. And most important, put into action. These photographs were posted, and like one comment, those chairs will be replaced. Not the same old people will be sitting on those empty chairs. These chairs will be occupied by a brand new battery of young cardiac surgeons. So my friends, co-ed is perfect. We are in the right direction. And see, who was the mentor? Mentor was Sayaji Rao Sargar. Have you heard of him? No. He practices in Wardha. Cardiac surgery percolating down, not just Mumbai. Then Mumbai, it went to Pune, we were happy. We went to Nagpur, we were happy. This is now even further. Sir, Nana Sahib, borobar na? From Nagpur reaching Wardha is a great thing. This young gentleman, Varun, wrote down some 24 or 34 cases he scrubbed up. Am I right? And he taught students how to do coronary angiography and perhaps angioplasty also. I forgot the detail. But see, these are the young people who are doing this. I think if somebody asks me cardiac surgery cohort is, I am sure, I am happy. All those people who were crying in the afternoon, kahan ja raha hai, what is happening? I am confused, I am depressed, I am suppressed. Forget, this is thing, they are progressing, they are marching, they are going fast ahead. And this is all because of embracing new technology. And as Sir Bajpayee sir mentioned, that we are focused workshops, absolutely focused workshop, rather than Wahal workshop. Now we have got focused workshop, Ozaki procedure, all focused workshop. And most important, what I feel very good, people keep on talking about me being teacher, feel very good is local mentors. Gone are the days for everything we used to call people from UK and US for mentorship. These are Sayajirao Sargar is from Wardha. He's the mentor. And another person from Sangli, Doi Phode or so these are, Sangli is a tier 3 city in Maharashtra. Many people think it is from China, Sangli. So you have to tell. So we had to tell them that Sangli, incidentally, Sangli is the 50% India's grapes. 50% of India's grapes come from Sangli. So this is real development, really makes me very, very happy. So another offshoot of this technology is a couple of months back, I was in Ahmedabad. I attended one local Gujarat surgeons meeting. Sukumar was there, Bhupesh was there, he was in fact the president, and one person spoke on towards digitalized ICU. And one thing in that he spoke was no human being in the ICU. In a very proud manner, he said that this ICU, after a couple of days and weeks and years, will be without any human being. That what scared me. He painted, he showed pictures similar to these. No one in the ICU. Machines, and machines. If at all some human, it will be the one in the center. Robotic persons over there. This kind of person will be there. So, if you gather, if you collect, if you ask people who were during COVID in ICU, and COVID situation was almost similar situation. No human being. You are seeing human bodies, but they are fully in that special attire. You don't recognize them. You don't know who they are. And these are the thoughts of my own wife, my own and only wife. She was in ICU for 28 days. She came home on oxygen. And first thing she said, you require people. She wanted people around. She wanted people for physical and emotional needs. She wanted people to talk to. She wanted people to touch and to be touched by, both. She wanted people who will empathize with her. She wanted people who will offer a shoulder to cry. So friends, co-word is this road of don't be proud and tell that my ICU is without human beings. We require human beings. Unless you have a robo who will show emotions, I don't know whether that will be accepted or not. But you require human beings for these things. And again, I'm thankful to Tushar. I'm sure he will get hiccups wherever he is. that this is a small message is sent me. Too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. So you may not have extremely highly qualified nurses and doctors, but remember, you will require human beings in ICU. They may be the level of psychological counselors, that kind of persons. You will require human beings in the ICU for this purpose. And this feeling of loss of humanity comes in many forms, including the loss of personal identity. In ICU, person is all are wearing the same dress. They lose their name. They are bed number 4, bed number 5, bed number 6, like that. Or a case of MI, which I admitted yesterday, or which I operated today morning. That kind of their identity. They lose control. Nurse comes and tells them, have this drug, have this injection. They lose respect. They lose privacy. They lose their support system, and consisting of treating somebody as an object rather than a person. Those clinicians who have experienced being a patient, the insider experience has taught them the importance of family bedside presence, physical touch such as holding a hand, and calm words of explanation, safety, and support. So friends, that is not the correct way, correct path to be proud of that my ICU is without human beings. No, please, I request you, I warn that that may not be the correct approach. So you must have some people around for this purpose. Another thing, this is my favorite, next one. We talk about justice delayed, justice denied. Remember, treatment delayed, treatment denied. If you want to avoid some patient, purposefully tell him that this will cost you 30 lakhs rupees. So except Anil Ambani to certainly will not afford. Mukesh Ambani also will start thinking. But see, you maintain your macho image that I am willing to operate. It is that patient. So the onus of not coming, not following the treatment falls on the patient. So treatment delayed, treatment denied. And few stories I would like to tell you about treatment delayed, treatment denied. This is Kutch. Kutch, for those who are not initiated, is the westernmost district of India. Forget about Gujarat, it is the westernmost district of India, and the entire population of Kutch is less than the entire population of Mumbai. So vast, it's the biggest district after Ladakh, perhaps. The biggest district with the least number of population. And you see this run, and these are the few animals you can see. And these are the type of patients you receive, and this is the place from 1982 through KM Hospital and then LTMG Hospital, we conducted camps. Those days, it is to take 28 hours to reach from door to door, from door of KM Hospital to reach this camp door is to take 28 hours. Train and then again car travel for 3 hours. People over there had not seen a telephone or a train. So this kind of people, we used to conduct camps through an NGO, Bidra Sarvodaya Trust, and patients were brought with special attendant with them to Mumbai. They were kept in Mumbai in a special place, and one attendant is to be with that person throughout. And if we had a variety of patients, tetralogy of fellow, if we're less than 2 years or 10 kg, we used to do staged operation. We used to first do a BT shunt, allow the child to grow, and then to do a intracardiac repair. Like all NGOs, when your baby requires diaper changes, nobody comes to help you. But when your baby becomes a 13, 14-year-old girl, everybody likes to come and put a hand around and tell, "Hi baby, I'm your uncle." So as this NGO grew and became popular, all these NRIs entered the trust. And the first thing they did was they wanted a specialized pediatric cardiologist. So we want a specialized pediatric cardiologist. So a specialized pediatric echocardiographer was flown from Mumbai, and that person sent 3-month pediatric specialized. They have to be different. So they said primary repair. A year, barabar, primary repair. So they were told to go to a center 1,826 kilometers away from Kutch for primary repair. And the cost was accordingly told. So next camp we found out of 9 babies of tetralogy of Fallot, 6 had died for want of treatment. They got scared. As such, going to Bombay was scary, but they had an attendant. They were told by others that don't worry, there are people to take care. So treatment was delayed, and that resulted in denial of this treatment. So please remember, you have to take into account many things. Situation number 2, Aurangabad. My friend is over here. I used to go to his center to help him in doing cases which he thought difficult. And we had one patient of aneurysm of sinus of Valsalva rupture. So it's almost like an ASD. You don't require cost for valve and all that. So we gave him an estimate of 1.5 lakhs perhaps, I think by stretch of imagination. But the hospital director was a cardiologist. He said device closure. So the cost of device closure in those days, aneurysm sinus of Valsalva closure by device had just come those days. And KM Hospital had published a paper. So everybody wanted to close the aneurysm of sinus of Valsalva. Cost 7 to 8 lakhs. Result, my next visit, the patient was no more. He was trying to get those 7 or 8 lakhs. Aneurysm sinus of Valsalva patients are in gross failure. A sudden or development of massive left to right shunt. So required early treatment. So in recently, Cardiac Surgeons of India, one patient, a case of MS with severe PH with CCF, the cardiologist is treating conservatively because patient wants a new everlasting valve which doesn't require anticoagulation. So you only tell me, these are the, but the physician is telling, yes, wait, a new valve is coming. New valve is coming. A new valve will keep on coming. And everyone will say nothing is required. So I pray to Almighty to save this patient from such wrongly given advices. I was brought up in a municipal setup. So our attitude was to be a trustee of patient's life. You explain to those farmers, workers about patient's condition. They used to say, forget, you consider him to be, the patient to be your son, brother, mother, according to the age and gender. And you treat as if you are going to treat your father, brother, mother, sister. So that was the attitude. I feel, even in this modern era, this attitude we must have. I am aware that we are now made into, under Consumer Protection Act, we are now provider of service providers. I'm fully aware. There are all companies I teach, they treat me as a, not as consultant. The accountant treats me as a service provider. So I am service provider. So not consultant. So, but as our attitude should be trustee of the life and advise according to patient, socio-economic and family status. Patient should not feel bad, should not feel guilty because you are implanting a chitrawal. The whole problem is we tell them, ye chitra to itna sasta ho jayega. Paisa nahi to chitra kar lo. So that sounds as if it's something inferior you are trying to offer to the patient. Please don't do it. Please be trustee of patient's life. Another thought, totally different thought, and which is contrary to the theme of this conference, is concentrate on the goal, not on the road. Enough of that talk that my incision is small, my incision is small. There was a little vulgar joke that this is the only place where the surgeon is proud that theirs is a small one. So let us stop about it. Now let us talk more about, in a CABG patient, let us talk what conduits did you use? Did you do a complete revascularization and a long-term revascularization? Rather than saying 7 centimeter scale kept over here, 7 centimeter, 6.9 centimeter. Forget, enough, claps, well done. Now let us talk, let us go further and let us talk something which is for which the patient has come to a surgeon. Talking about Dr. Bhattacharya's principle, he said you cannot compete with cardiologists. They do by a puncture. You do by an incision. You cannot compete puncture and incision. What you can compete is a complete job and a long-term job. So emphasize on that completeness and long-termness rather than mera incision itna mera incision. About valve, let us discuss whether did you create a patient prosthesis mismatch. That is more important. What is the incidence of parallel leak? Friends, 35 years I am doing AVR. Even today, after the sternotomy, I am scared whether my knots are fitting rightly on the sewing ring and the valve is sitting perfectly on the annulus. I can't see the annulus of aortic stenosis. It is deep inside. So perfect, you are great, your vision is supreme. But let us talk more about patient prosthesis mismatch and all these problems. And CPB biochemistry. I was wondering whether should I reveal or not reveal. During COVID time, we used to have a Zoom meeting. And Zoom meeting of perfusionists. And one perfusionist who was called Dada of minimal invasive perfusion, he presented a paper with bypass pH 7.1. Not for 1 minute, for entire period of that bypass. 7.1. And as usual, the answer was, we had no problem. Patient had no problem. So you tell me, if 7.1 pH is tolerable, then why at all we are teaching perfusionist perfusion? Do anything. It is tolerable. It is acceptable. And he was considered as Dada of minimal invasive perfusion. So time has come for that. Another thing I personally feel that most uncommon is logic. And we just don't use logic. And I'm happy Prasanna is here. Because I want to pose a question to him. I'm sure he will blast me out. Because unfortunately, his flight is delayed. So he has got ample time to blast me out. I was preparing my topic for aortic root. And see the elaborate aortic cusp. See the corrugations. See the gelatinous sponging material God has inserted for aortic valve to receive that 80 pressure per beat. 72 beats, 60 minutes, 24 hours, 365 days for 70 years in Anil Tendulkar. And then you replace that valve with one pericardium with this arrangement. See that arrangement. And you say this will work? This will last? This doesn't fit into my logic. Prasanna, I am sure you must be ready with your all answers. You please keep it with you. Next year in co-audis, you tell where are we going. No, this is what simple logic. God has created such an intricate design of that aortic valve. You replace it with a piece of fibrous tissue and say it will last long. My point is lasting long, not lasting for 1 day or 2 days. Ionescu Shaili valve, second logic which constantly bugs me. Ionescu Shaili valve. Tell me modern pericardial valves, what new thing they have done than Ionescu Shaili valve? They say they have done something at this hinge spot. What is that they have done? You mean Ionescu did not do at that tip of the struts? They also had put padding at the tip of the strut. You just ask yourself, what have they done? They keep on telling you newer generation. What have you done for that? That resulted in such tears. See those arrows showing you the tears. This defies. All these years we were told that bovine pericardium is superior to porcine pericardium. Yes or no? Yes or no? When I say yes or no, answer is yes. Suddenly one company comes with porcine pericardial valve. And you are implanting and saying good because it can be crimped into a smaller size. Because porcine pericardium is 1/3 thickness of bovine pericardium. All these years we said bovine pericardium is superior. And now you say porcine pericardium. Defies my logic. I am sure you can immediately tell all the randomized studies, this and that. Kunal is not here. Kunal has gone. So otherwise he will immediately quote the randomized studies. Another confusion about logic of bypass time. Bypass time is important or not important? Let us declare. When it comes to minimal invasive surgery, long bypass time is statistically not important. When it comes to rapid deployment valves, suddenly bypass time becomes important. We say we wanted to shorten. Thambi, correct Leo? Huh? Minimal invasive surgery, 149 minutes, 2 hours bypass time, 2.5 hours bypass time, statistically not important than the conventional surgery. And same paper on rapid deployment valve, bypass time suddenly becomes important. Immediately, there are statistical, all supports and everything designed. It defies my logic. And according to me, what we should use is logic. Then something which is very dear to me is resident teaching. Yesterday I saw resident teaching. Today you see the institution which hosted yesterday's teaching program. Not a single person from the faculty is present here for the meeting. This is teaching. Resident teaching, during our time, we took KM because of lot of work. Now residents don't take KM because of lot of work. Sir, सोचने की बात है. Out of 13 seats in Mumbai, only 2 filled up, 11 not filled up because of lot of work. I sincerely don't know what they really want. They only want to attend Techno College and learn the latest Ozaki procedure. Sir, last year in one conference, hands-on workshop, pig aorta, which is thumb size, one resident could not suture. He was sweating, but he was trying. I was impressed. I said, next experiment is small vessel, but for you, I will keep thumb size aorta for suturing. So he said, sir, I can't come tomorrow. I said, what happened? Come tomorrow. He said, no, sir. Tomorrow I am attending off-pump CABG workshop. So really, Ozaki procedure, you should have seen the attendance, massive attendance. So sir, we were impressed by the figures you told us about DNB training, but unfortunately, residents are considered as Damul. Damul in Bihari was a picture by one beautiful picture. Damul are laborers with no right. So they are treated. What they learn in first year, same thing they learn in second year, third year, fourth year, and fifth year. A well-designed curriculum is lacking. Teachers are lacking. If teachers are present, they are not given importance. More importance as a retractor. So time has come. No, if you say that co-wardis is our resident population who are going to become future cardiac surgeons, time has come to offer them an attractive teaching package. That is what is really, really essential. Perhaps this is the last slide. I feel really sad that during our days, most of the speakers were from KEM, SIAN, All India Institute, PGI Chandigarh, CMC Vellore. These were the speakers. Today, sadly, these speakers are speakers from this teaching institute, which should be doing lots of basic research, which should be doing lots of clinical work, producing papers, generating data, giving us guidelines. They are lacking. So if you want to walk further distance, co-wardis, I think we require these institutions more and more participation. See, today's meeting, I don't mind because I am now retired. Mera koi bura koi nahi karega. UN Mehta, let me repeat again. This is the premier institute of this state. For our state, the country. The speaker should have been here and talking and telling what they do. They're supposed to be doing 50 cases a day, multiplied by 300. It's a huge phenomenal number. Come here, tell, teach, and talk. So that is the real place to talk and teach. So new curriculum, incidentally, new curriculum not entered over here. Bajpayee sir, new curriculum, not a single word in surgical curriculum about operative work to be given to the residents. All talk is about professors, ये कितना होता है, कितना किताब होना चाहिए, कितने lectures होने चाहिए. Why don't you talk about operative work that should be given to the resident? Should be. That these many operations they have to perform. Not just harvesting vein. Operations to be performed. So according to me, curriculum should include humanity. And people have found that if you include humanity in the curriculum, right from MBBS day, how to include is controversial. But if you include humanity in your curriculum, you produce humane doctors, doctors who are empathic, doctors who understand patients' problems better, rather than just advising something and walking out. So humanity should be part of medical curriculum. So far, unfortunately, it has not been. Retrospectively, I feel I would have been a better doctor had I been, if I were taught humanity. Thank you very much for a patient hearing. Dinner is served, kya? Half an hour more. Sukumar is telling me to keep it in loop. You want me to tell you some jokes? Gaurav, joke बोलेगा? किसके लिए? गाला अच्छा मैं सुना काला. By the time you arrange, I can tell you some. Huh? By the time you start arranging. See, GS Medical College, you know GS Medical College? You don't know. By the way, GS Medical College, we stop admitting at 99%. कितना 98 नहीं मिलेगा. 99 we stop, but it is absolutely like a school. So in GS, we were taught, second MBBS, when we go to second MBBS, we were taught how to present yourself to the patient. And we were constantly ingrained, talk in patient's language. Don't laugh at patient's complaints. And immediately we used to prepare notes. GS students excellent in preparing notes. Some notes beats karke. So first day in hospital was in skin VD department. And VD specialist, Dr. Durandar, was our teacher, batch of 25, starting with T, U, V, W, X, Y, Zaveri. So we had full batch, 25, with skin first day in hospital. White coat, apron, stethoscope, we went. So Dr. Durandar, in the classic venereologist arrogance, he told us how, without looking at us, he told us how to take history of a patient suffering from venereal disease, and told us in English how to ask a history of exposure, this, that, tak, 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 tak. GS student, tabadtop notes. So he opened a roll call. Tendolkar Anil Gangadhar. So Tendolkar Anil Gangadhar got up. He said, take history. Pandu is the ward boy. Pandu, patient pathav. Send the patient. So patient came. So apna notes what to ask and constantly told, talk in patient's language. Don't laugh at patient's illness. Like them. I'm basically clever. On top of that, GS Medical College. So ऐसा एकदम well trained. So मैंने पूछा, the dialogue is in entire Marathi, but you will automatically understand. So I asked him, आपका नाम क्या है? So he said some typical Marathi name, Dagdu, Dondu, something. So I realized Marathi, and we were told, talk in patient's language. So I immediately changed to patient's language, Marathi, and I am Shuddha Marathi. By the way, our school was King George. That time it was Marathi medium. Now it is Raja Shivaji English medium. So I am absolutely very good in Marathi. So I asked him, where do you stay, age, all that pro forma. Now came that question, history of exposure, to ask in Marathi. But everybody started realize now what is going to happen. But you know, I'm basically clever. On top of that, GS Medical College. So I asked him, आपण बाहेर ख्यालीपणा करता का? Marathi has got 33% Persian words. बाहर का ख्याल जो करता है वो बाहर ख्याली. नम्रता जी समझ गई कि नहीं? So one who gives lot of consideration to outside things into inverted comma, is बाहर ख्याली. So I asked him, बाहर ख्यालीपणा करता का? So that illiterate person did not understand. So he said, because we were told not to laugh at patient, use decent language. So constantly taught to us. So मैंने पूछा, आपके बाहर संबंध? तो बोलता, काम के लिए बाहर जाना पड़ता है ना, बहुत संबंध बाहर ऐसा बहुत टाइम आता है. So again, he did not understand. By this time, Dr. Durandar, a seasoned venereologist, had lost patient. He asked him, भोसड़ी के रंडी के पास गया के नहीं? The question. So he said, हो गया था ना. So he said, अरे भड़वे बोलता क्यों नहीं डॉक्टर को? सो पेशेंट सेड, डॉक्टर ने अभी तक पूछा किधर? नम्रता, दैट वाज अ जोक. Are they ready? Ready? I'm filler. Another joke is about Kutch. We used to go to Kutch. आपके पास डायरी. So this, अरे तुम लोग लगाओ ना, ये निकालो ना सामान. तुम लोग सुनते क्यों बैठते हैं हमारा? तुम निकालो ना. मैडम आप हंस सकती हैं, allowed. Many people, see, in cardiac surgeons, people who laugh the least are pediatric cardiac surgeons. Because they are most intellectual. If they laugh, it becomes absolutely equivalent to coronary surgeons. ऐसा. So, pediatric cardiac surgeons, most intellectual, they have to constantly think how that septum comes down and how the septum rotates. You know. So they are. So this Kutch, we used to go for camp, and the only complication with Anil Tendulkar, that patient go home. They become cured and they go home. अरे ताली बजाओ ना, हंसो ना, क्या यार? So a baby, and I used to go there for 26 years. So girl whom I had operated at the age of say 1 year, 2 year, now had become 14-year-old. And by Kutch standard, घोड़ी. मतलब 14-year-old unmarried means घोड़ी. So had to be married. So her father came to me and asked me कि मुमताज बेगम का तबीयत कैसा है? तमिल कारण हिंदी इत्रुंद तिरियम की तिरिया दे. हाँ तिरियम तमिल कारण உங்களுக்கு கேக்குறேன். Hey, you are all impressed na? I can speak Tamil. That was the whole idea. तिरिंजाचा. Okay. So I said, अच्छी तबीयत है, शादी कर सकते क्या? I said, okay. So for me, because he arranged the marriage on our next camp day, next camp after 6 months. Marriage was arranged for that. I thought this bugger has forgotten. Second camp, he came with that any, you know, any olden days, any 116 something, white any stands in front of me at noon when the camp is over, and he takes me in the run of Kutch. Run of Kutch. And we go to a village, barren village, just 1 or 2 huts around. So we get down. I could realize that this looks like a marriage place because all the decorations. So he told me, "Aap udhar jao. Mumtaz Ben udhar hai." So as per the traditions in Kutch, the bride doesn't mix up with others. So like Mahmood, I opened the door and I found inside one red burqa lady and 11, 12 black burqa ladies sitting around her. So I realized this must be Mumtaz and the others must be the other family folks. So moment Mumtaz saw me, she unveiled her burqa. And moment Mumtaz unveiled her burqa, her mother, who used to come for follow-up, she also unveiled burqa. Because I was the doctor. Her father had told, हमने जान दी, आपने जिंदगी दी. So ऐसा. So, but one lady did not unveil her burqa. She was holding to her burqa. So Mumtaz's mother told her, Sanyasti Ben, burqa nikalo na. Sanyasti Ben now holding her burqa with 2 hands. Before that she was holding with 1 hand. Now she was holding burqa with 2 hands. So Mumtaz's mother told her, Sanyasti Ben, ये कोई मर्द नहीं है, डॉक्टर है. I told this to my wife. She said, "What is the joke?" I already knew it. Thank you very much. चलो हम बाहर जाएंगे.
Thank you very much, sir. I will agree, this was the best part of today. Let's give a big round of applause.
Sir will say, this is not CME.
May I request Dr. Sukumar Mehta to please present a memento on our behalf.
अभी क्या memento?
Big round of applause, please. Thank you, sir. Now we can follow Gaurav's instructions. बाहर चलते हैं. The dinner and the other program will start soon, so kindly be here. It's right here in this hall. Please come as soon as you can. Thank you.